Hello everyone and welcome to my channel Coach2Boards, and today we are going to start renal module from first aid, and obviously we will cover embryology, anatomy, physiopatho and pharma line by line, word by word from first aid book. So let us start our discussion on renal module, and the first thing that we have to discuss is the renal embryology, how kidneys are developed. Now in the development of the kidney, you have to remember three basic structures. Two of them actually degenerate after a while, but the third one then is persistent, and it is actually transformed into the adult type of renal system. So the first structure which comes in the developing embryo is known as the pronephros. The second one is known as mesonephros, and the third one, which is permanent, is known as metanephros. So pronephros appears and then it degenerates, and this all happens around week 4 of the development. So then is the mesonephros, which also comes around 3rd to 4th week of development, but then it persists there for at least the end of the first trimester, until the end of the first trimester, and it is for all this time it is actually working as an interim kidney. So it is kind of producing the urine, which is the amniotic fluid. So that mesonephros is very much functional, at least for the first trimester. And even after the first trimester, if it is a male baby, then this mesonephric duct in the system persists and it contributes to the male genital system development. And the third tubular system, which is actually the tissue which finally develops into the adult type renal tissue, and that is called metanephros. It is permanent. It first appears in week 5 of the development. Now you imagine that by this time pronephros has come and gone. Mesonephros is there and it's still working, and now this metanephros is developing. Week 5 it starts appearing, and then it actually persists there, and it leads to the process what we call as nephrogenesis, which is formation of nephrons in kidney, which is usually completed just before, slightly before birth, at around 36 weeks of gestation. Now if you look at this diagram, that nicely shows you. So in simplistic way, this is one single tube which develops. The caudal part, which would be down here, and the cephalic part, these are the two different parts of this developing duct, which has different tissues forming pronephros and mesonephros and metanephros. So the cranial region, the head region, this is where the tube starts forming pronephros, the first and the primitive tissue. But this pronephros then degenerate. You see here, so this is completely degenerated pronephros. And then there is the middle portion of this duct, which is called mesonephros. It works as an interim kidney. I'm telling you again and again, it keeps on producing the amniotic fluid for the first trimester. And then if it's a male baby, it persists, but then it develops into the genital duct. And then the very caudal portion is the one which is known as metanephros, and this metanephros actually develops into the real kidney system. And how it happens is there is initiation of formation of a structure which is known as ureteric bud. So ureteric bud basically comes off as a diverticulum from the metanephros. So this is the metanephric duct you can see here, and this is the ureteric bud, which is coming out as a diverticulum, as a pouch from the metanephros. And this outpockaging is fully canalized by week 10 of the development, and it induces the surrounding tissue, and the surrounding tissue is known as metanephric mesenchyme. So the way this is happening is, again, I told you this is a long tube. The first part of the tube, this first part, it degenerates. Then there is the middle part, which is the mesonephros. It persists only for the first trimester as far as the renal system is concerned, and afterwards, if it's a male body, if it's a male baby, only then it persists and develops into the genital ductular system. But this later portion, this caudal portion, which is what we call the metanephros, it gives rise to this structure, which is known as the ureteric bud. And the ureteric bud tries and induce the surrounding mesenchymal tissue, and this mesenchymal tissue is known as metanephric mesenchyme. Now it is very important to mention here that the interaction between the ureteric bud and the surrounding mesenchyme is extremely important for normal development of the kidney, because if this interaction does not happen, there will be pathologies such as cyst formation or renal agenesis. So the metanephric mesenchyme is basically interacts with the ureteric bud, and this interaction induces the differentiation and formation of glomerular structure and also some parts of the collecting in the tubular system until the DCT. We will talk about this in a minute. If there is abnormal interaction between the ureteric bud and the metanephric mesenchyme, this will lead to congenital anomalies. So for example, renal agenesis or multicystic dysplastic kidney. So there will be cyst formation. So again and again, I'm emphasizing that the interaction between the two tissues, the first one is the ureteric bud and the other one is the mesenchyme surrounding the ureteric bud. This interaction is very important. Okay. Uretero-pelvic junction, which is the last part of the ureter to canalize. It doesn't fully canalize. I'll come back to this in a minute. What does that basically mean? Because we are talking about two different tissue. Now imagine, here's an important concept to grasp right now. So if this is the metanephric duct and there is the ureteric bud which has canalized into a tubular system, surrounding here would be the mesenchyme, and the mesenchyme is going to develop into the kidney. So imagine this now. Here we have a complete kidney formation which is then connected to the collecting system, and the collecting system is coming from the ureteric bud, and the kidney tissue is basically coming from the mesenchyme. So this is the junction where they're talking about uretero-pelvic junction. So here's the pelvis and here is the ureter coming out of it. So this uretero-pelvic junction, once it canalizes, it forms the channel from where the urine will be coming from the papilla, and it will drain into the calyces, and from the calyces into the pelvis into the ureter. If this canalization at the junction does not happen appropriately, there will be problem. There will be obstruction of the urine outflow. So that's what they're talking about here. So uretero-pelvic junction is the last part of the ureter to canalize, and if it doesn't fully canalize, there will be congenital obstruction of one side of the kidney. It can actually be unilateral or bilateral. More commonly it is unilateral, and most common pathologic cause of prenatal hydronephrosis. So if you see a prenatal scan and there is enlarged kidney hydronephrosis, always think about obstruction at the level of the junction of ureter and pelvis. Maybe this portion has not canalized. So the kidney is there, the ureter is there, but there is a block here. So somebody need to remove this cap kind of thing. Okay, so that's very important discussion, and we then move on to another important discussion, which is the Porter sequence. Now Porter sequence is basically it's a range of different presentations which are all associated with one single thing, and that one single thing is reduced urine production in utero. Now if there is reduced urine production, that basically means that the kidneys are not working appropriately. So if kidneys are not working appropriately, they are not producing urine. And you must appreciate the fact that baby requires urine. This is very important, because this little teeny weeny baby is floating in amniotic fluid. What is the amniotic fluid? Amniotic fluid is the urine secreted by the baby. So if the baby is not producing urine because kidneys are not functioning properly, now there can be so many reasons of the kidney if they are not working appropriately. There could be so many clinical, we will talk about them. There can be renal agenesis, there can be cyst in the kidney, or there can be obstruction at the junction. So for any reason, if the kidneys are not producing appropriate amount of urine, there will be less amount of amniotic fluid. So the baby is not bathed appropriately in the amniotic fluid. Now if the quantity of the amniotic fluid is less, what will happen? That the baby will be compressed against the wall structures of mother. So there is no cushion effect, there is no liquid to protect the baby, and as a result what will happen? As a result there will be flat facies and twisted face and twisted skin, and there will be peripheral, extremity, upper and lower limb defects, because imagine the whole baby being pushed against a surface and there is no intervening amniotic fluid, so there is no cushion effect. Okay, and now all these words should be very clear to you. You should know why there is a facial deformity, why there are deformities in the extremities. Why is this all happening? This is all happening because of renal failure, because kidneys are not working fine, so there is no amniotic, there is no urine formation. As a result, there is no amniotic fluid or reduced amniotic fluid. Okay, now if there is reduced quantity of amniotic fluid, this is what we call oligohydramnios, and that's the trigger. So kidneys are not working, low urine and low amniotic fluid. Also, these babies have pulmonary hyperplasia because it simply means that their lung tissues are not developed appropriately. Why? Because we know from the embryology series of lectures that in part, lung expansion and development depends upon intake of the amniotic fluid, because intake of the amniotic fluid is related to the expansion of lung, and this expansion is one of the stimuli for development of the normal lung tissue. So if there is less amniotic fluid, there is less intake of amniotic fluid, there is less expansion, there is less stimulus for the lung, and therefore pulmonary hypoplasia. So basically, the Potter sequence is composed of all these presentations, and they have nicely, in order for you to remember this appropriately, in the first aid they have written as P for pulmonary hypoplasia, O for oligohydramnios, TT for twisted face and twisted skin, E for extremity defect, and R for renal failure. I love first aid for these very nice mnemonics. Although I'm not a mnemonic guy, it's difficult sometimes to remember the mnemonics, but this one is good. Let's read what they have written here. So oligohydramnios is the initiating factor for any reason. Kidney is not working and there is low amount of amniotic fluid. It leads to compression of the developing fetus, and therefore there are limb deformities and facial abnormalities, flat face, flat nose, low set ears, and pulmonary hypoplasia. We talked about this, and this is caused by chronic placental inefficiency or reduced fetal urine output. So any condition which is going to reduce the fetal output will lead to Potter sequence. And as I told you, there can be so many different things which can lead to reduced amniotic fluid. So for example, embryologically there is renal agenesis, particularly bilateral renal agenesis. So for any reason, if kidneys don't develop on both the sides, right and left, it will be renal agenesis bilateral, and if there are no kidneys, there will be no urine, which means there will be no amniotic fluid. If there are posterior urethral valves, for example, as a result of this there will be obstruction of the urine outflow, and then there will be back pressure towards the kidney, and these kidneys will be damaged because the urine is not getting out from the bladder because there are posterior urethral valves obstructing the outflow. Kidneys will be damaged. If kidneys are damaged, there are chances that the baby will have low quantity of amniotic fluid. If there is autosomal recessive polycystic kidney disease, that is also something where the baby can have a cyst in both kidneys. That's the juvenile form of polycystic kidney disease, and both kidneys are not working, or they are working less than the normal is expected. As a result, there will be low amount of urine and there will be low amniotic fluid. So all should make sense to you. You see, I'm spending a lot of time reading each and every word because this is the way to read the first aid. Okay, let's now talk about some embryological conditions which are very common to be tested in examination. So if you look at this diagram, that's a CAT scan where these are the kidneys, and these kidneys are kind of conjoined to each other, and this is what happens in horseshoe-shaped kidney. The lower pole is usually like this. They are amalgamated into each other, so they are combined, they are fused. And one important consideration is the anatomy tie in here, because when the kidneys usually ascend in the abdomen embryologically, if they are two separate kidneys, they are two distinct kidneys, they can go up easily. But if they are tight at the bottom, they are caught up by inferior mesenteric artery. So this is something that you should also remember. Okay, so the inferior poles of both the kidneys fuse abnormally. They fuse with each other. As they ascend from the pelvis during fetal development, the horseshoe kidney get trapped in the inferior mesenteric artery. These kidneys can function normally, but associated with hydronephrosis, because they can lead to any anatomical variation from normal can lead to problems such as obstruction and hydronephrosis, stone formation, increased risk of infection, as well as renal cancer. Higher incidence in a few chromosomal abnormalities such as trisomy 13, 18, 21. So if they are explaining to you a case of Down syndrome, for example, or Turner syndrome, you should consider that there may be pointers towards horseshoe-shaped kidney. Okay. Now this is another scenario where we will talk about congenital solitary function kidney, and the baby is born with only one functioning kidney. So the condition where the baby is born with only one functioning kidney, and most of them are asymptomatic, and the kidney which is there actually has to perform the job of two kidneys. So therefore the contralateral kidney hypertrophy, and later in the life there can be problems. So but early in the life they may be fine. Okay, and they're usually diagnosed if we talk about prenatal diagnosis, diagnosed during the ultrasounds. Okay, and if both kidneys are missing, it will definitely lead to Potter sequence, because if both kidneys are not there, there is no urine formation, and which means typically that there is no amniotic fluid, and this is then incompatible with life. So these babies will obviously not survive in utero. Okay, now what are the conditions where we have only one functioning kidney? It can be because of unilateral renal agenesis. So on one side of the kidney, it just doesn't form. Okay, either right or left. So ureteric bud fails to develop and induce differentiation, and therefore there is complete absence of kidney and ureter. And if this interaction between the ureteric bud and the surrounding mesenchyme does not happen, then this kidney system will not develop. And this is usually what happens. If there is no interaction, there is unilateral agenesis. Another condition is a multicystic dysplastic kidney. Now that's very important for you to remember, that when we talk about cystic diseases of kidney, usually students think about polycystic kidney disease, but here we are talking about multicystic dysplastic kidney disease, which is actually non-hereditary condition. So here the ureteric bud actually develops, but it fails to induce differentiation of the metanephric mesenchyme. So the bud is there, but the surrounding mesenchyme is not induced. And as a result of this, the kidney tissue, which develops somehow, but it develops with a lot of cysts. This is what happens. It is usually unilateral, and it is different from the inherited version of the cystic disease, which is the polycystic kidney disease. Then embryologically, there may be babies born with duplex collecting system. So inside the kidney, usually we have like one ureter coming out, but if there are two ureters coming out, this is called duplex collecting system. So bifurcation of the ureteric bud at the very early stage leads to formation of a Y-shaped or duplex ureter. Duplex collecting system can alternatively occur through two ureteric buds. So there can be either two separate ureteric buds making two ureter, or there can be one ureteric bud making bifurcation, and both of these conditions are actually under the heading of duplex collecting system. And the important point for examination purposes is that these collecting systems, they have increased risk of UTI and urethral obstruction. Now I will tell you, there is a common that's one of the common things that you have to generally understand. Whenever there is any change in anatomy because of any embryological aberration, that can lead to variation from the normal function. So if in the kidney system we are talking about any variation from normal anatomy, it almost always means, at least for examination purposes, increased reflux, for example, increased risk of UTI, increased risk of obstruction, increased risk of stone formation, variation from normal anatomy. All these can happen. Okay, so that's a general principle. Then there is a condition which is called posterior urethral valves. Now membrane remnant in the posterior urethra in male, its persistence can lead to urethral obstruction. So this is the bladder, and the urine has to come out through the bladder via urethra. If there is an anatomical variation here, an additional tissue present here in the form of a valve, this will obstruct the outflow, which will mean that there will be backflow in the ureter and then also in the kidney, and kidneys can be damaged, and this can also lead to oligohydramnios. Basic concept. So if you understand the basic mechanisms of embryology, many of the embryological scenarios are very easy to understand, right? Let us now discuss, before anatomy we have this vesicoureteral reflex. Now, reflex basically means that there is bladder, and from the bladder, the outflow is via urethra, while we have ureters coming into the bladder bringing urine from the kidney. So if there is any retrograde flow of urine from the bladder towards the kidney, this is what we call vesicoureteral reflex. It's the retrograde flow of urine from the bladder towards the upper urinary tract. It can be primarily due to abnormal insufficient insertion of the ureters, so there is any abnormality in the anatomic insertion of ureters, or it can be because of any obstruction at this level, so that there is increased pressure and backflow. Okay, again, increased risk of UTI. I told you, whenever, as a general rule in renal module, if there is any deviation in anatomy, then it will lead to increased risk of UTIs, increased risk of stone formation, increased risk of even cancer formation. Okay, let us now talk about the renal gross anatomy, particularly with context of renal blood flow. So if you look at the kidney, we have like the outermost region, which is called the cortex, then these pyramids, which is what we call the medulla, and then we have the pelvis here. And the way it works is in each region, so for example in cortex we have glomerulus, which is filtering the blood, and then there are loop of Henle and other tubular system in the pyramids. And once these little drops are formed, and these little drops are the drops of urine basically, so this urine which is formed here, it is collected into this small channel which is known as minor calyx, and minor calyx is drained into major calyx, then into the pelvis, and the pelvis drains into the ureter, and ureter takes it to the urinary bladder. So that's a very simple stuff to understand. Then you also need to know that there is blood coming towards the kidney by renal artery, and the blood leaves the kidney by renal vein. That's routine, usual for anything that you would study in any arterial system. But there is something special as far as the kidney blood supply is concerned, and we'll talk about them. So if you look at this diagram, for example, here we have an arteriole, which is known as afferent arteriole. It is actually bringing blood towards the glomerulus. So the arteriole comes in here, divides into a lot of capillaries which are called the glomerular capillaries, and then the blood goes away in another arteriole which is known as efferent arteriole. Now that's interesting because in many tissues there is an artery gives rise to arteriole, from the arteriole capillaries arrive, and then there is a veniole and vein. But if we talk about the kidney system, artery is bringing in the blood and artery is taking out the blood. Arteriole, I mean, but that's both arteriolar system. There is no vein here which is taking blood out. So that's interesting, and it is for a purpose, and we'll talk about the purpose later on. So the artery which is bringing in the blood then divides into a lot of branches. The first set of branches it is converted into are known as segmental artery, then further smaller branches called interlobar arteries, then arcuate arteries, which are at the top of the pyramids, and then the smallest one, interlobular, and the interlobular arteries basically then give rise to the glomerular capillaries, and from the glomerular capillaries there is another set of arteriole coming out called the efferent arteriole. So interlobular artery is feeding blood into the afferent arteriole. Very important diagram for you to understand. Okay, so the blood flows in this direction. Now there are some important considerations. The left renal vein receives two additional veins, the left suprarenal, left gonadal. They're very important. So if I draw a diagram of two kidneys, and let's say the person is standing in a way that the back is towards you. So in this case, this will be the right kidney and this will be the left kidney. Okay. Now if we talk about the left renal vein, which drains the left kidney, this receives left suprarenal as well as left gonadal vein. This is very important because if there is any blood flow obstruction in the left renal vein, your testicles will be enlarged because the gonads are draining there. So that's an important consideration. Okay. Similarly, renal medulla receives significantly less blood flow than the renal cortex, and this means that if there is any ischemia, if there is any hypoxia, then the renal medulla are more sensitive to acute tubular necrosis. Another point to remember is left kidney is taken during the live donor transplant because it has longer renal vein. So basically it is easily manipulable during the surgery. Okay. And this diagram, we will come back to this diagram when we talk about nephron physiology, because all begins here. They are very important glomerular anatomical diagram which tells you a lot of things. So for example, it tells you the blood supply. So the blood is coming by afferent arteriole, and afferent arteriole will be getting blood from interlobular artery, and the interlobular will be getting blood from arcuate artery, and the arcuate will be getting blood from interlobar artery. You need to know this. So this is afferent arteriole, which feeds blood into glomerulus, which is a tuft of capillaries. Okay, and here they are surrounded by specialized cells which are called porocytes, which sit on a basement membrane, and then there is capillary endothelium. So these three structures together make the glomerular filtration barrier. So very, 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 very important diagram, but as I told you, we'll come back to this. Okay, and there is also a very important structure called the JG cells, and part of the distal convoluted tubule having a specialized epithelium known as macula densa. I'm not going into the details right now. We will discuss this when we are talking about nephron physiology in the next section. So up till now, we have covered the basic gross anatomy, particularly giving focus to the blood supply, okay, and the embryology. So let's now start discussing a few bits about the course of ureters. That's also an important anatomical consideration. Now, when we talk about the ureters which are passing from the kidneys to the bladder, they actually arise from the renal pelvis, this bit, the pelvis area, and they travel under the gonadal arteries. It's a very important surgical point of view. So over common iliac artery and uterine arteries, if depending upon we're talking about male or female, what structure, okay? Gynecological procedures such as ligation of the uterine or ovarian vessels may sometime break, obstruct, damage the ureters. Therefore, this anatomical consideration is very, very important, okay? Now, bladder contraction compresses the intramural ureter, preventing the urine reflux, and so we have talked about it, okay? And this is important anatomically. There are three common points of ureteral obstruction. One is at the uretero-pelvic junction, one is at the pelvic inlet, and one is at the uretero-vesical junction. So these 3 points are where the ureters are slightly narrower than the usual diameter. And why they're important? Because these are the points where a stone can be impacted. So a stone, if passing through ureter, obviously if there comes a point of constriction, this is where the stone will be impacted and it will cause pain. That's why they become important, okay? Now, I told you that there is a very intimate relationship of the ureter with arterial system. So here is an easy way to understand this. Water, which means urine, which means ureters, flow over the iliacs and under the bridge. So bridge means the uterine artery or the vas deferens, if you want to remember it this way. But anyways, there is no easy way to remember things. You have to remember them, okay? So here is the diagram, which is to show you the bladder, and then this is the median umbilical ligament, which is a remnant structure. It's obliterated after birth. Ureters are coming under the vas deferens and the uterine artery in female. If it's a male, we are talking about vas deferens, okay? Very important diagram to understand, because if you want to ligate this, you don't have to ligate the ureter itself. Right? Let's now talk about a very detailed section, and I would say a very important section, because without understanding renal physiology, you are not going to understand renal pathology and pharma. Okay, so let's begin renal physiology. The first thing to understand is obviously the fluid compartmentalization within the body, and that's very easy stuff. I mean, you have done this so many times in your physiology lectures. You know, our fluid compartmentalization is all depicted here in this particular diagram. So 55 to 60% total body of water, and 40 to 45% of the total body mass is basically non-water. So if you have to divide the body mass, if somebody, say for example 70 kg, so 55 to 60% of that total mass would be composed of water fluid, and 40 to 45% would be non-water. So non-water is primarily because of the red blood cells, which is the hematocrit of the person. And if you talk about the 55 to 60% of the total body water, so that water either resides inside the cell, which is about 2/3 of the total number, and 1/3 of that water is in the extracellular fluid outside the cells. And outside the cells can be literally outside the cells, which means the interstitial fluid, which is about 75% of this number. And the outside the cells can also be in the blood vessel, which is what we call the plasma. So 25% of the total extracellular fluid is in the blood vessels, in the plasma. So this is a very self-explanatory diagram, and it should be very clear to you, but that's a very important one to understand, okay? Now, here are some routine facts which are written, which you have to remember, that we have sodium ion concentration on the outside and potassium on the inside. So that's the high concentration. That basically means that more sodium is present outside the cells and more potassium is present inside the cells. Also, it helps if you remember 60-40-20 rule, that is percentage of body weight for average person. So 60% of the body weight is usually total body water. So if you talk about the water component, the percentage wise of the total body mass, it's about 55 to 60. So 60 and 40 means the intracellular fluid, which is mainly composed of potassium and magnesium, also contains organic phosphates. So intracellular fluid, 40% of the total mass of the person. So if we are talking about 70 kilogram heavy person, either male or female, 40% of this would be intracellular fluid and 20% would be extracellular fluid. And when we talk about extracellular fluid, it is largely composed of sodium, chloride, bicarbs, and albumin. This is very important composition. So these are some facts which you must remember by heart, I would say, if you are doing the renal physiology. Okay. Now remember that plasma volume can be measured, so we can easily measure different components and different compartments of the body, the volume of different compartments. And this is something which is not really a tough thing, because we say, for example, if this is a vessel or a container and this is the amount of solute, and you need to know that what is the volume of this compartment of this vessel. So all you have to do is dissolve a solute in the vessel, and then at the end of the day what you do is, now this vessel or the container will contain the solute. So what you can easily do is measure the concentration of the solute here. So this will be something X amount milligram per liter, for example. So if you know the final concentration, if you know the amount of solute that you actually entered into the container, then you can simply back calculate the volume of the container, and this is very easy stuff to do. So we can do this for plasma, for example, using albumin, because this albumin stays in the blood vessel compartment. So if you know how much albumin you are adding and you know the final plasma concentration of albumin, then you can back calculate the volume of the plasma compartment. Okay. Similarly, we can also calculate the volume of the whole extracellular fluid compartment by using inulin or mannitol. So it stays within the extracellular compartment, does not get inside the cells. And if you know how much inulin or mannitol you have actually given, and you know the final plasma concentration, then you can back calculate the volume of extracellular compartment. Okay, so this is not something which is very difficult. You can easily calculate volumes of different compartments of your body. And you should also know that what is the normal serum osmolarity. It's roughly around 300 osmol is something that we usually take the number for easy calculations, but in reality it's about 275 to 295 milliosmoles per kilogram of water. And this particular equation, which is talking about the total body volume into 1 minus hematocrit. We will come back to this equation later on, because later in this video we have some calculations about plasma volume and the total blood volume. Now, this particular heading talks about the barrier which is present at the level of the glomerulus, and this is called the glomerular filtration barrier. So this barrier is basically responsible for filtration of the plasma according to the size and charge selectivity, and we have talked about this barrier earlier on in this video as well. So imagine this is the glomerulus, and in the glomerulus we have the blood vessels going like that. Okay, this is part of the this is the Bowman capsule, and this is the glomerular capillary, and this Bowman capsule is obviously going to get into the proximal convoluted tubule. So if you think about this area where the glomerular capillaries are in very close and intimate contact with the Bowman capsule, so what are the different layers of filtration barrier? So we have fenestrated capillary endothelium. Obviously this capillary will be lined by endothelial cells, and these are fenestrated, so these have holes. There are endothelial pores in there. Okay, and then will come after the endothelium, there will be a basement membrane, which is obviously made up of type 4 collagen, and after the basement membrane what will come is the visceral epithelial layer of the Bowman capsule, and this will become comprising of the food processes, or what we call the podocytes. Okay, so all these layers you should be very clear about. So this is an electron microscopic depiction of what we are talking about. So this is the blood side, for example. So this will be the blood vessel, and the blood vessel have endothelial lining, which has, you see, there are small little openings in there, and after which there is a glomerular basement membrane, after which there are podocytes. So all this together is known as glomerular filtration barrier. So whatever is present in the blood has to go through this barrier in order to come into the Bowman space. Okay, so these barriers must be remembered because they are very commonly asked in examination, and they are also affected in different pathologies. So when we will deal about pathology section in the first aid, we will talk about, say for example, effacement of food processes. So at that time you should know what do we actually mean by food processes. Now, charge barrier wise, you should know that glomerular filtration barrier contains negatively charged glycoproteins. So these membranes contain negatively charged glycoproteins, and therefore they inhibit or they repel, they prevent the entry of negative charged particles into the filtrate, and an example being albumin. So albumin, being a protein, is also negatively charged, so it is not usually filtered at the level of glomerulus. Then there is another barrier which is called the size barrier. Now, I told you that we have fenestrated capillary endothelium, and these holes are designed in a way that it does not allow the entry or filtration of any particle which has size of more than 100 nanometers. So anything which is bigger than that size is not filtered here. Okay, then there are podocytes or food processes. They also have filtration slits, and so they are arranged like this, for example. So they have slits here. These are called filtration diaphragm or slit diaphragm. So they have a size barrier as well. So their size filtration barrier is about 40 to 50 nanometers. So things bigger than 100 nanometer do not cross the blood barrier, which is the glomerular membrane, and things which are more than 40-50 do not cross the podocyte barrier. So remember, all this is very important information. First thing you should appreciate is that we have a filtration barrier which is composed of, if you are talking from the side of the blood vessel, so we have endothelial lining, then basement membrane, then food processes. And if you're talking from the Bowman capsule side, it's the food processes, then the basement membrane, then the endothelium. Endothelial pores, 100 nanometer size barrier. Filtration slits of the podocytes, about 40 to 50 nanometer. That 100 is also nanometer, by the way, not millimeter if I said it wrong. Okay, so once this is all clear, then let's dive into some basic concepts. Actually, there are some indicators of kidney function. So for example, GFR is one of them. GFR is something which tells you how the kidneys are working. If GFR is good, then your kidneys are working good. If GFR goes down, it generally means that your kidneys are not working well, kidneys are sick. So this is one indicator of assessing kidney function. Similarly, renal blood flow, autoregulation, we'll talk about this in a minute, and what is effective. So let's start discussing some indices which are routinely calculated in order to estimate how kidneys are working. Okay, so the first concept is the concept of the renal clearance. Now, technically, you can, for the examination purposes, you can remember the formula that clearance is equal to urinary concentration of any substance multiplied the volume flow of urine divided by the plasma concentration of the same substance. Now, the concept basically is something like this. So, for example, I have, this is my compartment, and this compartment, when I say my compartment, so let's say this is blood, and this blood contains, say for example, 10 milligrams of anything, of something X, okay? And here is my kidney. This is my Bowman capsule, and this is my nephron. And this nephron, at the level of the nephron, complete 10 milligrams is filtered and excreted into the urine. And I tell you that the compartment size is about 1 liter. So what I'm actually telling you, that from 1 liter of my blood, 10 milligram of substance X is being filtered, is getting out. Or the other way of putting this would be that 1 liter of the blood is being cleared of 10 milligram of substance X. Or another way of putting this would be that this 1 liter of blood actually initially contained 10 milligram because I'm getting rid of 10 milligram solute X from that 1 liter. So the amount of blood which is cleared off by any solute is basically known as the clearance. And the way to calculate this is you should know the urinary concentration of the substance, so how much of this substance is coming in the urine, then the plasma concentration of that substance, what was initially present in plasma, and then what is the volume of the urine, volume flow. So the way to calculate volume flow is that you ask the patient to collect urinary volume over 24-hour period time, and then you can actually calculate how much urine flow actually this patient is having. Okay, it's a very cumbersome process. Obviously it's not easy to do this, but that's what you should at least know for the purpose of formula. So that's what is clearance, and we define this clearance concept by these words: volume of plasma from which the substance is completely cleared in the urine. So volume of the plasma from which this substance is completely filtered or cleared. So that volume is basically termed as, and that should be per unit time, is termed as clearance. Okay. So you should know all these symbols. That clearance is usually represented by C, easy to remember, substance X. So if it's clearance of sodium, you use C and A. If it's clearance of anything else, inulin for example, you use I and U and I. So clearance C is representing clearance, and it is represented in units milliliters per minute, because I told you it's the volume of the plasma which is cleared off a particular solute per unit time. So this is for volume, ml, and this is for per unit time. So mLs per minute is the unit for clearance. U sub X is basically the urinary concentration of solute X. P sub X is the plasma concentration of solute X, and V is the urine flow rate. Okay, now these three concepts are very important, and they make perfect sense, so it should be easy to understand them. So if the clearance of any substance is equal to the GFR, so GFR is basically the filtration. So if the clearance is equal to the filtration, that means that the substance is neither secreted by the nephron nor it is absorbed. So the way to understand this would be, in this example, for example, I told you there is 10 milligrams of substance X, and all of this is out in the urine. So basically 1 liter, or the amount of the plasma, is completely cleared of the solute. So it is completely cleared, which means that the clearance is equal to the GFR, and this is the amount which is actually filtered into the nephron as well. So if the amount cleared is equal to the GFR, the substance is not being secreted by the nephron, and it is not being absorbed by the nephron, because think about it this way. Now this is a very important concept to grab, and please grab this at this stage, because otherwise later on there may be difficulties for you to understand this concept. So if there was initially 10 milligrams of substance X which was filtered here, now imagine 2 milligram was reabsorbed. So in the urine you will actually be excreting 8 milligrams. So this simply means that the volume is not cleared completely of a substance. 2 milligram is going back into this volume, so this is going back into the blood, this is going back into the plasma, and the actual excretion is only 8. So if the GFR is less than the clearance, so this particular scenario, if the clearance is less than GFR, there is reabsorption. So clearance is less than GFR, it is clearly being reabsorbed. However, if this is more than the GFR, it would simply mean, say for example, if this is 10 milligram initially here, and in the urine you are excreting 12 milligrams, so it simply means the 2 milligrams are coming into the nephron, it's being secreted. So if the clearance is simply equal to GFR, that's very easy to understand. There is no net secretion, no reabsorption. But if the numbers are changed, if clearance for example is less than GFR, there is reabsorption. Where is it going? Going back into the blood. If the clearance is more than the GFR, it is secretion. Where is it coming from? It's coming from the blood. Okay, so after this, the GFR. GFR, I told you, is the basic, a very basic functioning indicator of the kidney function. So if GFR is okay, kidneys are fine. If GFR is not okay, kidneys are screwed. Okay, and inulin is usually in textbooks at least, used to calculate inulin clearance to measure the kidney function or the GFR. But in practical, in daily laboratory or daily clinical practice, we actually don't use insulin. I'll tell you what do we use routinely, but theoretically you should know that inulin clearance can be used to calculate the GFR because it is freely filtered and is neither reabsorbed nor secreted. So if this is your nephron, for example, and this is your glomerulus, so if you inject the person with inulin, whatever is coming out should come out in the urine. So it's neither been secreted nor been reabsorbed. So it's a very good molecule to study the kidney function. If the GFR is fine, or the kidney function is fine, in other words, then inulin injected should be coming out. So clearance of inulin should actually be equal to the GFR if everything is well. And how do you calculate the clearance? You know that the formula to calculate clearance is urinary concentration of inulin multiplied by the volume flow divided by the plasma concentration of inulin. So that basically, under normal circumstances, tells you very nicely the GFR of the kidney. So if you have to calculate GFR, perfect thing would be calculate inulin clearance. Okay. Now this is further dive down of different parameters, which we actually will be talking about these later on. So stay tuned with me and we'll come back to these equations. So whenever I'm saying we'll come back to these equations, we'll hit the concept once they are appropriate. Okay. Now that's the value of the normal GFR, 100 milliliters per minute, and I told you that we, in the textbook at least, use inulin clearance for measuring GFR, but under routine circumstances in the laboratory, in bedside when we are dealing with patients, is the creatinine clearance that we use to, investigate how kidneys are working. So creatinine, inulin basically is not a naturally occurring substance. Creatinine is the closest mimicking substance to inulin. So if you although some amount of creatinine is secreted by the nephron, so if you imagine it this way, creatinine is filtered at the level of the Bowman capsule, but some amount is also secreted. So whatever you calculate as a GFR is a slight overestimation. So they will be slightly overestimated because it is secreted by the proximal renal tubule, but still it's a very good estimate of kidney function. So if creatinine levels go up, that's basically indicating poor kidneys. That's how it is depicted. Okay. Now after this, what I would like to discuss and what is mentioned in the first aid is the renal blood flow autoregulation. Now remember, the word autoregulation basically means that if there are certain changes in your blood pressure or there are certain changes in the flow dynamics in your circulatory system, kidney has the capacity to control those fluctuations. So if this is kidney and there are millions of nephrons inside, if for example I'm angry on something and my blood pressure shoots up, so what would happen if it was not regulated? The blood supply to the kidney would have increased and then there could be damage to the nephron. And similarly, if I have low blood pressure episode during the day, the blood supply of the kidney would have been reduced. So in order to prevent those daily variations of the blood pressure, kidneys have developed autoregulatory mechanisms. So these mechanisms help to maintain a constant renal blood flow and therefore constant GFR. Otherwise we cannot afford this to, if there are changes and fluctuations in the blood pressure and then there are changes and fluctuations in renal blood flow and GFR, we just can't afford it. We need constant GFR, we need constant renal blood flow. So therefore kidneys have these two mechanisms. First one is called myogenic mechanism. So for example, if any blood supply coming to the kidney has high blood pressure, so the increase in the arterial pressure would lead to stretch of the afferent arteriole, and that stretch will then induce vasoconstriction of the afferent artery. So that's a reflex mechanism, because the afferent arterioles are supplied with the smooth muscles like any other arterioles, and any stretch would lead to contraction of those muscles and thus vasoconstriction, and as a result the renal blood flow will slightly decrease. So initiating insults was the increased arterial pressure, as a result of which now there is reduced blood flow. So that's the reflex mechanism. That's called myogenic, because in this particular loop muscles are contracting. Then there is another mechanism which is called tubular glomerular. So what happens is, If for any reason there is increased blood flow, say for example during high blood pressure, if there is increased blood flow, there will be increased sodium chloride filtered, and that increased sodium chloride which is filtered at higher rate will reach to the macula densa, which can sense sodium chloride, and this will then in a paracrine fashion cause vasoconstriction of the afferent arteriole, that hey afferent arteriole, you need to shut down because I'm getting more sodium, which means I'm getting more and more blood supply, so please shut off and vasoconstrict so that the blood flow reduces. So both these mechanisms, the myogenic mechanism and glomerular mechanism, they have the tendency and they have the potential to counteract the initiating insult. The initiating insult was, for example, high blood pressure, so the muscles stretch and increased sodium chloride leads to vasoconstriction of afferent arterioles. Both of these actions lead to decreased renal blood flow, so that the initial insult of increased blood flow is counteracted. Okay. Now the concept of effective renal plasma flow must be understood very, very clearly. It is actually different from the total blood flow. Now imagine this is the kidney, and in the kidney here is the renal artery, and the afferent arteriole will obviously come from this renal artery. Now there is an X amount of blood which is coming towards the blood. That is what we call the renal blood flow, but that is not equal to the renal plasma flow or the effective renal plasma flow for two reasons. Number one, plasma is obviously a number less than the total blood flow, because you know the blood is composed of what? It is composed of plasma plus cells. So if I ask you what is the total plasma flow, it will be a different number than the total blood flow. And the way to represent this would be that the renal blood flow is actually equal to the plasma flow divided by the number of cells, which is represented by 1 minus hematocrit value. Okay, so that's how you calculate the total blood flow towards the kidney, which is usually about 20-25% of the total cardiac output. And when we talk about the effective renal plasma flow, it can be estimated using para-aminohippuric acid clearance. This is very important concept to understand, guys. If you have to estimate GFR for the kidneys, you use inulin clearance, or as I told you, in reality you use creatinine clearance. But if you have to calculate how much effective plasma flow is towards the kidney, it's the para-aminohippuric acid clearance that you have to measure. Now between filtration and secretion, there is nearly complete excretion of para-aminohippuric acid, which would mean that whatever para-aminohippuric acid is coming to the nephron, it is getting out in the urine. So 100% of this is getting out in the urine, which means that complete plasma which is coming to the kidney will be cleared out of para-aminohippuric acid. Therefore, it's a very good indicator of how much plasma is coming in here. We can only calculate this by calculating the clearance of a substance which is, out of that plasma 100%. So if it is coming out 100%, it's filtered and then it is secreted as well. None of this is reabsorbed. So I can easily say that whatever amount of plasma is coming here is 100% clear. So now if I know the urinary concentration of para-aminohippuric acid and the plasma concentration of para-aminohippuric acid, and I know the volume flow, then I can easily tell you what is the effective renal plasma flow. So para-aminohippuric acid is its clearance is equal to calculating effective renal plasma flow. Very, very important concept. They check this concept that you should know. If you have to calculate GFR, it's the inulin clearance, or in reality it is the creatinine clearance. But if you want to check the renal effective renal blood flow, then you are talking about para-aminohippuric acid clearance. Okay. Now let's talk about the filtration dynamics. So this is a very easy concept to understand, but it is an important concept. Okay, so look at the diagram here and try to orient yourself with the structure. So we have the Bowman space here. So this is Bowman capsule. Here is the afferent arteriole. This is bringing in blood. Here is the efferent arteriole that's taking blood away from the glomerulus, and these are glomerular capillaries. And the filtration happens here. Now, if you recall from my previous discussion, this is the blood side. So these are the endothelial cells. Then we have the basement membrane. Then we have have the podocytes. So this is effectively known as the glomerular filtration barrier, and you know that between the endothelial cells there are filtration pores, and there are also slit diaphragms at the level of the podocyte. So you know all these structural details already. Now we have to discuss how does the filtration happens. Obviously we are talking about that many of the solutes here in the blood, they filter out into the Bowman space, and the filtered volume then moves forward in the nephron. Now what are the forces which control the process of filtration? There are only two forces. The first force is basically the hydrostatic pressure, and the second force is known as the oncotic osmotic pressure, right? So let's talk about these forces. So the pressure within the glomerular capillaries is known as the hydrostatic pressure of the glomerular capillary. So it is represented by P subscript GC. So GC is the glomerular capillary, P is the hydrostatic pressure. So this pressure will obviously favor the process of filtration, right? Because this is the pressure within the capillary. So these capillary pressure would try to get everything out of the glomerular capillaries into the Bowman space and into the nephron. Then there is another pressure which is known as the oncotic pressure of the Bowman space. So there will be some amount of protein here, and those protein or some well, actually there should not normally be any filtered protein here, but because of the solutes we have some osmotic pressure here. So that osmotic pressure or oncotic pressure is trying to drive filtration towards the Bowman space, and this is known as the osmotic pressure of the Bowman space. So these two forces are actually favoring the process of filtration, but any pressure within the Bowman space, which is called the Bowman space hydrostatic pressure, oppose the filtration process. So if there is any increase in pressure here, so say for example if I block the nephron here, if I block it at this level, what will happen? There will be increase in the pressure in this area, and this will oppose the process of filtration. It will reduce the GFR, it will reduce the filtration process. Or for any reason, if in the capillary I have a very high osmotic pressure, say for example I have very high amounts of protein, so those proteins will try to keep water and all the filtrate within the blood vessel, and they will oppose. So there are two forces, hydrostatic pressure and oncotic osmotic pressure. Hydrostatic pressure of the capillary will favor filtration. Hydrostatic pressure of Bowman space will oppose filtration. Osmotic pressure high in the Bowman space will drive filtration towards the nephron. High osmotic oncotic pressure within the blood, within the capillary bed, within the glomerulus, will actually drive filtration towards this direction. So these two forces stopping the process of filtration, and these two forces promoting the process of filtration. Okay, so therefore the net filtration pressure would be, listen to this carefully, hydrostatic pressure of the capillary, which favor filtration, or osmotic oncotic pressure within the glomerulus, this favors. So if you add both these forces and subtract the opposing forces, this is what is the net filtration pressure within the glomerulus. Okay, so you should understand this concept of filtration by heart, right? Then this is an important table as well, but before doing this table, let me tell you that kidney is a very unique structure because the blood supply here is actually very unique, and it is distinct from other parts of the body in a way that if you notice here, there is an afferent arteriole. Arteriole usually goes into capillary, and these are the capillaries here, glomerulus. But then what is coming out is not a venule, but this is another arteriole. So there are two sets of arteriole. There is an afferent arteriole and an efferent arteriole. And the reason we have this setup in the body, because this kidney filtration has to be regulated, which means that we have to maintain certain amount of filtration, we have to secrete certain solutes, we have to reabsorb certain solutes. So this area has to be highly regulated, and one way we can regulate this area is by constricting, for example, the afferent arteriole, or constricting the efferent arteriole, because they have muscles, right? And once they have muscles, they can simply be, they can be sympathetic stimulation, parasympathetic stimulation. So they can be constricted, they can be dilated. So body can easily control this area and this area, and by controlling these two areas, the whole process of filtration can be altered. So for example, let me share this example with you. So if for any reason my afferent arterioles dilate, look at this example very carefully. What will happen? So if the afferent arterioles are dilated, there will be more blood flow in the glomerulus. Because of the more blood flow, there will be more pressure, and then there will be more filtration. So increase in the size of the afferent arteriole, which means the dilatation, there will be more filtration. There will be more plasma flow. There will be more blood obviously coming here, so more plasma flow, more filtration, which means GFR. Okay, and a ratio between GFR and renal plasma flow is something what we call the filtration fraction, which basically means if this is my Bowman capsule and the nephron, and this is the blood coming towards the nephron, if I say that, for example, there is 5 liters plasma which is coming towards the nephron per minute, this is the total amount of plasma coming here. So renal plasma flow is 5 liters per minute. But of that 5 liters, say for example only 2 liters is filtered, then there's a very small fraction of the total renal plasma flow which is filtered. So this is known as filtration fraction, the amount of anything which is filtered out of the total which is coming towards the kidney. And the formula to do this would be GFR, which is this amount, divided by renal plasma flow, which is this amount. So if you divide 2 divided by 5, that should give you the filtration fraction in percentage. Okay, so that's the concept of filtration fraction. So if in this example which I was telling you there is dilatation of afferent arteriole, what will happen to the renal plasma flow? It will increase. What will happen to the GFR, the filtration? It will increase. Since both of them increase, what will happen to the filtration fraction? Nothing, because the GFR is increasing and the renal plasma flow is also increasing almost to the similar ratio, so the filtration fraction is not affected. Similar thing will happen if we constrict the afferent arteriole for any reason. There can be different mechanisms by which we can do this actually, but if we constrict the afferent arteriole, the size will reduce. What will happen to the renal plasma flow? It will decrease. What will happen to the GFR? Obviously it will decrease because less blood is coming in, so filtration will go slow. So there is less GFR, there is less renal plasma flow, and therefore because both of them are less, GFR and renal plasma flow, there will be no effect on the filtration fraction. But let's now imagine what happens if we constrict the efferent arteriole instead. So if this is constricted, what will happen? Imagine what will happen to, for example, to the GFR. Think about it. If this is constricted, there will be back pressure of blood into the capillaries here in the glomerulus, and because of the back pressure there will be more filtration. So GFR will increase if you constrict the efferent arteriole, increase in GFR. And what will happen to the renal plasma flow? Basically the renal plasma flow is also going to decrease in this condition. Why? Because imagine there is a blockage in the efferent arteriole, so blood is actually not going forward. If blood is not going forward, it will backlog here. If it backlogs in here, there will be less amount of blood coming in here. So that's just simply because of the obstruction. So the renal plasma flow is decreasing. Now for the filtration fraction, we have the formula GFR divided by renal plasma flow. So if GFR is going up and renal plasma flow is going down, you can estimate that the filtration fraction will go up, actually very high. Okay, now what will happen if for any reason there is increase in the protein concentration in the plasma? Now think your way through. If there is increased protein concentration in the plasma, this simply means that there is more osmotic power here. If there is more osmotic power here, what will happen to the GFR? It will reduce, because now this high osmotic power will try to retain water within the blood vessel. So the GFR will reduce in this condition. What will happen to the blood flow? Nothing, because the high osmotic power, usually, generally speaking, changes in the osmotic oncotic capacity of the blood does not affect the renal plasma flow. The blood will still go through the capillary. There is no obstruction in the blood vessels, so no change in the renal plasma flow, therefore the filtration fraction will go down. Okay, if there is decreased plasma protein concentration, now think about this scenario. Now we have decreased plasma concentration. I mean, patient may be cirrhotic, or the patient has any protein losing enteropathy, so there is less protein here in the blood. So less protein in the blood would mean what? There is less oncotic power. If there is less oncotic power, there will be changes in the GFR. GFR will increase. We will lose more filtrate. So GFR, and there will be no effect on the renal plasma flow, because I told you changes in protein concentration in the blood does not affect the renal plasma flow. So as a result, now what will happen to the filtration fraction? It will go in the upper side. It will increase. Now let's talk about if ureters are blocked. So this condition can happen, for example, in stones or tumors and things like that. So this tube is connected to the ureter at the end of the day. So if I block ureter is essentially equal to as if I do a blockage here in the proximal convoluted tubule, because of the blockage here in the ureter, there will be back pressure, and this area will have high pressure. And if this area will have high pressure, what will happen to the GFR? It will reduce. What will happen to the plasma flow? Nothing, because there's high pressure here. It has nothing to do with the blood supply. The blood supply is not blocked anywhere. Okay, so and the final condition would be if there is dehydration, there will be low volume. Because of low volume, there will be low GFR, and obviously the renal plasma flow is also decreased because there is generally low volume throughout the body, and this will increase the filtration fraction. So this is a super important table for you to understand, otherwise you'll be in great trouble. Okay, now before I move forward from this page, it is important to spend a few minutes on two very important concepts. The first one is the concept of the prostaglandin and the NSAIDs. So prostaglandins usually dilate afferent arteriole, and they have given a very nice mnemonic here. Prostaglandin dilate afferent arteriole. PDA is something that you know for some reason, yeah? Patent ductus arteriosus. So prostaglandin dilate afferent arteriole. Now imagine if they dilate the afferent arteriole, now you know everything. There will be more renal plasma flow, there will be more GFR, there will be no change in filtration fraction. But if prostaglandins are blocked, for example by using NSAIDs, and we use NSAIDs quite a lot in clinical practice. So if you use NSAIDs, all the actions will be reversed. So what were the actions of prostaglandin? They dilate the afferent arteriole. So by dilating the afferent arteriole, the renal plasma flow increases, GFR increases, but no change in the filtration fraction. So if NSAIDs are used, everything opposite to this will happen. And if you use ACE, angiotensin 2 is the potent constrictor preferentially of the efferent arteriole. So that's the normal job of angiotensin 2. And if efferent arteriole is constricted, there is decreased plasma flow, increased GFR. We have done this bit in this table. But if you now use ACE inhibitor, the actions will be opposite. Now it has very important clinical relevance. The clinical significance lies in the fact that when you use NSAIDs, what did I just tell you? I tell you that there will be reduced renal plasma flow because of NSAIDs, because NSAIDs is going to inhibit the function of prostaglandin. Prostaglandin tend to increase the renal plasma flow, but if you use NSAIDs, the renal plasma flow will be decreased. GFR will be decreased. Think about it. Would you like to give NSAIDs to your patient who have kidney failure? No. Would you like to give NSAIDs to your patients who have chronic kidney disease? No, because they already have chronic kidney disease, and now you are giving NSAIDs which reduce the renal plasma flow, which reduce the GFR. You don't want to do this, basically, right? All right, okay, and now let's move on to the next page, which is about that's a simple concept. Basically, here we talk about the concept of reabsorption and secretion. I already told you that in the nephron, we know that there are certain stuff which is reabsorbed after filtration. There are certain stuff which is secreted after filtration, and therefore the excreted amount is not necessarily the same as the filtered amount. Because imagine if something is being filtered, say for example 100 milligrams of something, but 120 milligrams is coming out in the urine, it simply means the 20 milligram is secreted at some stage in the nephron. And conversely, if 100 milligram of something is filtered and only 80 milligram is coming out in the urine, so the excreted amount is 80, but the filtered amount is 100, which means that 20 more is reabsorbed. So therefore these are two different terminologies. Okay, if you want to talk about filtered load, the filtered load is basically the GFR, which means the filtration, times the plasma concentration. So this area will give you filtered load. Out of that filtered load, how much is excreted? So that is then the excretion rate, which is the volume flow of the urine times the urinary concentration. Very important equations. Okay, so in general, you should know that reabsorption rate is equal to the filtered rate minus excreted. So anything, if you want to see if it is being reabsorbed or not, you have to know these variables. You know what is the amount filtered here, what is the amount excreted here. Subtract the numbers, you get the reabsorption rate. And the secretion would be, and these should make sense to you. Secretion would be anything excreted minus the filtered. If it is if the number is 0, so let's put some numbers in here, and that will then make sense to you. Otherwise it may just be a random read. Yeah, so this is the nephron again, and this is the excretion bit, this is the filtration bit. So say for example, if we have the excreted value of 120 of any substance X, that's the concentration which is excreted, and the filtered concentration is, say for example, 100. So that would simply mean that 120, which is excreted, 120 minus 100 is equal to 20. So 20 is the secreted concentration of that solute. Okay, and now if we change the scenario, if the secreted if the filtered load is 100 but the excreted load is 80, so use this equation now. What was the filtered load? 100. What is the excreted load? 80. Where did this 20 go? This is reabsorbed. Easy peasy. Easy stuff. Yeah. Now we have already talked about the filtration fraction concept. Now this is a different concept which is called FENA, and this is the sodium excreted versus sodium filtered. This is very, very important indicator of how your kidneys are working. So remember, FENA is the fractional excretion of sodium. And for this, in order to calculate this, you need to know what is the amount of sodium coming out in the urine. So sodium excreted, and the formula to get that would be excretion rate is always equal to the urinary concentration of sodium times the volume flow. And you also need to know how much sodium is filtered, for which filtration load formula is GFR into plasma concentration. So if you know these things, you easily know what is the fractional excretion of sodium. Okay, right. That then brings me to the next concept, which is glucose clearance. Now glucose at normal plasma level, if it is 60 to 120, is completely reabsorbed. So whatever is filtered in the nephron goes back into the blood. But obviously if the plasma concentration of glucose go high, then there are problems. So the plasma glucose of 200 milligram, for example, if it reaches to this level from 120, it raises to that level, then you start seeing glucose in the urine. So glucose-urea begins, and at the rate of 375 milligrams per minute, all the reabsorption transporters in the nephron, they are fully saturated, and now you have like obviously glucose coming in the urine. Okay, so if you look at this graph, here is the plasma concentration. So up till the level of 200 you are perhaps okay, but after 200 you start excreting glucose into the urine, and after the level of 375 or 400, then the reabsorption just stops and it gets out into the urine. Okay, now you also need to consider this very important concept that in the normal pregnancy, which is associated with increased GFR because of the fluid dynamics in the body, the filtration is increased. With increased filtration of all the substances, including the glucose, because GFR is increased, so more and more GFR means more and more solute, means also more and more glucose. The glucose threshold occurs at lower plasma concentration. So you see glucose in the urine at levels lower than 200 milligrams. Okay, so that's an important point to understand, that in pregnancy the glycosuria is seen even at normal plasma glucose levels. So don't consider that the kidneys are all screwed up. It's just the normal physiology which is happening during the process of pregnancy. Okay, Now, the sodium glucose co-transporters, you know these transporters in the proximal convoluted tubule, we talked about them. There are these transporters on the urinary side, on the apical side, so they take sodium along with glucose. So there are drugs which can inhibit these transporters, and if these drugs are used, obviously glucose will not be reabsorbed and glucose will get out in the urine. So these drugs, all the flozin drugs, will lead to glucosuria. Glucose will go in the urine. Okay, and obviously this will happen, it has nothing to do with the plasma concentration of the glucose, because now you are actually inhibiting the glucose transport at the level of the nephron. So whatever the level of plasma glucose be, even less than 200, you can get glucose in the urine. So two scenarios at least you need to understand where you can see glucose in the urine even if the levels of the plasma are less than 200 milligrams. So one condition is pregnancy, and the other condition is the use of SGLT2 inhibitors. Okay, why we are talking about this so much? Because glucosuria is a very important indicator of how your kidneys are working, and this gives a clue towards diabetes mellitus. Okay, the splay phenomena is this area where the transport maximum is being achieved for the reabsorption within the nephron. So we have the nephrons, and these nephrons contain receptors for absorption of glucose. As the glucose concentration in the blood increases, more and more glucose comes in the urine, and more transporters, proteins, are saturated. So that time period when they begin to saturate till they're fully saturated is what we call the splay. Once they're saturated, everything gets out in the urine. Okay, let us now talk about a very important concept, and this is the mainstay of understanding renal physiology. Let's talk about what happens in the nephrons. Let us now go through this very important diagram of renal module from first aid, which actually is the basis for complete understanding of how nephron transport physiology happens. We draw this diagram so many times that in the nephron we have this Bowman capsule, and then there is proximal convoluted tubule, then there is descending loop of Henle, then there is ascending loop of Henle, then distal convoluted tubule, and then the collecting ducts. Okay, this diagram you have to remember all the time. So in all the discussion that we do, we will be referring to all these parts. So there is this portion which is called Bowman capsule. And Bowman capsule is the place where we have, if I draw this in red, it will look much more beautiful. We have this glomerulus, okay? And this glomerulus is the area where all the filtration of solutes happen. So all these solutes then enter into the next segment, which is known as the proximal convoluted tubule. Then this portion, complete U-shaped structure, is called loop of Henle, which is composed of a descending limb of loop of Henle, and then there is an ascending limb of loop of Henle. They are physiologically very different from each other. Then there is the distal convoluted tubule, and then we have this collecting duct. All these portions have their distinct features. They have different type of cells, they have different type of physiological transport mechanisms in place. So keeping this diagram in view, and one more important concept, which is about, before we start this particular diagram, because this is very rich diagram, and what they have done there in this book, that they have picked up a portion. So for example, the first part of this diagram will be proximal convoluted tubule physiology. So they have taken up this diagram, and this is what they are explaining, what happens in the proximal convoluted tubule. The cells they have made here, obviously, I mean, if you imagine a tubule, this is a tubule, right? If this is a proximal convoluted tubule, this is the portion which I have magnified over here. So whatever is filtered at the level of the glomerulus, it comes here. So there is urine going in this tubule right there, okay? And obviously, because this is a tubule made up of different type of cells, there will be so many different types of cells here like this, okay? And the other side of the tubule will also be having a lot of cells. So this is the basic structure. There is a tubule, and then the proximal convoluted tubule, goes into the loop of Henle. So it continues as a tube. Now, this is the portion that we are talking about. Now, if we consider this one single cell, you see this cell has at least two surfaces. There is one surface which is facing towards the urine, because this is the area, this is the part of the tube where we will have urine, okay, the filtrate from the Bowman capsule. So this surface of these cells which are lining the proximal convoluted tubule, this surface, this is known as urinary surface or urine surface or the apical surface. And the other part of the cell which is facing towards the interstitium, obviously this will be the tissue, kidney tissue, interstitial tissue. So this surface is known as basolateral part of the membrane. This is the basolateral membrane, basolateral side of the cell, and this is the urine side of the cell. So technical terms we call it the apical side is the urine side. So this is the urine portion. Patient will have urine here, okay? So all these solutes, they are present in the urine, and this is then the basolateral side. Now, when we say the basolateral side, it basically means that towards the interstitial side of the kidney, so towards the tissue side, and obviously there will be blood vessel here. So whatever comes out of the basolateral side, it goes into the blood. Therefore, the basolateral side is also known as the blood side. So whenever we are looking at this diagram, try to look at the diagram in pockets. So the first pocket is this. Let me make it simple for you so that you can read first aid very, very effectively. So the first pocket is this, proximal convoluted tubule. This pocket is pocket number 1, okay? So let us focus on pocket number first. What happens in the proximal convoluted tubule, and now you have the context that this is one single cell that we have drawn, and it is actually placed like this. In the proximal convoluted tubule, we have taken only one cell, and this one cell has a urinary surface and a basolateral surface. So whatever is present on this side towards the urinary surface, towards the apical membrane, this is all present in the filtrate, or in other words, the filtrate is also known as urine. And whatever is coming out of this side is actually going into the blood. So let's see what happens in the proximal convoluted tubule. So first thing which you have to remember, that the proximal convoluted tubule, let me redraw this diagram one more time for you, focusing on the proximal convoluted tubule. So the proximal convoluted tubule, this portion, is the place where maximum reabsorption of solute happens. So this is very busy part of your nephron. So whatever is filtered from here, I am inclined to make this red again and again because it looks so beautiful. So this is the glomerulus, okay? The afferent and the efferent arteriole, and in between is the glomerulus. So whatever is filtered from here at the level of the Bowman capsule comes into the proximal convoluted tubule, and the proximal convoluted tubule contains, the filtrate here contains a lot of sodium, a lot of glucose, a lot of different solutes. Most of them are reabsorbed here. So wherever in the body we have huge reabsorption going on, we have brush border, and the brush border, the same happens in villi, for example, in intestine. So the purpose of the brush border is to increase the surface area. So the first thing written here, that the proximal convoluted tubule contains brush border, and this is to increase the level of absorption. And this segment of the nephron reabsorbs all of the glucose, this is very important, and amino acids. So complete amino acids, whatever filtered here, all glucose, whatever filtered here, is reabsorbed back in the proximal convoluted tubule. It also reabsorbs most of the sodium, most of the chloride, most of the phosphate, potassium, and bicarb. Also a lot of water is reabsorbed, and uric acid as well. Although most of the uric acid is functionally reabsorbed at the level of the collecting duct, we'll discuss this later, but this segment is also permeable to uric acid. So you see, such a large number of solutes are reabsorbed in the proximal convoluted tubule, and we'll talk about them in great detail in a moment. But for now, just remember that this portion, the proximal convoluted tubule of your nephron, is a very busy portion. It reabsorbs a lot of things, okay? Right, it generates and secretes ammonia, which enables kidney to excrete more hydrogen. We'll talk about this. So let's talk about this in terms of this diagram, which makes life easy. Now, if you look at this cell, this is a cell of the proximal convoluted tubule, and I will begin my discussion from this pump, which is the sodium potassium pump, which utilizes energy. This is basically the generator of the whole transport mechanism. So what basically happens, that this pump functions and it takes sodium ions from the tubular cell into the basolateral side, which means into the blood, and in exchange, 2 potassium ions are taken in. So what happens basically, that this pump, if I have to transfer this into very simple language, the pump is basically throwing out sodium. So when it throws out sodium, the concentration of sodium within the cell will go down. So there is reduced concentration of sodium. So there is reduced concentration of sodium, and we have a lot of sodium in the urine. This is the urinary side. So high concentration and low concentration. So sodium gets into the cell. Sodium is reabsorbed. It is reabsorbed, and from this pump it goes into the blood. So sodium is reabsorbed, and in doing so, sodium brings along with itself glucose as well as amino acids. So sodium entry is then also joined by glucose and amino acids. So all the glucose is reabsorbed, all the amino acids are reabsorbed. Why? Because this generator, this is the initial event. It generates a low sodium concentration within the cell, which generates a sodium gradient, and the urinary sodium, whatever was filtered, is now taken up by the cell, and from the cell it goes into the blood. And I'm repeating this, sodium along with itself also brings in glucose and amino acids. Okay, so that's how sodium entry, glucose entry, and amino acid entry happens within the proximal convoluted tubular cell. So that's very important part. So this is covered, this is covered, this is covered. We talked about sodium entry, glucose entry. Let's talk about something else. What happens with bicarbonate and ammonia and hydrogens is very, very important. Now, parathyroid hormone inhibits sodium phosphate cotransport. So sodium is bringing in a lot of things, not only glucose and amino acid, but it also along with itself brings in phosphate. And this phosphate reabsorption is inhibited by PTH, and this also happens at the level of proximal convoluted tubule. So parathyroid hormone is easy to remember. It's phosphate trashing hormone. So what it does, it stops the reabsorption of phosphate. So if phosphate is not reabsorbed, it will be excreted out in the urine. So imagine this is the urine side. It contains a lot of phosphate, and this phosphate was supposed to go into the cell, but PTH is blocking phosphate entry into the cell, so it will get out in the urine. So PTH is a phosphate trashing hormone, right? Next, angiotensin 2. This is something that you have to also remember. It stimulates sodium and hydrogen exchange, which means increased sodium and water and bicarb reabsorption, and it allows more and more hydrogen to get out. So what basically we are talking about is this bit of the metabolism within the proximal convoluted tubule. So let's focus on what happens with bicarb and how is that handled within the proximal convoluted tubular cell. So you know that we have bicarbonate and hydrogen within the cells, and we also have a lot of bicarbonate filtered into the filtrate at the level of the glomerulus. So this bicarbonate has to be reabsorbed because that's an important thing for the body. Bicarbonate is an important basic component, and it is utilized as an important buffer for many body functions. So what basically happens that the cells are producing carbon dioxide, and cells are also producing a lot of water. So this cycle keeps on going, and the key enzyme to remember here is the carbonic anhydrase. So you know that when we are absorbing a lot of sodium, and why we are absorbing a lot of sodium, because this pump is generating low sodium concentration within the cell. So sodium is getting in, and sodium is taking a lot of things with itself. It is taking glucose, it is taking phosphate, for example, it is taking amino acids. It is also antiporting hydrogen. So when sodium gets in, it removes a hydrogen out into the urine. Now this hydrogen binds with the bicarbonate, they form carbonic acid. Carbonic anhydrase works on it, and carbon dioxide and water are formed. They get into the cell, proximal convoluted tubular cell, and within the cell what happens, this carbon dioxide and water again forms carbonic acid, again by the same enzyme called carbonic anhydrase. And once carbonic acid is formed, it is dissociated into bicarb and hydrogen. This bicarb gets into the blood. So this is how we reabsorb bicarb. It is very important for us to reabsorb the bicarbonate, because if we don't reabsorb bicarbonate, we will be in trouble, and we will have a condition of acidosis, because this bicarbonate neutralizes a lot of acids within the body. Okay, so the point is, each and everything written on first aid should be very clear to you. So once we move forward, we should know that what does this mean? What does this mean? What does this mean? What is this? What does this mean? What does this mean? Everything should be clear. So the overall effect, if I have to summarize what's happening at the level of the proximal convoluted tubule, most of the things are being reabsorbed. Sodium, glucose, phosphate, all bicarbonate, all these things are being reabsorbed into the blood, and the main hero, the main generating force is the sodium potassium ADPase. All right, so everything clear here? So that was the first block, proximal convoluted tubule. This is what we have just discussed now, block number 1. Let us now focus on the next block, and the next block is called the descending loop of Henle. Remember this diagram, this initial diagram which I drew and then I think rubbed it. Let me draw this again for you. So we have Bowman capsule, proximal convoluted tubule, and then the descending limb of loop of Henle, then ascending limb of loop of Henle, then distal convoluted tubule, and then the collecting duct. So we have dealt with the proximal convoluted tubule, and we understood that many of the things are reabsorbed here from the nephron to the blood. Now we are talking about this portion, the descending loop of Henle. So this section is basically very much permeable to water. It is the segment where water gets out from the nephron and enters into the interstitium. So this is what happens here. So this is basically a segment which is concentrating the urine. Imagine, I mean, if this is the urine flowing here and you take a lot of water out, so whatever is remained within the nephron will be very much concentrated. So this segment here, there is passive reabsorption of water. And why this happens basically because this nephron is present in a very high tonicity, and this tonicity, which is in medulla, is maintained by high concentration of sodium, high concentration of chloride, and high concentration of urea. So this segment of nephron is surrounded by very strong osmoles. Therefore these strong osmoles drive water out, and once water gets out, urine becomes very concentrated in this part. So this is therefore called the concentrating segment. It makes the urine very concentrated or hypertonic. So this was block number 2. So you have to keep track of what's happening in each and every part of the nephron. So the proximal convoluted tubule, many things are reabsorbed. You should know by this diagram how this happens. Descending loop of Henle, water is reabsorbed. This is concentrating the urine, and therefore this is called the concentrating segment of the nephron. So the third part now is the ascending limb of loop of Henle. So this portion basically, this ascending limb. And let's see what happens here. So this is block number 3, okay? Ascending limb of loop of Henle, block number 3 that you have to understand. So thick ascending loop of Henle is designed to reabsorb sodium, potassium, and chloride. So sodium reabsorption was also happening in the proximal convoluted tubule. So same story happens here again. Let me increase the size here so that you understand. So again, this is the main initiating factor, the sodium potassium pump. What it does, it throws sodium out from the cell into the blood and potassium in. This potassium leaks out in the urine. And because a lot of potassium is leaking out, there is a positive charge on the surface. On which surface? On the apical surface of the nephron cells. And these positive charges, they kick off, they repel other positive charges such as magnesium and calcium. This is how magnesium and calcium are reabsorbed by paracellular route. This is one cell, this is other cell. And who is kicking these positive cations? Potassium. The positive charge generated by the potassium leak. Now, this is very important to understand because many times they test the concept in examination that how magnesium and calcium paracellular absorption is facilitated by potassium. So what's happening here is that this pump is throwing sodium out. So sodium is gone out and potassium is coming in. So there is high concentration of potassium which leaks outside, and it kicks off other positively charged ions to be absorbed into the blood. Another effect of this sodium potassium ADPase is that it lowers the concentration of sodium within the cell because it is throwing sodium out. So once there is low sodium concentration within the cell, sodium gets in. And this time, this protein, this pump also brings in potassium and chloride. And there are some diuretics which block this pump. So loop diuretics, we'll talk about them when we do the pharmacology of renal module. But I hope you now understand that what's happening with increased potassium concentration, what's happening with decreased potassium concentration. It is absorbing sodium from the urine. This high potassium will leak in this direction as well. Okay, and the high level of chloride which is entering into the cell also is reabsorbed into the basolateral side. So basically this part of the nephron is reabsorbing sodium, potassium, and chloride. It indirectly induces paracellular absorption of magnesium and calcium. I just told you how it kicks off magnesium and calcium, because there is a positive lumen potential generated by leak of potassium. Now, this segment, very important to understand, is impermeable to the action of anything which reabsorbs water. So this is impermeable to water. No water movement takes place here, and therefore if water does not get out, it stays in the urine. It makes the urine less concentrated. Okay, and overall, if we talk about nephron wise, different part of the nephrons, if we talk about the selective sodium reabsorption, so most of the sodium, about 60 to 70% of the sodium, roughly about say 65%, is reabsorbed in the proximal convoluted tubule. And then this part which we are discussing right now, the ascending limb of loop of Henle, it takes about 10 to 15%. So this is what is written here: 10 to 20% sodium is reabsorbed in this particular part, and this is impermeable to water. I just told you that the proximal convoluted tubule and the descending limb, ascending limb, a lot of water is reabsorbed in the proximal convoluted tubule, a lot of water is reabsorbed in the descending limb of loop of Henle, so much so that this concentrates the urine, but this part is impermeable to water. Okay, so if I have to make a diagram to make it much more interesting, I'll do this for you. So this is distal convoluted tubule and collecting duct. So if I have to demarcate this portion, anything on the left, which means the proximal convoluted tubule and the descending loop of Henle, this part is permeable to water, and then this part is impermeable to water, and the remaining portion, it depends if there is ADH or not. So it may be permeable to water, may be impermeable to water. So you need to remember three different parts of the nephron as far as their water permeability is concerned. So I hope you now have very clear understanding of proximal convoluted tubular reabsorption, what happens in the descending limb of loop of Henle, part 2, and then ascending limb. Now let us enter and dive into another segment of nephron, which is known as the distal convoluted tubule. So this is part 4, fourth section of the nephron. Remember this beautiful nephron? Bowman capsule, proximal convoluted tubule, descending loop of Henle, ascending loop of Henle, and now the distal convoluted tubule. The distal convoluted tubule reabsorbs sodium chloride. It is also impermeable to water, and because it is impermeable to water, water stays in the urine, and the urine becomes very, very dilute. And here you also expect the action of parathyroid hormone, which increases calcium and sodium exchange. Let's talk about it. Look at the cell. If you look at the cell, you understand how different solutes are being transported. Remember, this is the apical side. So here we have the urine, we have the filtrate, and here we have the blood. So this is the basolateral side. Okay, again we have this super pump available, sodium potassium pump, which throws sodium out and gets potassium in. So the sodium, if it gets out, it reduces the concentration of sodium within the cell, which brings in sodium from the urine, and it is doing so here along with chloride. Okay, now this part of nephron is also permeable to some other cations via different channels such as magnesium and calcium. So they are also absorbed here, and then the calcium gets into the blood in exchange for sodium, and we can always throw sodium out to again generate the gradient here, and chloride also diffuses into the blood. So this part of the nephron is basically doing reabsorption of sodium and chloride from the urine into the blood. It also absorbs calcium in exchange with sodium, and this action is enhanced by parathyroid hormone. Okay, so parathyroid hormone increases calcium reabsorption, and it increases calcium reabsorption by inducing this particular receptor. So what happens when parathyroid binds to its receptor on these cells, expression of this protein pump is increased, and once the expression of this protein pump is increased, it functions more. So calcium out, sodium in, and calcium out lowers the calcium concentration inside the cell, more calcium coming into the cell from the urine. All right, so everything should be very much clear. So up till now we have observed that sodium is being reabsorbed in the proximal convoluted tubule and then in other parts as well, in the ascending limb of loop of Henle and now in the distal convoluted tubule as well. Only about 5 to 10% is reabsorbed here. So every single word written in the text should be clear to you. Every single thing on the diagram should be clear to you. Okay. Now let's move our discussion on to the next part of the nephron, which is the collecting tubule. So again, if I have to draw the diagram, this is the loop of Henle, then we have proximal convoluted tubule, then descending limb of loop of Henle, ascending limb of loop of Henle, distal convoluted tubule, and the last part, the collecting duct. Now this collecting duct contains two different type of cells. They have principal cells and they have intercalated cells, and each cell has different type of function, different type of physiological requirements. Okay, so let us start again our discussion by reading the text. So in the collecting tubule, what happens? It reabsorbs sodium in exchange for secreting potassium and hydrogen. So the job of this part of the collecting of the nephron, which is the collecting tubule, is basically to reabsorb sodium. So sodium has to get in, but what happens is that it throws out potassium. So the sodium is being reabsorbed in exchange for potassium and hydrogen. So it secretes hydrogen, it secretes potassium. That's the main. So if I have to talk about this portion of nephron, I should be very clear that this portion is reabsorbing sodium into the blood and throwing out two very important things, which is potassium and hydrogen. Okay, all this transport physiology becomes highly relevant and very important, particularly when we are talking about drugs. So say for example, if we are talking about blockage of a particular channel, we should know, okay, what will be the consequences of that blockage. If we use any diuretic, what will happen? It will induce more and more sodium reabsorption, so it will also induce more and more potassium and hydrogen excretion, which means hypokalemia and loss of hydrogen. So this line becomes very important, and this function, reabsorption of sodium and loss of hydrogen and potassium, is basically regulated by aldosterone, which can bind to its channel, induce the activity of sodium potassium ATPase. So more sodium getting into the blood, potassium into the cell. This potassium then gets out and lost in the urine, and because you are creating a lower gradient, a lower concentration of sodium within the cell, then sodium gets into the cell and it is reabsorbed. So the overall effect of aldosterone here on the principal cell would be reabsorption of sodium and loss of potassium. Also, please remember that the collecting duct is also permeable to urea, and this is very important because urea gets absorbed in here and then it is released out into the interstitium, and in the interstitium it creates the high osmolarity because of which water comes out from the descending limb of loop of Henle. Okay. So aldosterone effect we talked about. Now aldosterone basically act on the mineralocorticoid receptor and increases the synthesis of protein, which means these channels. So once aldosterone binds here, the expression of these channels is increased. Okay. In principal cells, what happens? So we're talking about this group of cell. The messenger RNA is also transcribed because aldosterone is binding to the receptor, and then there will be nuclear expression changes. So in principal cells, what happens? Apical potassium conductance increase sodium potassium ATPase activity. Because there is increased ATPase activity of sodium potassium ATPase, there is more and more potassium coming in and there is more and more sodium getting out of the cell. So this potassium which comes into the cell has to get lost in the urine. This is what happens. Okay, and what happens in intercalated cell, alpha intercalated cells? This is the intercalated cell. So here again aldosterone is binding and it is then inducing the activity. The overall effect of that activity of aldosterone would be loss of hydrogen. Okay, so this is increasingly losing hydrogen from the intercalated cell. So in intercalated cell, the lumen negativity, hydrogen ATPase activity is increased. So if hydrogen ATPase activity is increased, it releases more and more hydrogen into the urine. Therefore, there is more hydrogen secretion. There is more bicarb and chloride exchanger activity also because of the aldosterone. So if the bicarb chloride exchange activity is increased, it increases the absorption of bicarb from the cell into the blood and chloride into the cell. So these are the overall effects that you definitely have to remember. Okay, there are also beta intercalated cells which are releasing hydrogen into the interstitium via ATPase activity, and there is a chloride bicarb antiporter towards the urine side. But definitely for exam purposes you have to remember principal cells, activity of aldosterone, and intercalated cell. We also should consider the discussion about antidiuretic hormone. Now antidiuretic hormone basically are a group of hormones which basically increases water reabsorption, and how it does this is it induces the expression of channels which reabsorb water, and these channels are called aquaporin channels, aquaporin 2 to be very specific. So more and more aquaporin channels are inserted into the urine side, and more water is reabsorbed. Now obviously think about all those conditions where you have very high osmolarity in the blood. High osmolarity in the blood means you need more and more water in the body. So when you need more and more water in the body, expression of ADH is increased and these channels are expressed and you get more and more water in the body. All this also happens in the collecting duct. So again, if you look at the diagram cumulatively, we talked about different parts of the nephron, starting from proximal convoluted tubule, then the descending limb of loop of Henle, then the ascending limb of loop of Henle, then the distal convoluted tubule, and then the collecting duct. Each and every part has a different dynamics, and this is very nicely written on the first aid. The point of reading first aid again and again, ladies and gentlemen, is that you should make sense of each and every word written. So with this, let us now move on to a very important topic, which are renal tubular defects. If you look at this little beautiful diagram, let me zoom into this particular diagram. So you're looking at a beautiful nephron. Here you see the Bowman capsule, and this is the proximal convoluted tubule, and then this is the loop of Henle, and this particular segment is the thick ascending limb of loop of Henle. Then this is the distal convoluted tubule and the collecting tubules. Okay, so 4 different areas: proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting tubules. And you see 4 important names written there. These are all called the renal tubular defects. When we say renal tubular defects, obviously the name indicates that these are going to be the defects in the renal tubules, and this is the renal tubule, basically the nephron. So if there is something wrong in the proximal convoluted tubule, the name of the disorder is Fanconi syndrome. If there is something wrong in the ascending thick limb of loop of Henle, this is what we call the Bartter syndrome. Then we have the Gitelman syndrome, which is problems in the distal convoluted tubule, and then Little syndrome, and same. So 4 and 5. So 5 disorders that we have to deal with today. Fanconi syndrome, number 1. Number 2, we will talk about Bartter syndrome, then Gitelman syndrome, Little syndrome, and syndrome of apparent mineralocorticoid excess. SAM is what we call it. Now each one of these defects are obviously linked with the basic understanding of normal physiology. So for example, when we talk about Fanconi syndrome, what is the defect in the Fanconi syndrome? There is generalized reabsorption defect in the PCT. PCT is the proximal convoluted tubule. Now in order to understand the effects of what is wrong in Fanconi syndrome, you must know what is the normal physiology which happens in the proximal convoluted tubule. So PCT's normal physiology will have a very big effect on your understanding the effects of the particular disease. So my suggestion would be that first go watch my video on nephron transport, in which we discuss in detail this particular diagram, in which we talked about what happens in proximal convoluted tubule, what happens in thin ascending limb. So if you understand my previous video, I'm giving the link again here in the description, so that you first watch that video, and then we say easily that if there is anything wrong in the proximal convoluted tubule, the outcome is known as Fanconi syndrome. And what will happen if the proximal convoluted tubule is defected? There will be increased excretion of amino acid, glucose, bicarbs and phosphate and all other substances which are absorbed by the PCT. You remember proximal convoluted tubule was the site where most of the filtrates were actually reabsorbed back into the body. So we discussed in detail this particular diagram, that there was the urine side of these cells, and then there was the tissue side or the interstitium or the blood side. So whatever was filtered in the urine was, most of it was reabsorbed. For example, sodium gets into the cell, glucose is reabsorbed, bicarb is reabsorbed, chloride is reabsorbed, we talked about phosphate, we talked about potassium. All these things were reabsorbed, and if these cells are defective, the proximal convoluted cells are defected, all these things which were reabsorbed, they will go away in the urine. So this is what is happening in Fanconi syndrome. Increased excretion. Excretion where? Excretion in the urine. So increased excretion of everything which was absorbed normally. Now because there is defect in proximal convoluted tubule, these things are not reabsorbed, but they are wasted in the urine. So that's what happens in Fanconi syndrome. The problem lies in the proximal convoluted tubule. Now why does this problem happen? What is the cause? This is usually a hereditary defect and is associated with other disorders. For example, Wilson disease, for example, tyrosinemia, glycogen storage disease. So in all these disorders, Fanconi syndrome is usually observed. So in examination, you may be given a question which is more looking like a Wilson disease, but suddenly they talk about the patient is losing lots of glucose. So you should be able to link Wilson disease and glycogen storage diseases and any other disorder which can lead to defects in PCT. You should be able to link them with Fanconi syndrome. Okay, and this is not the only thing. Hereditary defects are not the only thing which can cause Fanconi syndrome. Ischemia can do the same thing. Multiple myeloma, which is a tumor. Drugs, for example, ifosfamide, cisplatin, tenofovir, lead poisoning. So that is an extremely important paragraph that you must remember. What are the causes of Fanconi syndrome? So because of these causes and maybe others, there is defect in proximal convoluted tubular reabsorption. As a result, everything which is reabsorbed in the PCT is now not reabsorbed, and it goes and gets excreted in the urine. So we know what is the defect, we know what are the causes, and now what would be the effects. I mean, obviously you are losing everything which was reabsorbed. So in the proximal convoluted tubule, you were reabsorbing potassium, so now you are excreting potassium, so you are devoid of potassium, so hypokalemia. You will be losing phosphate, so hypophosphatemia, and metabolic acidosis. Now in order to understand the effects, it is again important to remember the physiology, because physiology tells you what happens if there is a pathological state. So for example, you see here potassium was being reabsorbed. Now potassium will be excreted, so hypokalemia. Phosphate was being reabsorbed, so phosphate will now be excreted in the urine, so hypophosphatemia. Now what about hydrogen? So if you look at this diagram here, hydrogen is being excreted in exchange for sodium. So that's the normal physiology. If these cells are not working, this hydrogen ion will not be excreted, obviously. And once the hydrogen ion is not excreted, what will happen? It will be accumulated, you know, in the interstitium side or the cellular side of the nephron, because it is not being excreted, which means that in the blood the concentration of hydrogen ion is going to be increased, and this is what we call metabolic acidosis. So just because this counter transport between hydrogen and sodium, this is not working, so we are not able to lose hydrogen. Since we are not able to lose hydrogen, blood concentration of hydrogen ion increases, and because of this, Fanconi syndrome is associated with metabolic acidosis, which is also called more to be associated with proximal renal tubular acidosis. This terminology we are going to study when we talk about different types of acidosis, but for now remember, Fanconi syndrome is a defect in proximal convoluted tubule, is caused by all these things, and it causes these effects including metabolic acidosis, hypophosphatemia, hypokalemia, hypokalemia, and so many other things. For example, the patient will also suffer from sodium deficiencies, or there may be sodium concentration decrement in the extracellular fluid, because now the person is not able to reabsorb sodium, not able to reabsorb glucose. So everything which was being reabsorbed in the proximal convoluted tubule is now not being reabsorbed, but is rather excreted in the urine. So that is what is all about the Fanconi syndrome. See, the point is, I always say that every written word on the first aid should be understandable to you. If you don't understand it, don't move ahead. So for example, if you are reading first aid and you are studying the topic of renal tubular defects, and you are studying Fanconi syndrome, and you are stuck here that why Fanconi syndrome is causing metabolic acidosis, do not move forward unless you understand and grasp this concept, because on first aid every single word is it's not less than a Bible word for you, I would say. Read it religiously if you want to score good in your USMLE MRCP exam. And this topic, by the way, renal tubular defects, I can guarantee you will have a question from renal tubular defects in one form or the other in your professional exams, whether you are talking about MRCP, USMLE, FCPS, whatever. There will be a question on renal tubular defects. It's extremely important topic. Okay, and now there are some special notes on each disorder. So for example, Fanconi syndrome is associated with growth retardation, rickets, and osteopenia, and you can assume this because there is hypophosphatemia. Phosphate is being excreted in the urine, so no phosphate, no calcium phosphate chelation, and osteopenia and rickets. And there will also be volume depletion, and that should also make sense to you, because I just told you there will be problem with the proximal convoluted tubular cells, which means sodium will not be reabsorbed. And if sodium is not reabsorbed, sodium was the main driving force for what? It was the main driving source for reabsorption of water, because for every sodium ion reabsorbed, we have an isotonic movement of water from the urine into the interstitium. And if sodium entry is blocked, water entry is also blocked. The patient will also have signs and symptoms of hypovolemia. So see, Fanconi syndrome is now all done and dusted. If you have any queries, let me know in the comment section, but I tried to read each and every single word to make sense and to explain that how important is this. These are 4 areas that we have to cover for each of the renal tubular defect. The first one was Fanconi syndrome. You know the defect is in the proximal convoluted tubule. This bit is Fanconi syndrome. What are the effects which are caused by the Fanconi syndrome, and then what are the causes of Fanconi syndrome, and some special notes. Okay, so all clear. Let's move on to the next one, which is the Bartter syndrome. Now Bartter syndrome is again the same formula. We need to understand the defect. The defect lies in the thick ascending loop of Henle, and the special channel which was present in the thick ascending loop of Henle was the sodium potassium 2 chloride. Now this sodium potassium 2 chloride channel is no more working, and when this channel is no more working, then now you should be able to understand what happens. Remember my video on the nephron transport? Now you realize how important that video is, to first watch this video and then to move on the renal tubular defect. So this is thick ascending loop of Henle, and on the apical membrane we have these ions moving into the cell by this transport protein, which is called the sodium potassium 2 chloride transporter. So this is now not working, and that is the problem in Bartter syndrome. In Bartter syndrome, this transport, the co-transport of sodium, potassium and chloride, does not happen. And if this does not happen, then so many other problems will be observed. So for example, let's start with the easy ones. What do you think will happen to the potassium concentration in the blood? So simple, potassium is not being reabsorbed into the cell, so it will not obviously be leaking into the interstitium, and in the interstitium we will see decreased concentration of potassium just because it's not being reabsorbed. It's a simple thing, as simple as that. It cannot be more simple than that. We are not reabsorbing potassium, so there is decrease of potassium in the blood, in the ECF, in the interstitium, so therefore we see hypokalemia. All clear? Now
what else is written here? Hypercalciuria, which means more calcium in the urine, which means less calcium absorption. So let's now talk about this and try to make a sense. Remember, I told you that because of this potassium leakage into the urine side of the thick loop of Henle, this potassium via its channel, it gets out into the urine, and because of this, what happens that the membrane starts getting a positive potential. So because of the positive ion moving outside, there we have a positive membrane potential, and this positive charge pushes these divalent ions, which are magnesium and calcium, to get between the cells into the interstitium. This is what was happening, and this is all discussed in detail in my previous video where we talked about nephron transport. But the point here to remember again is the fact that potassium leakage into the urine is creating positive membrane potential on the urine side, and because of that positive potential, divalent ions are repelled by the positive ion which is generated by potassium. Okay, now these divalent ions are then pushed, they are kicked between the cells to be entering into the interstitium. So that's the normal physiology. Okay, I have repeated it twice so that the concept is very clear to you. So now think about the scenario when this is not happening actually. So now potassium is not leaking. Why potassium is not leaking? Because we are not absorbing potassium. So the whole dynamics, the whole transport physiology of the thing ascending limb of loop of Henle is not working. So potassium will not be leaking through this particular channel, which means there will be no positive charges on the urine side of the membrane, which means no one will be kicking these divalent ions, and these divalent ions will not be moving into the interstitium, which means they will be getting out in the urine. And when more calcium is getting out in the urine, what is the terminology used? Hypercalciuria. So is that now all very clear to all of you that what's happening? Why hypokalemia is happening in Bartter syndrome? Why hypercalciuria is happening in Bartter syndrome? Now let's talk about a little more logical kind of thing, which is the metabolic alkalosis in Bartter syndrome. So again, try to look and spend a few seconds on this diagram to figure out why metabolic alkalosis will actually happen in Bartter syndrome. Now that you are very well aware of the fact that this channel is not working in Bartter syndrome, so if this is not working, there will be no reabsorption of sodium. And since you are not reabsorbing sodium, what will happen that in the collecting tubules, less and less sodium will be reaching there. So if you are losing salt, in any case when you are losing salt, less concentration of sodium is being sensed by the collecting tubule. And collecting tubule, just by sensing less concentration of sodium ion, it activates a beautiful system which is called the Renin-angiotensin-aldosterone system. So I have a separate video uploaded for Renin-angiotensin-aldosterone system. And for RAS activators, if you know, one of the important activator for RAS system was decreased sodium chloride delivery to the macular denser cell. So that is a potent activator, and obviously it makes sense now that if you are losing sodium in the urine, because this channel is not working in Bartter syndrome, so if sodium is not being reabsorbed, less sodium is reaching to the sensors, and as a result of this, the renin-angiotensin system is increased, and now you have more levels of angiotensin 2. So there will be more angiotensin in the body, and this angiotensin is going to then work on proximal convoluted tubule and this particular channel, which tries to reabsorb sodium and excretes hydrogen in exchange. So when more hydrogen is being excreted in the urine because of angiotensin 2, what will happen? More hydrogen being excreted, which means there will be less hydrogen in the blood, which is also what we call metabolic alkalosis, decrease in the hydrogen ion concentration. So just because of the fact that this sodium potassium chloride transport is not working, because it's not working, there will be less sodium reabsorption, activation of renin-angiotensin-aldosterone system, and more sodium entry into the body. So the body actually tries to make up for the disorder. If this channel is not working and it is not reabsorbing sodium, the body tries to absorb sodium from the proximal convoluted tubule via the angiotensin 2. And because of this channel's overactivity under the influence of angiotensin Renin-angiotensin 2, hydrogen is excreted more and more, and therefore we get metabolic alkalosis. So see, you need to have an overall picture, and the way I'm uploading the video is, first I uploaded the nephron transport physiology so that you classically understand what are the concepts associated with each single part of the nephron. So if you don't know that, it's difficult for you to understand all what we are discussing today. Therefore, I always recommend try to look up for the videos in the order that I have uploaded them. So Bartter syndrome, reabsorption defect in the thick ascending loop of Henle, disturbing the sodium potassium chloride co-transport, leading to all these things. And we spend time understanding why hypokalemia happens in Bartter, why hypercalciuria happens in Bartter, why metabolic alkalosis happens in Bartter. Okay, now what is the cause of Bartter syndrome? It's a purely autosomal recessive disorder, not caused by any other drug, but one thing which I have to mention, there are drugs which have similar effects as if Bartter syndrome is there, and these are loop diuretics. So if you give loop diuretics to a patient, they have the similar effect, because the loop diuretics are also doing the same thing. They are blocking this channel. This channel is blocked in Bartter syndrome as well as by the loop diuretics. But the point is, as soon as you discontinue the loop diuretics, the defect will be over. However, in case of Bartter syndrome, which is an autosomal recessive disorder, it will be a permanent problem. Okay, and this is what is written in the additional notes, that Bartter syndrome presents similarly to the chronic loop diuretic usage. It's an important point for you to remember, because the Bartter syndrome is affecting the same channel which is also affected by loop diuretics. So all clear, every single word explained about the Bartter syndrome. Let us now talk about the Gitelman syndrome. Now Gitelman syndrome, again try to remember this initial diagram जो मैंने start में we discussed this diagram, and this particular diagram nicely tells you that if there is a defect in the proximal convoluted tubule wala part, then this is called Fanconi syndrome. If there is a problem in the thick ascending loop of Henle, it is called the Bartter syndrome. Now if there is a problem in the distal convoluted tubule, this is what we call Gitelman syndrome, and that's what we are discussing now. The Gitelman syndrome, what is the defect? It is a reabsorption defect of what? Of sodium chloride in the distal convoluted tubule. Again, in order to understand this, you have to understand what was the normal physiology in the DCT, which is the distal convoluted tubule. You see, the one and very important channel that we discussed in the distal convoluted tubule was this thing, which has a co-transport ability to reabsorb sodium as well as chloride. So this channel is not working in the Gitelman syndrome. Okay, so no reabsorption of sodium and chloride in the distal convoluted tubule. Now keeping this in view, now let us try to understand each and every effect that we have to discuss here. Okay, so let's start with any one of them. Basically, let's talk about hypomagnesemia. Now what is also observed that in Gitelman syndrome, apart from the mutation and non-functioning attitude of this particular receptor, the magnesium receptor is also actually not working. So if the magnesium receptor is also concurrently not working, there will be no reabsorption of magnesium, leading to low magnesium levels in the blood, which is what we call hypomagnesemia. And actually this hypomagnesemia is a characteristic feature of Gitelman syndrome, because you will see that many of the features are very much overlapping between Bartter and Gitelman. For example, Bartter also has hypokalemia, Gitelman also has hypokalemia, and we will talk about the reason for Gitelman's hypokalemia in a minute. The differentiating features actually are hypocalciuria in Gitelman and hypercalciuria in Bartter, and we talked about the reason for hypercalciuria in Bartter. We will now talk about what is the reason for hypocalciuria in Gitelman, but let's go one by one. So hypomagnesemia, we discussed that there is also mutation in the magnesium receptor, so magnesium reabsorption is affected, therefore we lose magnesium in the urine, which means less magnesium in the blood. So is that clear to all of you? Hypomagnesemia. Now let's talk about the metabolic alkalosis. Now here the reason is actually the same as we discussed for the Bartter syndrome. See what is happening, that this receptor in Gitelman is affected, the sodium chloride channel, and when sodium chloride channel is affected, you are not reabsorbing sodium, which also means that you are actually excreting salt. So when you excrete salt, less salt is being reabsorbed, which means less concentration of sodium is reaching to the sensors, macula densa, remember? And if less sodium is reaching to the sensors, the system will start activating the renin-angiotensin-aldosterone pathway. And once this system is activated, what will happen in the proximal convoluted tubule, the angiotensin 2 will try to reabsorb sodium. In doing so, it will lose hydrogen, and if you are losing hydrogen, this is what we call the metabolic alkalosis. So metabolic alkalosis of Gitelman syndrome is also associated with decreased sodium reabsorption. So less sodium reabsorption, less sodium reaching to the collecting duct, and the activation of renin-angiotensin-aldosterone system, which leads to metabolic alkalosis. Same pathophysiology as we discussed in Bartter syndrome. So metabolic alkalosis is clear, hypomagnesemia is clear. Now let's talk about hypokalemia and hypocalciuria. So hypokalemia and hypocalciuria. So because there is a state of metabolic alkalosis which by itself leads to hypokalemia, so there will be a state of hypokalemia in Gitelman syndrome. And what happens with calcium? Listen to this carefully. See, the calcium in Gitelman syndrome is actually reabsorbed more into the blood. And why is so? This calcium is being filtered, and this is the urine side of the nephron. So this calcium is in the urine, and this channel is not working. We know that this channel is not working, the sodium chloride co-transport on the apical membrane towards the urine side, but this channel is working. What do you think? There is no mutation there. So if this sodium potassium ADP is working, it is getting sodium out and potassium in. So that is absolutely working fine. And because this is working fine and this channel is also working fine, what happens that there is a sodium gradient which is being developed outside the cell. This is what is happening, or you can say there is low sodium concentration inside the cell, and this is what the job of sodium potassium ADP is to create a lower gradient of sodium concentration within the cell. Now with this lower gradient, this particular channel, which is also a feature of the distal convoluted tubule, it tries to drive sodium back into the cell to make up for this lower concentration of sodium, and in order to do so, it releases a calcium into the interstitium. So that sodium calcium counter transport system is working, and therefore more and more calcium is reabsorbed from the urine into the interstitium. And since because this sodium potassium ADPase is continuously dropping down the concentration of sodium inside the cell, in order to maintain this sodium concentration, this pump gets in sodium but pushes out calcium. So more and more calcium is reabsorbed into the interstitium. So if more and more calcium is reabsorbed into the interstitium, less calcium is released into the urine, and therefore the condition of hypocalciuria. So is that all very clear to you now? It's simple stuff. All this can also be understood, or I should say only be understood, if you have a very good grasp on the normal physiology. So if, for example, you don't know what happens normally in distal convoluted tubule, I mean, forget about understanding Gitelman syndrome. You just cannot ratify or memorize all these things. Okay, metabolic alkalosis happens in this and acidosis happens. No, you have to learn the logics, and the logics can only be understood if you understand the physiology. Okay, Gitelman syndrome is also an autosomal recessive disorder, and the effects, just like when we were talking about Bartter syndrome, I told you that the effect of Bartter syndrome are actually same as those which are seen in the loop diuretics. Loop diuretics also block the same channel. Similarly, in the Gitelman syndrome, this is the channel which is affected, and this sodium chloride co-transport is affected also by the use of thiazide diuretics. So Gitelman is equal to as if you are using thiazide diuretics. Okay, and since there are so many similarities between Bartter and Gitelman, you see metabolic alkalosis in Bartter, you see metabolic alkalosis in Gitelman, you see hypokalemia in Bartter, you see hypokalemia in Gitelman. So there is an overlap of features. But remember that Gitelman is less severe than the Bartter syndrome. So in Bartter syndrome, you see more of the severe effects. Okay, so all terminology is clear. Fanconi syndrome, Bartter syndrome, Gitelman syndrome. Now let's move on to a problem which is usually seen in the collecting tubular system, which is the Liddle syndrome. Liddle syndrome, it is not little syndrome, okay? Many people say and write it like this. It's not little, it's Liddle syndrome. And what is the problem in Liddle syndrome? There is a gain of function mutation. Now, what does gain of function mutation basically means? The point is, if this is a cell and the job of the cell, for example, is to throw sodium in this direction and to get anything, say for example potassium in this direction, I'm just making up an example, and this channel has now a gain of function mutation. So a gain of function mutation will enhance, it will increase the job of this particular receptor, because this is gain of function. Functions will be gained. It will be performing more efficiently. So more and more sodium in this direction and more potassium in this direction. That is what we mean by gain of function mutation. And where is the mutation? That's in the collecting tubule. And what happens in the collecting tubule? You see, this is the collecting tubule, and the dynamics of the collecting tubule, you have to understand there are different types of cells there. There is a principal cell, there is an alpha intercalated cell, there is a beta intercalated cell. But there is a gain of function mutation for enhanced sodium reabsorption. Listen to this carefully. There is increased sodium reabsorption in the collecting tubule. So more and more sodium is reabsorbed. So look here, where is this sodium reabsorption channel? This is present right there in the principal cell. So in the principal cell of the collecting tubule, this sodium channel has now gain of function mutation, which means more and more sodium will be reabsorbed into the interstitium. So that's the pathological defect. So defect is very important to understand, because if you know the defect, now only you can understand what will be the effects, what happens because of this. So the defect is increased sodium reabsorption in the collecting tubule, and because of the increased sodium reabsorption, all these effects happen, including metabolic alkalosis, hypokalemia, hypertension, and decreased aldosterone. So let's try to make sense for all of them. Now, sodium is usually reabsorbed in the principal cells, and that happens in exchange for a potassium and hydrogen. So potassium as well as hydrogen are actually being exchanged for sodium to maintain the electrochemical gradient within the cell in the homeostatic limits. Now we are saying that there is gain of function mutation, so more sodium is being reabsorbed. By the virtue of the same token, it also means that more potassium and more hydrogen are lost. So if more hydrogen is being lost, this is what we call metabolic alkalosis. So there will be less hydrogen in the interstitium, so metabolic alkalosis. So that should explain metabolic alkalosis. And if more potassium is being lost, that will lead to hypokalemia in the blood. The concentration of potassium will be low. So just by the virtue of normal physiological understanding that sodium is reabsorbed by exchange with these two positive ions, you should be able to understand at least two of the effects of Liddle syndrome. There will be metabolic alkalosis because you are losing hydrogen. There will be hypokalemia because you are losing potassium. Hypertension, obviously, because you are absorbing more and more sodium. And who doesn't know that sodium ion concentration increased, it is associated with hypertension. And all of this will kind of, it will be suppressing the aldosterone. Because you know what is the job of aldosterone? The job of aldosterone is the same thing, to reabsorb sodium, to get rid of potassium. But that's under normal physiology. Now something else is doing the same job which aldosterone was supposed to do. But the point is, because somebody else is doing the same job, aldosterone in the body is shut off. So therefore aldosterone is shut down. Now Liddle syndrome is an autosomal dominant disorder. This is in contrast to the previous diseases that we discussed, which were autosomal recessive. Bartter and Gittelman both were autosomal recessive, but and the upcoming one is also autosomal recessive, which is same. The only autosomal dominant is Liddleman syndrome, and it present similarly to hyperaldosteronism, because if there is more aldosterone in the system, then this aldosterone is going to increase sodium reabsorption, and it's going to also enhance potassium excretion. Same thing. But aldosterone in this particular scenario is undetectable. So if you have to, so the patient comes to you and they explain all the features, that there is metabolic alkalosis, there is hypokalemia, there is hypertension, and then they are asking you what is the test to distinguish if it is hyperaldosteronism or if it is because of Liddle syndrome. So you order one single test, which is the levels of aldosterone. If aldosterone levels are high, that would mean hyperaldosteronism, that all these effects are because of high aldosterone levels. But if the lab values show that aldosterone levels are very, very low, that would mean that in the absence of aldosterone, somebody is doing the nasty stuff, and that may be Liddle syndrome. Okay, and that can also be a confusing stuff, because let's wait for the next disorder. It will also have a lot of overlapping features with Liddle syndrome, and there are a few other tests to identify if it's because of Liddle syndrome or because of same. But anyways, for now, Liddle syndrome is increased sodium reabsorption in the collecting tubule. All these effects we understood that how and what are the causes of these effects, why and how do these happen, why there is metabolic alkalosis, hypokalemia, hypertension, and decreased aldosterone. It's an autosomal dominant disorder, and all this is important discussion. What would be the treatment? So if you remember my nephron transport physiology video, we discussed about that this sodium channel in the principal cells of the collecting tubule can be negatively influenced by a couple of drugs such as amyloid, trimethoprim. So what is the problem in Liddle syndrome? The problem is overactivity of this channel, more and more sodium being reabsorbed. So if I want to inhibit this channel, let's use these drugs. So these drugs are an important treatment line for Liddle syndrome because they block the sodium channel. Okay, now the last one of the disorders is the same, which is called the syndrome of apparent mineralocorticoid excess. So as the name indicates, it's an apparent mineralocorticoid. It's not actual. There is a word which is actual, which means that mineralocorticoids are actually increased. But in this disorder, it seems like mineralocorticoids are increased, but there is no actual increase in the mineralocorticoid. Actually, what is the story? Let me tell you. Now, in your body, there is this little chemical which is known as cortisol. It activates mineralocorticoid receptors. So actually the receptors, they are supposed to be for the mineralocorticoid, but cortisol can also have an activation effect on the same receptor. So this receptor, I don't like this receptor because this is not purely committed to mineralocorticoid. It is also responding to cortisol. But anyways, this is how your body is. Cortisol can activate mineralocorticoid receptors. Okay, so park this information in your head, and we will then reconsolidate everything under the heading of same. So fact number one, cortisol can activate mineralocorticoid receptors. Fact number two is 11 beta HSD converts cortisol to cortisone, which inactive on these receptors. So that's a good thing in your body. See what's happening. So that's a receptor which is actually the mineralocorticoid receptor. It should only respond to mineralocorticoid, but there is a nasty molecule which is called cortisol. So this cortisol can also activate the mineralocorticoid receptor, but 11 beta HSD, another very loyal molecule, it does not like cortisol's action on mineralocorticoid receptor, so it blocks the activity of cortisol. So this is a good thing because it tries to maintain the loyalty and integrity of the mineralocorticoid receptor only to be activated by the mineralocorticoid. So cortisol is doing the nasty thing, inactivating something which has to be inactivated by mineralocorticoid receptor. So this cortisol is not doing a good job. I don't like this. And similarly, 11 beta HSD also does not like this. So it kind of inactivates the cortisol's activity by converting cortisol into cortisone. So that's the normal physiology. Fact number one, cortisol can activate the mineralocorticoid receptor, and fact number two, it does not allow cortisol to activate the mineralocorticoid receptor. Now if there is a mutation in 11 beta HSD, oh my god, if there is a mutation there is nobody to inhibit the cortisol's malintention, and cortisol will go and activate the mineralocorticoid receptor. So therefore, if the person has any mutation in 11 beta HSD, cortisol levels actually increase in the body because it's not degraded into cortisone, and because of the increased cortisol levels, this mineralocorticoid receptor becomes activated. And if this becomes activated, what will happen? All those things which were also seen kind of in the Liddle syndrome, because now think about the effects of aldosterone. What does aldosterone do? Aldosterone increases sodium reabsorption. that is the job of aldosterone. We discussed this in the nephron transport video, that aldosterone, the job of the aldosterone is to act on the mineralocorticoid receptor, but now somebody else is acting on the mineralocorticoid receptor. Who is that somebody else? That is cortisol. Why? Because 11 beta HSD is not there, and the job of 11 beta HSD was to stop this. If this is not there, nobody is there to stop this, and more action on the mineralocorticoid receptor. So more sodium reabsorption. So more sodium reabsorption, more potassium secretion, more hydrogen secretion. So if this will happen, similar effects will be noticed. There will be hypertension because of increased sodium reabsorption. There will be hypokalemia because in exchange for sodium, hydrogen and potassium are lost. So if potassium is lost, hypokalemia. If hydrogen is lost, metabolic alkalosis. Same story as we discussed in Liddle syndrome. Metabolic acidosis, hypokalemia and hypertension. Metabolic alkalosis, hyperkalemia and hypertension. What will happen to the levels of aldosterone? Well, this poor chap will be decreased levels, same as we notice in Liddle. Why? Because the job of the aldosterone was to actually activate this receptor. Now this receptor is automatically super activated because of cortisol. So it's a negative feedback loop. Hey aldosterone, you are no more needed because somebody else is doing your job. Not a nice story. So aldosterone levels will be down as well. Okay, so we can say that in the whole scenario, cortisol is trying to be same as aldosterone, although it's not the same, but this beautiful receptor which was supposed to be acted upon by aldosterone is now being acted upon by cortisol. So cortisol is acting same as the aldosterone. So is this all clear? Now what are the causes of same? It is an autosomal recessive disorder, can also be acquired particularly by using anything which destroys 11 beta hydroxysteroid dehydrogenase, such as the use of licorice. So licorice, if consumed in high amounts, can block the activity of 11 beta HSD, and if 11 beta HSD activity is blocked, cortisol levels are increased and the same is observed. Okay. Now, how would you treat this? What would be the treatment option for this? The treatment option for this is, what was the treatment option for Liddle syndrome? The Liddle syndrome, the problem was gain of function mutation here. So we had to block this receptor by using amyloid or trimethrin. Now, when we are talking about same, the problem is not actually this receptor. The problem is the mineralocorticoid receptor. And here what we can do is we can block mineralocorticoid receptor, and one option would be to use potassium sparing diuretics, which are actually mineralocorticoid receptor antagonists. So now here is the story. So understanding pharmacology, I am soon going to be starting also pharmacology videos so that you understand exactly how do drugs work, because many students are asking me, sir, please start pharmacology very soon. Okay, so this is the receptor, which is the mineralocorticoid receptor. Normally who acts on this receptor? Aldosterone. And now who is acting on this receptor? Cortisol. So what I would love to do is, what about if I use I pitch in another thing, which is the potassium sparing diuretics, examples being spironolactone, for example. So if I use those diuretics, they will come and occupy the mineralocorticoid receptor. Now aldosterone cannot work. This poor chap was not able to work anyways because cortisol was there. But now the good news is cortisol will also not be able to work on this receptor because potassium sparing diuretics have covered the receptor completely. Now cortisol cannot perform its action, and since cortisol cannot perform its action, that's what is required in this particular disorder, is stop the activity of cortisol. Therefore mineralocorticoid receptor is no more functional to the increased levels of cortisol. Okay, so you can use potassium, and why we call them potassium sparing diuretics, that's another next level discussion that we have actually done in my detailed video from Guyton. So these are the diuretics which increase the sodium excretion in the urine, but they on the same time do not affect potassium. Actually they increase the potassium concentration in the ECF, so increase ECF potassium, and therefore we are not losing potassium in the urine. That's why they are called potassium sparing diuretics. So the treatment for same would be potassium sparing diuretics, okay, or corticosteroids, exogenous corticosteroid. That's important. Exogenous corticosteroid would decrease the endogenous production of cortisol. Here is another way how you can treat the same problem. So the problem is increased level of cortisol. That's what the problem is. Okay. Now one way to do, and that's the best way. I like doing it this most of the times because potassium sparing diuretics, the whole receptor is blocked and cortisol cannot work. But what you can also do is you can give exogenous steroid, start steroid supplementation of the patient. So if the patient is taking steroid as tablets, this cortisol will be inhibited as for this is the normal mechanism. When you give exogenous steroid as a negative feedback loop, the endogenous production of cortisol decreases, and if endogenous production of cortisol decreases, you are good, because this was the problem. Now there is no increased level of cortisol and therefore no same disorder. Okay, so that's the end of this small table, but you realize how important the table was, and it is loaded with the concepts of renal physiology. It's very important that you first understand and master. I'm using the word master. You master the concept of renal transport, because if you do not understand renal transport, this particular diagram, you're not going to understand renal tubular defects. Okay, so 5 defects: Fanconi, Barter, Gittelman, Liddell, and Same. 5 different locations, 5 different mechanisms, 5 different effects, 5 different causes. I hope this is all now very clear to you. There is a little mnemonic here, which is Fanconi, but that's irrelevant because there's only 5 of them. It's not difficult to remember them.
The renin-angiotensin-aldosterone system, also called RAAS or RAS system. This is a key system in your body which is basically activated to restore the body volumes. So you have to think about this. First, you need to know what is the apparatus which releases all these important chemicals which are required for the activation of the system, and then you should know what are the stimuli. So let's first talk about this little apparatus. So this is the Bowman's capsule, this is the glomerulus, and the blood taking the vessel which is taking blood towards the glomerulus is the afferent arteriole, and the blood vessel which is exiting the glomerulus is the efferent arteriole. So and also in very close proximity to the glomerulus is the distal convoluted tubule, and within the distal convoluted tubule there are some specialized cells which are called macula densa. These macula densa cells are very important chemoreceptors which can actually detect the changes in levels or concentration of sodium which is delivered to the distal convoluted tubule. So these cells have the capacity to sense sodium basically. And then we have some specialized cells which are in close proximity to the afferent arteriole, and it is believed that these cells are actually modified version from this blood vessel, and these are called JG cells, juxtaglomerular cells. Now these are the cells which basically secrete a chemical which is known as renin, and this is activated, the release is increased by certain conditions. So for example, if there is reduced blood pressure in the body, if there is reduced sodium delivery to the macula densa cells. Now see, both these are actually telling the kidneys that the body has low blood pressure, the body has low volume status. So whenever there is low volume status in the body, the JG cell start releasing renin. And the third stimulus is the activity of the sympathetic system, beta 1 receptors through, and all these are very potent stimuli to the JG cells to release renin. And what is the job of renin? It basically converts angiotensinogen, which is released from the liver, into angiotensin 1, and then angiotensin 1 is acted upon by angiotensin converting enzyme which comes from kidney and lungs, and it converts angiotensin 1 to angiotensin 2. So the basic potent molecule which brings about all the actions, all the desired action, is actually angiotensin 2. But in order to get angiotensin 2, we need to have these stimuli and the release of renin. Renin converts, and you see the diversity of this system. So renin is coming from kidney, from the GG cells, and it is acting on angiotensinogen which is coming from liver, and then angiotensin 1 is produced which is acted upon by ACE which is coming from lungs, and after this reaction this also gives rise to bradykinin. So therefore and bradykinin is associated with cough when we use ACE inhibitor. This is something that we will talk about in pharmacology section. So right now just remember the pathway. Any of these stimuli, release of renin, angiotensinogen into angiotensin 1, angiotensin 1 into angiotensin 2 by ACE. And this angiotensin 2 has a very wide receptor base. So for example, it will work on the receptors on blood vessels, and it will cause vasoconstriction. And the net effect of vasoconstriction will be increased blood pressure, because you know that the blood pressure is a measure of cardiac output times the total peripheral resistance. So if there is vasoconstriction, the total peripheral resistance go high and the blood pressure go high. So that's one job done by angiotensin 2. It also preferentially constrict the efferent arteriole. So once the efferent arteriole is constricted, what will happen? There will be increase in the GFR. There will be filtration fraction of the kidney will be maintained. So basically it is to restore the filtration fraction of the kidney in hypovolemic situation. So it basically preserves the GFR when the renal blood flow is less. This is a very, very important renoprotective effect of angiotensin 2. It also works on kidney to, particularly at the level of proximal convoluted tubular cells, to reabsorb sodium and bicarb, and obviously along with sodium, water comes in. So see, here it is increasing the blood pressure, here it is increasing the sodium and water reabsorption. All efforts towards increasing the body volume, preservation of blood pressure, preservation of kidney functions. Okay, angiotensin 2 also has receptors on the hypothalamic tract and the adrenals. So it increases the secretion of ADH, which induces the expression of aquaporin channel, so more water reabsorption. And aldosterone, via aldosterone, what it does, it is doing multiple things. So for example, when we talk about the principal cells, it induces sodium reabsorption, and along with sodium, water comes in. Obviously we lose potassium and hydrogen because of this effect, but that's fine. We are happy to lose hydrogen and potassium, but we need water and sodium at this moment. So all these effects are doing one single thing. They are trying to increase sodium and water reabsorption. They are trying to restore blood pressure. They are trying to restore the volume. Because remember, the initial insult was low blood pressure, low sodium delivery here. So kidney thinks all the mechanism this way. So if there is any of these, low blood pressure, low sodium delivery, increased sympathetic system, kidney thinks, okay, there is hypovolemia in the body and the body needs my help. So kidney starts releasing renin, and all these effects try to bring back the arterial pressure. So that's a very easy concept, but very important for examination purposes. Okay, so if we dive down into one of them now, renin, I just told you it is secreted by the JG cells, and it is released in response to reduced renal perfusion, which means low blood pressure, increased sympathetic drive via B1 effect, and decreased sodium delivery to the macular densa cells in the distal convoluted tubule. ACE basically catalyzes the conversion of angiotensin 1 to angiotensin 2, which is the potent molecule. Okay. Now angiotensin 2, it helps maintain blood pressure by so many effects. All these effects are listed here. We just discussed about them. Atrial natriuretic peptide or the BNP, these are released from the atria and the ventricles in response to high volume, and they increase the sodium and water secretion. So that's what their job is. Okay, so they do everything opposite to what we just discussed. They are opposite to angiotensin 2, right? ADH and aldosterone, we have talked about them in other parts of this video. So ADH works on the collecting ducts to increase water reabsorption, and it is released when there is high osmolarity in the body. So there is high osmolarity, body needs water, ADH does that. Aldosterone primarily regulates the ECF volume and sodium content, so it increases sodium and water reabsorption and also releases a lot of potassium in the urine, so it causes hypokalemia basically. Okay, so easy stuff. Now I've already told you about what is JG apparatus. So whole this apparatus is known as JG apparatus. It consists of different components. So it contains JG cells, which I just told you are modified smooth muscles of the afferent arteriole. It also contains macula densa, which is the specialized sensors in the distal convoluted tubule. The JG cells secrete renin. Okay, and the macula densa cells, they sense sodium delivery to them. And JGA prevents short-term changes in the GFR. Now this is something that we have already talked about, that if this system was not there, then any blood pressure changes would have led to reduced GFR and reduced blood flow. So the system actually prevents it. Okay, Renin-angiotensin-aldosterone system, very, very important. Now, beta blockers reduces blood pressure by reducing the cardiac output and inhibiting the beta receptors at the GG cells. So there is reduced renin release. This is very important clinical correlate because beta blockers are commonly used drugs, and you should know that beta blockers will obviously block this activity. So they will reduce the release of renin. Okay, right. Now, some important endocrine functions of your kidney. Your kidney is not only filtering your blood, but it is also releasing some important stuff. For example, it releases erythropoietin, which is required for erythropoiesis. So erythropoietin, also abbreviated as EPO, it is released by the interstitial cells in the peritubular capillary bed in response to hypoxia. So if there is low oxygen levels, hypoxia, this is released. It stimulates RBC proliferation, and this happens at the level of the bone marrow. And this EPO is actually also administered for anemia purposes because it has direct effects on increasing the number of red blood cells. Okay, but it has a tendency to make you hypertensive, right? If you are at risk, not in everyone. So EPO released from kidney increases hematopoiesis. Then vitamin D. Proximal convoluted tubular cells convert 25-hydroxyvitamin D3 to 125-hydroxyvitamin D3. So this is a very important thing. Vitamin D3's metabolism is basically dependent on proximal convoluted tubular cells, right? And it therefore increases calcium absorption. So kidney has an important role to play in calcium absorption from the gut. And this is what happens in the kidney. So 25-hydroxy D3 is there is an additional hydroxylation at position 1 basically, and this is done by 1-alpha hydroxylase, which is present in the cells of proximal convoluted tubule, and it is augmented by parathyroid, right? Okay, then prostaglandins. Paracrine secretion vasodilate afferent arteriole. This I have already told you. Remember this PDA? So PDA is the prostaglandin dilate the afferent arteriole, and when the afferent arterioles are dilated, if you go back and look at this figure, what will happen? So if afferent arterioles are dilated, this will be dilated, right? So there will be increased blood flow, and there will be increased GFR, obviously increased GFR, but there will be no effect on filtration fraction. Remember, because filtration fraction is basically GFR divided by the blood flow. So since both of them are increasing, there will be no change. And NSAIDs will block this. So NSAIDs will block the production of prostaglandins, and obviously there will be then everything opposite: constriction of afferent arteriole and reduction in the GFR. Not good for the kidney, guys, because you don't want to give NSAIDs to your patients who have chronic kidney problems, because you give NSAIDs and their afferent arteriole starts constricting, and because of this constriction the GFR goes down. You don't want this to happen in your chronic kidney patients. Okay, now dopamine. So this is all that kidneys are actually releasing. Kidneys are releasing erythropoietin. They are releasing, actually not releasing, but metabolizing vitamin D. They are releasing prostaglandins and also dopamine. So dopamine is also released. It actually promotes natriuresis, increase sodium excretion. Okay, at low doses it dilates the interlobular arteries. Remember the structure. There is renal artery, then renal artery enters into segmental and whatnot. So at one stage there was interlobular arteries, and they also dilate the afferent arterioles and efferent arterioles as well. So there is increased renal blood flow and little or no change in the GFR basically. But this is at low doses. At high doses it can also constrict, because there are different receptors which are activated at different dosages. Okay, but these are different things which are released from kidney. Very, very important for you to understand. This particular diagram summarizes a lot of different discussion that we have previously done in this video. So basically the heading is hormones acting on the kidney, and for example we have already talked about angiotensin 2 in our previous discussion. We have talked about aldosterone and action of anti-diuretic hormones. So aldosterone, for example, is secreted whenever there is a thinking in the body that blood volume is going low. So whenever your body perceives low blood volume, it leads to secretion of aldosterone, and this aldosterone then perform some action. And what it does? It increases sodium reabsorption as well as increase potassium and hydrogen secretion. So this is something that we have already done when we were discussing the nephron physiology. We did the in detail discussion about what different parts of the nephron work in order to maintain the electrolytes and water in the body. So the function of aldosterone is to reabsorb sodium, and obviously along with sodium water comes in. So whenever there is a scenario in the body that there is reduced blood volume or increased plasma potassium, then the aldosterone is secreted. These are the stimuli for secretion of aldosterone, and in turn aldosterone starts increasing the reabsorption of sodium and water, and in replacement it loses potassium and hydrogen. So that should be very clear to you. Then you should know what is the job of antidiuretic hormone, when is it secreted, and what is the job of antidiuretic hormone. So it is secreted whenever there is high plasma osmolarity, because body thinks that there is less water and there is more solute, so we need more water. So in order to get more water, we release more ADH, and it increases the aquaporin channels, and therefore increased water reabsorption happens in the collecting duct. So this is something that we have already done. And angiotensin 2 is synthesized in response to low blood pressure. So you see, kidney is responding to various stimuli within the body. If kidney feels that there is low volume, this is one action which is happening. If kidney thinks there is high osmolarity, this is one action which is happening. Now this is also in response to low blood pressure, and so whenever this happens, there is increased angiotensin 2 release. So it is synthesized in response to low blood pressure, decreasing blood pressure, and it causes the efferent arteriole constriction. And we have discussed in detail that whenever efferent arteriole is constricted, there is increased GFR because of the back pressure and increased filtration fraction with compensatory sodium reabsorption as well in the proximal and distal nephron. Now, overall effect of angiotensin 2 would be to preserve the renal effective filtration fraction, because the kidney feels that there is low blood pressure, and then the filtration is going to be affected. So in order to restore the filtration fraction at the level of the glomerulus, efferent arteriole, so this part is constricted. Once this part is constricted, what happens that there is a backlocking of blood in the glomerulus, and there is more filtration. So basically the action of angiotensin 2 in this context is to maintain the filtration fraction even in the low volume state. So even when the blood pressure is low, there is a low volume state, the filtration fraction is being maintained, and you don't want this action to be blocked by using ACE inhibitors, obviously. Okay, now because this is renoprotective action, you see. Now, what is the job of parathyroid hormone? First, you should know what are the stimuli for secretion of parathyroid hormone. These hormones are released in response to decrease plasma concentration of calcium or increase phosphate levels. Also in response to decrease vitamin D3 levels. And what this hormone does is it increases, obviously it was released because of low concentration of calcium, so it increases calcium reabsorption. It increases vitamin D3 production as well, and it reduces phosphate absorption. Parathyroid hormone, so PTH, I always tell my students, is phosphate trashing hormone. So it trashes phosphate into the urine. It stops or reduces the reabsorption of phosphate. It increases the absorption of calcium. Okay, and this parathyroid, so these are the action of parathyroid on the nephron, but the parathyroid hormone is also very effective in increasing the phosphate and calcium absorption from the gut via vitamin D. So all these hormones also act on gut parathyroid bit. Atrial natriuretic peptide, so also known as abbreviated as ANP, it is secreted in response to increased arterial pressure, and it causes indirect afferent arteriole dilatation. So imagine when there is afferent arteriole dilatation, there will be increased GFR, there will be increased plasma flow, and then there will be increased sodium filtration with no compensatory sodium reabsorption. So net effect would be sodium loss. It reduces, it gets the body plasma, the blood plasma cleared of sodium. Okay, and along with sodium, you lose also volume because sodium reabsorption is associated with water reabsorption, and sodium loss is also associated with water loss, because that's the osmotic power of sodium. And imagine this is released in conditions when there is high blood pressure, so the body has to get rid of some of the solute in water to reduce the blood pressure down, right? So these are all the hormones that you have done already. We went through this very quickly because most of the relevant discussion has already been done, and then I don't need to repeat that there are different parts of the nephron. Here we are talking about Bowman capsule, then glomerulus afferent arteriole brings in the blood into the glomerulus, efferent arteriole takes the blood out. Then the nephron continues, and there is proximal convoluted tubule where most of the things are reabsorbed into the blood. All of the glucose, all of the amino acids, most of the other solutes. Then there is descending limb of loop of Henle, ascending limb of loop of Henle, which is notorious for reabsorbing sodium, potassium, and 2-chloride. Also not mentioned here in this diagram that this descending limb of loop of Henle is known for massive reabsorption of water, and it's impermeable to other things. So this is the concentrating segment, and this is the diluting segment of the nephron. Then comes the distal convoluted tubule, where you keep on reabsorbing sodium, also calcium. And then comes the collecting duct. At the level of the collecting duct, you maintain the levels of potassium hydrogen, and you also have receptors for action of aldosterone and antidiuretic hormone. So the point is that do not move forward unless you understand the whole page and the whole figure. That's the key to read first aid. In first aid, you have to understand each and every written word, otherwise you will be in trouble. Now, potassium shifts. Potassium is critically important because changes in the level of potassium have serious meaning to the patients. So therefore, in previous diagrams, I remember there were, in previous versions of the first aid, there was only a table which used to list that what are the factors which shift potassium into the cell and what are the factors which shift potassium out of the cell. But this is a nice diagrammatic representation. So let's talk about the factors which forces potassium to enter into the cell. So if this is the cell, what are the factors which pushes potassium into the cell? And also, let me tell you, if there are factors which are putting potassium into the cell, they will cause obviously reduced concentration of potassium outside, and this is something that we call hypokalemia. So hypokalemia is a situation which will be generated if potassium is pushed into the cell, and the converse will be true. So if potassium is forced out of the cell, obviously the concentration of potassium outside the cell will increase, and this is something that we call hyperkalemia. Okay, so shifting of potassium into the cell, which means hypokalemic situation, increase serum decrease serum osmolarity, so serum hypoosmolarity. What will happen if there is reduced serum osmolarity? Then what will happen, that water will move inside the cell, and along with water, potassium drags in. So this is the cell, for example, this is the plasma, and if the plasma osmolarity goes down, this means that there will be water drag inside the cell, and along with water, potassium will get in. So this is one thing, hypoosmolarity. Alkalemia, so alkaline situation in the plasma will also force potassium into the cell in exchange for hydrogen, obviously, because imagine if we have alkaline scenario here, what do we need outside? We need more and more hydrogen. So hydrogen comes out and potassium gets in. Okay, then the beta agonist and insulin, the job of insulin is to get potassium into the cells, and sodium gets out. The same is done also by the beta agonist. So remember these three factors which are very important, who push the potassium from outside the cell to inside the cell, and then the factors which are shifting potassium out of the cell. So obviously acidemia is one scenario. If there is a lot of hydrogen outside the cell, hydrogen wants to come in and potassium will get out. So because alkalemia was causing shift into the cell, acidemia, by virtue of just being opposite to alkalemia, this will push potassium outside the cell. And similarly, if we talked about, we didn't talk about this actually, cell lysis. Now, that our cells are bags containing a lot of different things concealed within the bag, and one of the things is potassium. So if because of any reason there is cell lysis. This can happen in infection, this can happen in tumor condition, tumor lysis syndrome. So if the cells burst, potassium will leak out. Okay. Succinylcholine can do this via sodium potassium exchange. Acidemia, we talked about it. Now beta agonist used to cause potassium entry into the cell. Beta blockers does the opposite. Okay. And also insulin forces potassium into the cell. Hypoinsulinemia, which means diabetes, gets it out of the cell. So this is a very nice diagram and very self-explanatory diagram which talks about what are the factors by which potassium is forced into the cell and what are the factors by which potassium moves out of the cell. Okay. Now very quickly, let's talk about some electrolytes and a very quick figure which I like very much. It's a very nice algorithm about acid-base disorders. Now electrolyte wise, you know the major electrolytes in the body, at the top being sodium. You should know what happens when there is low concentration of an electrolyte and what happens if there is a high concentration of an electrolyte. So let's begin our discussion with the sodium. If there is low sodium concentration, the symptoms include nausea, malaise, stupor, coma, and seizures. And high sodium is basically irritability, because the action potentials are, you are in a hyperexcitable state. So this is irritability, even stupidity, stupor, and coma. There is a lot of understanding and there is a lot of memorization in this table, but try linking all these signs and symptoms with your understanding of what is the normal sodium physiology. Okay. If you talk about potassium, if the levels are very high, then you have ECG changes, very, very serious, peaked T waves on ECG, arrhythmias can happen, muscle weakness and spasms can also happen in low potassium levels. Okay. And ECG changes are equivalent here and there as well, but there are obviously opposing patterns. So for example, if you have low serum levels of potassium, there is flattening of T waves and there is peak T waves in high potassium conditions. Then if you talk about calcium, low levels, tetany and seizures, and QT interval prolongation, muscle twitching. And you also have these joystick and trouser sign. You tap on the tendon and the muscles contract type of thing. If there is hypercalcemia, obviously it leads to stone formation, bones pain, abdominal pains, and disturbance in the urinary output because of stones sometimes, and psychiatric problems. If you have magnesium low and high levels and phosphate low and high levels, phosphate, for example, low levels of phosphate will lead to bone loss, because phosphate mineralization is a very important step of getting strong bones. So osteomalacia in adults and rickets in children, right? And if there are high levels of phosphate, can same as for as was true for calcium, they also leads to renal stone, also calcification in elsewhere in the body. And if the levels of phosphate are high, they will consume huge amount of calcium, leading to hypocalcemia. If magnesium levels are high, it can bradycardia, hypotension, hypocalcemia, cardiac arrest, and sometimes I mean, this is not extremely common scenario. The most commonly altered electrolytes are, for example, sodium, potassium, calcium, phosphate. But if magnesium is low, can lead to changes in ECG, hypokalemia, which itself have cardiac effects, hypocalcemia, and tetany considered along with hypocalcemia. So that's an important table. Now, the point is that each one of the ions listed here, each one of the electrolytes listed here, they have their own detailed physiology. So you should know how sodium is handled in the body, how potassium is handled in the body, what is the role of, for example, sodium and potassium and calcium in action potential, in cardiac action potential, in smooth muscle action potential. So that understanding is basically required to understand this whole table, right? Okay, let's now, I have to discuss this table, but before that, let's go through this beautiful, lovely diagram very quickly again. And this is one of the things which will be coming again and again in different aspects of first aid. But here, the purpose is to make you understand that how do you approach a patient who has changes in pH. So normal pH level, and if the pH level is less than 7.35, you label this as acidemia. If the pH level is more than 7.4, you call it alkalemia. So simply, if you have to divide the patient into if the patient is having acidemia or alkalemia, you look at the pH. Now, after looking at the pH, If the pH is less than 7.35, you decide that the patient has acidemia. Now you have to decide if this is a respiratory acidemia, respiratory acidosis, or metabolic acidosis. And the way to do this would be check the levels of carbon dioxide. If the carbon dioxide levels are more than 44, now this would mean that the person has a lot of carbon dioxide in the body. When you think that the person has a lot of carbon dioxide in the body, obviously this carbon dioxide will combine with water and it will lead to the formation of carbonic acid, H2CO3. So this is the acid, so therefore this is acidosis, and this is because of a lot of carbon dioxide. So therefore you label this as respiratory acidosis. Respiratory acidosis basically means high levels of carbon dioxide leading to a reduction in the pH value. So if the pH value is lowered because of high carbon dioxide, you call it respiratory acidosis. Now think about it. Usually you exhale carbon dioxide, but any condition in which you are unable to inhale carbon dioxide, this carbon dioxide will be accumulated in the body, and the body will be in a condition of respiratory acidosis. Now this is called hypoventilation. You are not ventilating appropriately to release carbon dioxide, so this will accumulate carbon dioxide in the body. So any lung disease, chronic lung disease, weakening of the respiratory muscle, airway obstruction, all these scenarios, your respiratory system is not working fine. Okay, another cause of acidosis could be reduced levels of bicarbonate. So maybe from the kidney you are losing a lot of bicarbonate in the urine because of any reason. So if you lose a lot of bicarbonate in the urine, for example, your bicarbonate levels in the blood go below 20 milliequivalents. This is what is called metabolic acidosis. It is still acidosis because the pH is less than 7.35. It is still acidosis because the levels of bicarbs are low. Bicarb is the buffering base for acids. So if the levels of bicarb are low and the acidosis is because of reduction in the bicarb level, this is called metabolic acidosis. Now you have to check what is the anion gap. And the way to do anion gap analysis is simply look at the plasma sodium concentration and chloride in bicarb. Add chloride in bicarb, subtract it from sodium concentration, and you get the anion gap. If it is more than 12, you call it increased anion gap type of metabolic acidosis. If it is between 8 to 12, it is called normal anion gap type of metabolic acidosis. Now, if it is increased anion gap type of metabolic acidosis, simply means that there are more acids coming into the blood, and those are contributing towards this low pH. And those acidic scenarios could be from aspirin, from renal failure. You are accumulating different acids. Ketone bodies are acidotic. L-lactate, D-lactate, methanol, any other alcohols can be doing the same thing as well, glycols. So there are additional acids into the system. And if the anion gap is normal, then you think about some drugs basically, or some kidney problems, or loss via the GI tract, all listed causes here. So that's how you drill down a patient with acidosis. Let me do this one more time with you. So let's go through this one more time very, very quickly, right? So we are discussing how to drill down the patients with acidosis and alkalosis. So the first thing to do would be to check the pH value, and the pH, if less than 7.35, this is acidosis. Check the levels of carbon dioxide. If more than 44, label this as respiratory acidosis, and the levels are high, perhaps because of hypoventilation. And lung causes are the ones to be considered. If the levels of bicarb, say for example the level of carbon dioxide is normal, and you see lowering of the bicarb level, you call it metabolic acidosis. Check the anion gap. If it is high, there are additional acids. If it's normal, then think of all these causes: drugs, kidney problems, GI problems. Okay, right. Now, on the other hand, if the pH value is more than 7.45, you call this alkalosis. Again, you check the levels of bicarb and carbon dioxide. If the carbon dioxide is less than 36, this means that the person is hyperventilating. So this is the person having increased rate of respiration, for example. So getting rid of a lot of carbon dioxide. So the body carbon dioxide levels go down. If this is the cause of alkalosis, this is called respiratory alkalosis. Hyperventilation can be because of anxiety, tumors, pulmonary embolism, pregnancy, when you are angry. All these things can lead to hyperventilation and low levels of carbon dioxide and alkalosis. If the levels of bicarb are instead very high, more than 28, then you have to check the urine chloride levels. If more than 20, then you have to consider all these causes, and we have actually talked about these when we were doing the renal tubular defects. Okay, now there is always a compensatory mechanism as well. So for example, let's talk about this. If we have metabolic acidosis, so the pH is low and there is bicarb low, there is metabolic acidosis, so the respiratory system tries to help the body. It tries to help the body. There is acidosis, so there is decreased pH. What the respiratory system does is hyperventilates. So when it hyperventilates, it releases a lot of carbon dioxide. So the levels of carbon dioxide in the blood goes down, and when the levels of carbon dioxide in the blood goes down, the levels of carbonic acid go down. Or the other way to say this would be the levels of bicarbonate goes up. Why? Because the carbonic acid is broken down into hydrogen ion and bicarb ion. So once these levels, the carbonic acid levels go down, simply the bicarb is more available to help this person. The levels of bicarb are in this particular condition very important, and the levels of bicarbonate are important because the scenario is acidotic scenario, and bicarb can be available to help this. But the overall situation is that there is reduced pH, and because this is metabolic, there is reduced bicarb, there will be hyperventilation to get rid of the carbon dioxide, to get rid of the carbonic acid. So the PCO2 will go down because of hyperventilation. Now, if there is metabolic alkalosis, you should be able to work through this complete table, okay? So let's read the first line. Metabolic acidosis, low pH and low bicarb. That's why it is called metabolic acidosis. This low carbon dioxide is the compensatory response because of hyperventilation, and this happens immediately. The respiratory system responds very quickly. If there is metabolic alkalosis, the pH will be high and the levels of bicarb will be high as well. Now your body has alkalotic environment, so the person will hypoventilate, release less amount of carbon dioxide, so that carbon dioxide stays within the body and you get more carbonic acid, so that alkalotic pH is then balanced. So the compensatory response of your body will be hypoventilation, retain carbon dioxide within the body. If we are talking about respiratory acidosis, there is obviously acidosis, so reduced pH, and there will be more carbon dioxide in the body. The person is hypoventilating, so kidney will start absorbing bicarb more. That will be the response from kidney, compensatory increase in bicarb. But anything coming from kidney is a delayed response. Kidneys take time to respond. And then if you talk about respiratory alkalosis, then it simply means that you have high pH because this is alkalosis, and you have low carbon dioxide. The person is hyperventilating. So kidney will try to increase the excretion of bicarb. So low compensatory bicarb levels. Okay. So that's an important table to understand, and I hope you do, because if you don't, then that's a problem, guys. Right. So this is all done, and now that takes me to the next topic, which is actually very important for exam, the renal tubular acidosis.
So this is basically mishandling of the renal tubular system for hydrogen and bicarbonate system. So if we have, by virtue of any defect, if there is decreased bicarbonate absorption into the body, decreased bicarbonate absorption would mean increasing acidic environment. So that is what we call acidosis. So whenever we have either increased acids in the body or decreased alkalis in the body, so bicarbonate is one of the alkali. So if the levels of bicarbonates go down in the blood, we call this acidosis. Now this acidosis can be because of so many different reasons. Today we are going to discuss the reasons which are associated with nephron. All the reasons which are associated with nephrons are listed here, and these tubular acidosis, these pathologies are divided into three categories, which are called renal tubular acidosis type 1, renal tubular acidosis type 2, and renal tubular acidosis type 4. There is no type 3, and there is a reason for that. So try to find out that reason. If you are unable to find that reason, buzz me, text me, I'll let you know. So for each of the renal tubular acidosis, you have to master what is the defect. For example, in RTA1, what is the problem? Where is the defect? Then we have to talk about what happens to the urine pH in particular RTA. What happens to serum potassium level? What are the causes of each one of the RTA? And what are the important associations? So if you cover these 5-6 headings, then you are good. But my message to all my students is that you should be able to understand what is written here. See, the way to read first aid is to read and understand. I would bold and highlight in italic the word understand. To understand each and every single word written on first aid. Because first aid is like Bible for USMLE STEP1 these days. It's just a pass-fail examination. So a very good learning tool is first aid. But first aid is a difficult book to study because many people try to just study first aid and try to ratify and try to memorize first aid. But this is just impossible without understanding. So my job as a teacher here to make you understand what is written in first aid. So let's begin with the proximal renal tubular acidosis type 2 first, and then we'll jump on to 1 and then ultimately RTA4. So let's begin. And why I'm actually going with this sequence, because proximal renal tubular acidosis happens in the proximal convoluted tubule. And if you know the nephron, there is Bowman capsule, then proximal convoluted tubule, then loop of Henle, then distal tubule and collecting duct. So the renal tubular defects in the proximal convoluted tubule are actually called RTA2, but they appear first because PCT appears before then loop of Henle and distal convoluted tubule and the collecting duct. So anyways, whichever we study first doesn't really matter. So let's begin with RTA type 2. Let us now focus on the findings of the renal tubular acidosis type 2, which is because of the defect in the proximal renal tubular system. Okay, so you're very well aware, I have now repeated this so many times, that renal tubular acidosis type 2 is linked with proximal convoluted tubule, and the basic defect is the bicarbonate reabsorption. Now if I take you back here, this is the machinery which explains the renal tubular acidosis type 2. Here we are looking at a proximal convoluted tubule, and the basic diagram shows that on the luminal side, which means on the urine side of this cell, there is a sodium hydrogen antiport transport channel protein. So the job of the protein is to reabsorb sodium from the urine into the cell, and this is happening in exchange of a hydrogen ion. So this is a normal routine physiological stuff happening in the body all the time. This hydrogen ion, which is excreted out into the urine, usually combines with a bicarbonate, which is also filtered from the glomerulus, and as a result they make the carbonic acid. The carbonic acid is then broken down into carbon dioxide and water, which is what is reabsorbed, the carbon dioxide particularly, into the proximal convoluted tubular cell. And inside the cell, the carbon dioxide again combines with water, leads to formation of carbonic acid, breaks down again in hydrogen and bicarbonate ion, and this bicarbonate is reabsorbed. See, this is the beauty. We have discussed this already in the nephron transport system, that the bicarbonate which is filtered from the glomerulus cannot be directly reabsorbed through the luminal membrane of the proximal convoluted cell. Therefore, since it cannot be reabsorbed directly, it takes another route. It combines with the secreted hydrogen, makes carbonic acid, broken down into carbon dioxide and water, and the carbon dioxide getting into the cell then reverse engineer itself to the generation of bicarbonate ion, which is then reabsorbed. So the theory is that for every hydrogen ion which is secreted into the urine, there is reabsorption of a bicarbonate ion, and that's happening normally. But when we talk about the RTA type 2, what happens? Two things happen. Number one, this reabsorption of bicarbonate is blocked. So when I say the reabsorption of bicarbonate is blocked, what would that mean? That simply means that the bicarbonate level in the blood, because this is the interstitium side or the blood side of the renal proximal convoluted tubular cell. So if there is decreased bicarbonate reabsorption, the levels of bicarbonate in the blood will go down. And in the blood there are two things. There are acidic things and then there are basic things. If you reduce the level of basic stuff, obviously the acidic stuff will go up, and this is why we call this acidosis, renal tubular acidosis. Why? Because, and that's the reason number one, that the reabsorption of bicarbonate at the interstitial side is simply blocked. The channel is blocked, and if this channel is blocked, then there is no more reabsorption of bicarbonate from the cell into the blood. Thus the level of bicarbonate in the blood go down, and since the level go down, it leads to acidosis. Well, that's a simple theory. Okay, so that is the defect. The defect in the renal tubular acidosis type 2 is the bicarbonate reabsorption, as a result of which there is more and more bicarbonate excreted out in the urine. So the urine becomes basic. Urine becomes obviously basic, okay, because there is more and more bicarbonate being excreted. Why is it being excreted? Because it is not being reabsorbed. Okay, is that very clear? Also, it has been reported that this particular channel is also blocked either fully or partially in RTA type 2. So this channel is also blocked. If this channel is blocked, there is no exchange for sodium and hydrogen, and that is one of the reason. If this channel is blocked, sodium entry into the cell will be reduced, and if sodium entry into the cell is reduced, that's a problem. Then the Renin-angiotensin-aldosterone system will be activated. You know that, and when that system is activated, the aldosterone will try to get more and more sodium into the body and more potassium out of the body, and this is why in RTA type 2 the serum potassium levels go down. So that is because of secondary hyperaldosteronism. Okay, so that's the reason. Now if we talk about the bicarbonate concentration in the urine, what will happen? It will obviously be increased because you are not able to reabsorb it. So if you're not able to reabsorb the bicarbonate, it is obviously going to get out in the urine, so it will go in the urine, excreted out. Okay, now there are some cells in your nephron which release quite a lot of hydrogen into the urine, and those cells are located in the alpha intercalated cell collecting duct. You know that. Now these cells, they secrete large quantities of hydrogen ion into the urine directly through the hydrogen ADPase, also through the hydrogen potassium counter transport. The end result is a lot of hydrogen in the urine. Now this hydrogen tries to balance out this bicarbonate which is coming in the urine in increased concentration because of the defects in the proximal convoluted tubular cell. So because there is a defect of reabsorption of bicarbonate in the PCT, we have a lot of bicarbonate in the urine, but this bicarbonate in the urine is titrated by the hydrogen which are excreted by the alpha intercalated cell. So they try to cope up with the increased number of bicarbonate ions. They try to titrate them, but obviously there is a threshold. So after one limit, there is so much bicarbonate in the urine that some of the hydrogen ion can actually titrate it, but once the hydrogen ion are also saturated, the intercalated cells are saturated, then the pH of the urine, it go really high because of the bicarbonate. Therefore you see what happens to the urine pH in RTA type 2. It is lower than 5.5. but then it becomes higher than 5.5 when filtered bicarbonate exceeds the resorptive threshold. So these alpha intercalated cell, they secrete hydrogen ion which try to titrate the bicarbonate. Unless they are titrating the bicarbonate, to the time till which they are titrating the bicarbonate, the urine pH remains a little acidic, less than 5.5. But once the hydrogen ion concentrations are also saturated, then the bicarbonate numbers are very high, as a result of which the pH is more than 5.5. So in RTA type 2, it depends that how much bicarbonate one is excreting in the urine. If it's a really high number, then ultimately it will be the urine pH will be more than 5.5. Okay, so I'm trying to explain each and every line to you. So now you understand in RTA type 2, the defect is in the bicarbonate reabsorption, as a result of which there is increased bicarbonate in the urine. Obviously metabolic acidosis, because you are not able to absorb bicarbonate. So if you have less basic thing, then you have acidosis. So there is metabolic acidosis. Urine can be acidified by alpha intercalated cells, because the alpha intercalated cells release a large amount of hydrogen ion into the urine. So urine is being acidified by these cells, but not enough to overcome the increased bicarbonate. But these hydrogen ion, these poor little hydrogen ions, at one point they become saturated, and we still have higher bicarbonate concentration, as a result of which they are no more titrated and the urinary pH go basic. Okay, so far so good. I already had a comment on why the serum levels are low. That's usually because of secondary hyperaldosteronism. What are the common causes of RTA type 2? It usually happens in Fanconi syndrome, which is a generalized problem of reabsorption of a lot of things in the proximal convoluted tubule. An example of this is problems in phosphate reabsorption, for example, which leads to hypophosphatemic rickets. So these patients who are RTA type 2 patients also have Fanconi syndrome, may present to you with rickets actually, and then when you read the question properly, the question may take you towards the diagnosis of Fanconi syndrome and ultimately to RTA type 2. So my job for the first 8 series at Dr. Asif lecture is to make you understand each and every single line written on each and every single page, because if you do it this way, then you are good for your USMLE MRCP exams. Okay, so Fanconi syndrome is the most common cause for RTA type 2, and there are some other diseases associated with RTA 2, including multiple myeloma as well as carbonic anhydrase inhibitor, because they do the same job as reduced bicarbonate absorption. So this figure should be all clear to you, all this text should be all clear to you. So we are done with RTA type 2. Let's talk about another RTA. So let us talk about the concepts associated with RTA type 1, which is the defect in the distal renal tubular part of the nephron. Therefore it is called distal renal tubular acidosis. So basically the defect lies in the intercalated cell, alpha intercalated cell, which normally secretes a lot of hydrogen ions into the urine. So there is now ban of secretion of hydrogen ions. So hydrogen ions are not secreted into the urine because alpha intercalated cells are not doing this, and as a result of this there is no new bicarbonate generated and reabsorbed into the blood, thus leading to metabolic acidosis. So if you look at the diagram here, this is a simple diagram showing physiological steps associated with the alpha intercalated cell. So what actually happens that the carbon dioxide and water combines together to form carbonic acid, which then breaks down into hydrogen. Now this hydrogen gets out into the urine. This is the urine side of the cell. This hydrogen gets out into the urine, number one by this hydrogen ATPase, and number two by this hydrogen potassium antipode or counter transport system. So these are the two routes by which the hydrogen generated in the alpha intercalated cell is secreted out into the urine. Okay, now what happens in RTA type 1, that this receptor is not working, therefore the alpha intercalated cells are not able to secrete this hydrogen ion. Since this hydrogen ion is not being able to be secreted out, what happens that the pH of the urine goes up, because by virtue of secretion of this hydrogen ion into the urine was being acidified. Now no hydrogen being added into the urine goes basic, and therefore if you see the urinary pH goes more than 5.5. Okay, so you now get the concept. What is the defect? The defect is here abnormality, problems in the secretion of hydrogen ion from the alpha intercalated cell into the urine. So since hydrogen is not being added into the urine, that also means that bicarbonate is not being added. There is also literature reported that there are defects in this bicarbonate reabsorptive channel as well, because when the carbonic acid is broken down into hydrogen and bicarbonate, hydrogen gets out towards the urine side via these two receptors, and the bicarbonate which is generated is reabsorbed into the blood by this bicarbonate chloride counter transport system. So this is also not working. If this is not working, we are not adding bicarbonate into the blood. So in the blood the levels of bicarbonate go down, which is equal to acidosis. So now each and every word should make sense to you. There is problem in the alpha intercalated cell, inability of these cells to secrete hydrogen, no bicarbonate added into the blood, and metabolic acidosis. You have now the idea why we are saying that there is increased urinary pH of 5.5, because more than 5.5 actually, because the urine is not being acidified. What do we mean by acidification of urine? Addition of hydrogen ion into the urine is called acidification. Now this is not happening because the receptor is not working, and since the urine is not being acidified, the pH of the urine goes more than 5.5. So that's the simple story. Okay, so far so good. Now what's happening to the serum potassium level? It's decreasing, and that you should be able to interpret directly. Look at here. See, this hydrogen is getting out into the urine in exchange of what? In exchange for potassium. So if this channel is also not working, hydrogen is not getting out and potassium is not getting in. If we are not reabsorbing potassium, the levels of potassium in the blood are obviously going to go down. So this RTA type 1 is also associated with hypokalemia. Hypokalemia because this exchange protein for hydrogen is not working. No hydrogen going out in the urine, no potassium getting reabsorbed into the alpha intercalate cells, okay, and therefore because of decreased reabsorption of potassium, decreased potassium levels in the blood, called hypokalemia. So far so good. So you should be able to memorize all these things and actually understand all these things. You cannot simply ratify them, it will not make sense. Now what are the causes associated with RTA type 1? The main causes actually are autoimmune disorders including SLE as well as Sjogren's syndrome. These are very common causes of RTA type 1. Also associated with the congenital anomalies which leads to obstruction of urinary tract, amphotericin B toxicity, analgesic nephropathy. All these you must be remembering. And other associations that you should know: increased risk of calcium phosphate kidney stone, so that's important. And in the word stone, what do we also see is 1, so that is RTA 1 associated with STO1. Stones are associated with RTA1. That's important. And the reason for this is increased urinary pH is a risk factor for formation of stones. And there is also increased bone turnover because of the buffering capacity of the bones. That is something that we will discuss in more detail when we talk about the physiology related to bone and the kidney. How do they function in synchronization together? But for now, just remember RTA1 is associated with stone formation. Okay, very important stuff. So all clear. I am trying to look if I have left any single word on the description of the RTA1. We talked about the defect, we talked about the urinary pH and the concept, we talked about the serum potassium levels and the causes and some important associations. Okay, when we talk about RTA type 4, this is primarily because of either deficiency in the aldosterone, which is called hypoaldosteronism, or if there is enough aldosterone present, maybe the receptors for aldosterone are not working, which is what we call the aldosterone resistance. It's something like diabetes. Diabetes is either because of decreased insulin, so there is no insulin around, or there is insulin resistance. So insulin is there, but the receptors are not ready to bind to the insulin, which is what we call the insulin resistance. So similarly, the defect in RTA4 is either reduced level of aldosterone, or if the levels of aldosterone are there, there may be resistance to aldosterone. Now you should be able to recapitulate from my previous lectures that what is the job of aldosterone. You know that aldosterone works at different levels in the nephron. Number one, its job is to increase the activity of the sodium potassium ADPase. So sodium potassium ADPase is known for getting 3 sodium out of the cell and 2 potassium into the cell. So that is the job of the sodium potassium ADPase. If this is blocked, this normal exchange will not happen and potassium will not enter into these cells, therefore leading to increased potassium concentration in the blood. So just by the fact that sodium potassium ATPase will not be working, there will be high potassium concentration in the blood, and this is why RTA4 is associated with serum potassium levels high, and that's the only RTA which has high serum levels of potassium, which is what we call hyperkalemia. So in the rest of the RTAs 1 and 2, there were decreased levels of potassium, hypokalemia, for different reasons as we discussed. But in RTA4 there is hyperkalemia for the reason that potassium is not being entering into the renal tubular cells, and therefore it is not being secreted out. Also, when there is no aldosterone, alpha intercalated hydrogen potassium ADPase is not working properly, which would mean that hydrogen ions are not being excreted into the urine, which would also mean that there will be increase in hydrogen ion concentration within the cells, and this hydrogen can leak back into the interstitium, leading to acidosis. And that's what we are discussing: hyperkalemic because there is hyperkalemia, tubular acidosis. Now also, because the aldosterone system is not working, the hydrogen ions are not being excreted into the urine. What happens that there are different jobs of hydrogen ion. So hydrogen ion gets out in the urine, and by virtue of this fact, bicarbonate is reabsorbed. So this is one good property of hydrogen ion, that whenever one hydrogen is secreted in the urine, one bicarb is reabsorbed. Another job of hydrogen ion is to combine with ammonia, and as a result, ammonium ion is produced. So now we have disturbances in the secretion of hydrogen ion, so there will be decreased levels of ammonium ion production as well, which is what is written here, that because of hypoaldosteronism or aldosterone resistance, number one, there will be hyperkalemia. You now know why. There will be decreased ammonia and ammonium production because hydrogen is not being secreted. Now the urine pH really will be variable. Sometimes it becomes acidic, sometimes basic, depending upon how different other parts of the nephron are actually working. Serum potassium level, high levels of potassium, we discussed why. What are the causes which lead to RTF4? All those causes which are associated with reduced aldosterone production, such as diabetes, such as ACE inhibitors, use of ACE inhibitors, angiotensin receptor blockers, ARBs, NSAIDs, cyclosporine, adrenal insufficiency. All these are different causes of reduced aldosterone production. Or there can be aldosterone resistance, such as when we use potassium sparing diuretics, when we use trimethoprim sulfamethoxazole, when we have nephropathy due to obstruction. So all these causes are either linked to low production of aldosterone or aldosterone resistance. Okay, is there any other association? Empty box. So that's all about RTA4. So that's basically all about renal tubular acidosis. See, the important point to remember in RTAs is the fact that these headings in the first column, you should be clear about all of them. What is the defect in each one of them? What happens to the urine pH and why? What happens to the serum potassium? What are the causes of each one of these acidotic type of conditions? What are different associations which are notorious for each one of them? So if you cover all these headings, defects, urine pH, serum potassium, causes and association, more than 99% of the questions you will be handling right in your USMLE or MRCP or FCPS examinations. But please try to build concepts. If you try to ratify whatever is written in first aid, it's not going to help, because in exams they twist the questions, they give you the scenarios, and only if you have good concepts, if you have these diagrams understood. See what I'm doing for you in these first aid videos. I'm trying to explain each and every single word. I'm trying not to leave any single line, any single word, so that you have good concepts. If there is decreased ammonium written here, I would try to explain why it is written here. If they talk about decreased bicarbonate here, I would have explained why low bicarbonate is there. So I'm trying to do my best. Now the rest is up to you. You have to watch this video with full sincerity so that you have clarity for your examinations. Okay,
let us now start the renal pathology section from first aid, and I'm sure you know and appreciate the importance of pathology in USMLE STEP1 examination. So this is by and large the most talked about section of every module. So let's talk about the pathology of renal module. So first thing first, a very important clue in the examination can be the presence of cast in the urine. Now the concept of cast goes like this. Actually, let me change the color. I like blue more giving the lecture. So the concept of the cast is something like this. So say for example, this is your Bowman capsule, and then this is the Bowman space, and then we have proximal convoluted tubule, and then the loop of Henle, and then so on and so forth. So imagine there is any damage in the, and here would be the glomeruli. So let me draw the glomeruli in red. So that's an afferent arteriole, this is the glomerulus, and this is the efferent arteriole. So now imagine there is any damage to the glomerular basement membrane, for example, or any damage to this filtration barrier. So what would happen? There would be leakage of stuff, and one of the things which will leak is obviously the red blood cells. So red blood cells will kind of accumulate here in the tubule, and they would be casted in the shape of a tubule. So that is what we call a red blood cell cast, and this can get out in the urine. So in the urine you will see a cast which contains red blood cells. So that's the kind of concept of the cast, okay? And this is very important because different type of cast gives you impression of different type of etiology of renal disorders, okay? So presence of cast in the urine indicates that hematuria or pyuria is of glomerular origin or renal tubular origin. Obviously the cast will be formed only in a few scenarios basically. So if there is anything filtering from here, so for example if red blood cells are filtering, they will be forming a cast here known as the red blood cell cast. White blood cells will be coming known as the white blood cell cast, and there can be another scenario. So you know this tubular epithelium is a complete continuous lining here on the renal tubule. So if for any reason there is an injury to the say for example proximal convoluted tubule, these cells will slough off, and once they slough off they will also be accumulated within the tubular lumen, and now they will cause they will make a granular cast is what we call them, or epithelial cast. So this cast will be composed of, and you see that in the urine, there will be a cast composing of the renal tubular epithelial cell. So now you have an idea that cast can either be because of the problems in filtration, or it can be either because of damage to the tubular epithelial cell. So it shows either glomerular origin pathology or renal tubular origin pathology, okay? Now so for example there may be instances in the exam when you have to differentiate them from some other pathology. So for example if there are kidney stones blocking the ureter, you will still see hematuria in these patients, but there will be no cast, because cast can only be seen if there is a glomerular problem or a tubular problem. Similarly, if there is a patient with cancer, for example bladder cancer, you will still see hematuria but no cast formation. So presence and absence of cast in the urine is very important information in your examination, okay? Similarly, acute cystitis. Cystitis is the inflammation of the bladder, and in the bladder, if there is inflammation, you may still see urine filled with blood. So hematuria can be there, pyuria can be there, pus in the urine, but there will be no cast, because cast is associated with either glomerular issue or tubular issue. Okay, all cast contains a matrix composed primarily of the TAM-Horsfall mucoprotein. So that's a mucoprotein which gels together by the cells, whichever are these. So for example, it's something like you make different shapes using plaster of Paris. You used to do this in your school times, didn't you? So in a very similar way, that's the mucoprotein in your body, which then gels up all the cells and make the casts. Okay, now there are different types of cast, and if they talk about red blood cell cast, that would indicate there is a glomerular damage, or it can also be during hypertensive emergencies. So obviously this will be linked with very high blood pressure in the examination. If you see WBC cast in the urine, and this is how the red blood cell cast look like. So there's a cast composing of red blood cells. Then the WBC casts are indicative of tubulointerstitial inflammation, acute pyelonephritis, or transplant rejection. All are immune mediated stuff, and they all indicate the scenarios where the WBCs will be leaking into the tubular epithelium, into the tubular lumen. Then there are granular casts. These are because of the damage of the epithelial lining, and that can happen in acute tubular necrosis. We'll study them, cumulative causes of ATN, in the upcoming few minutes. Then there can be fatty cast, which is composed of fats, okay? Can be seen in nephrotic syndrome, because in nephrotic syndrome you have hyperlipidemia, and we'll talk about them in a minute, and they're associated with Maltese cross sign. Beautiful. I like this one the most. You see the Maltese cross sign. Wow. So I mean, literally you see them like this in the urine. There's one of the things which I like. I mean, not for the patient, but it's a very nice aesthetic look actually. Now we can also see hyaline cast, which are like glassy appearance, and they can be very non-specific. They can be a normal finding even with dehydration, heavy exercise, or if somebody is taking diuretics. So I would say this is a very important high yield thing to understand, how casts are made and what are the different types of casts. So this concept stays high yield, okay? Then when we talk about Nephrotic and Nephritic syndrome in the next few minutes, we will be using a few terms. for which you have to be very clear about, and you should know what is the nomenclature. So the nomenclature of glomerular disorders, when we use the word focal, so focal basically means that less than 50% of glomeruli in a kidney are involved. So you know that kidney is composed of like millions of glomeruli, and if only less than 50% of them are involved, this is what we call focal disease. Okay, I'll skip these examples for now because we are going to discuss them in detail. But have a look that focal segmental glomerulosclerosis, although we have not studied this yet, I'll study in the first aid in the next few minutes, but just keep in your head, if you can remember, this is, as the name indicates, focal segmental. So there are two words basically in there to understand. One is the focal, which means that less than 50% of the glomeruli are involved, and then the next word is segmental. So segmental is another important word. So that basically means that only for those glomeruli which are involved, only a segment of them is involved. You know that the structure of glomeruli, if you look in the kidney H&E stains, you see a globe of the glomerulus, and the globe of the glomerulus is composed of mesangial cells and glomeruli and everything, and they're basically in different lobules. So if only one part of the glomeruli is affected, this is what we call segmental involvement. So if less than 50% glomeruli are involved, it's called focal, and of the glomeruli which are involved, only a part of them, only the part of the glomeruli, only of the part of the globe is affected, then this is called segmental. Then diffuse means obviously more than 50% of the glomeruli. It's like big involvement of kidney, and diffuse proliferative glomerulonephritis is an example. Proliferative basically means there is hypercellular glomeruli. So if you look at the globe of the glomeruli in the H&E stain, so what you basically see is that in the mesangial or in the interstitial space, you see hypercellular, a lot of cells in there, and most of the time these are either neutrophils or macrophages. So these are the immune cells coming in, leading to the hypercellularity. An example for this would be membranoproliferative glomerulonephritis. Then there is a terminology called membranous. As the name indicates, the membranous means involvement of the membrane. Which membrane? Basement membrane. At all the times, you have to remember a basic schematic of how the glomerular epithelial membranes are arranged. So we have the endothelial lining, and these are on the blood side, and let me draw the diagram here as well. So here we have the Bowman capsule, and this, for example, is the Bowman capsule leading to the proximal convoluted tubule, and then here we have the afferent arteriole, and the afferent arteriole is making capillaries, glomeruli, and then the efferent arteriole, something like this. Okay, so starting from this region, we have the endothelial lining. So these are the endothelial cells made here. And after the endothelial lining, we have obviously the basement membrane. So here we have the basement membrane, and after the basement membrane, we have the podocytes here. So these podocytes are basically the visceral layer of the Bowman capsule. So here, so these three structures are must for you to understand. Okay, now in many of the lectures you will see them drawn upside down. So for example, in some lectures you will see them that this is the endothelial lining, here is the basement membrane, and here is the podocyte. Doesn't really matter, the concepts matter. If I flip them up and down, that does not really matter. You should be very clear about the orientation and the concepts. So the concept is this again. So this is the Bowman capsule, and this is the Bowman capsule leading to the proximal convoluted tubule. So, and here is the blood supply. So the blood supply is obviously also a tubular structure. There will be an endothelial lining, so that's the endothelial. After the endothelium will be the basement membrane. After the basement membrane will be the podocytes here. So if I draw it like this, it will be in this order. Okay, if I draw this in any other order, it can be in any other order. If I draw it linear, I can also draw it like this. So there are endothelial lining, then there is a basement membrane, and then there are podocyte. Does not alter my understanding, because I understand where are the endothelial cell. They are sitting on the basement membrane, and then there are podocytes. Okay, so this understanding is super important. Now, once you have this idea, then you will understand that the basement membrane is basically involved in membranous disorder. So it's the either thickening of the basement membrane or any other pathology associated with membrane, the basement membrane. Okay, and an example for this would be membranous nephropathy. So these are quite complicated nomenclature, but we'll try to make life easy as much as we can. Now, what do we mean by primary glomerular disorder? That basically means primary disease of the kidney, meaning that it is specifically impacting the glomeruli. So it's something primarily impacting the glomeruli. Then there are secondary glomerular diseases, which means that there are some systemic disease such as diabetes or lupus, and that is then affecting glomeruli. I will talk about all of them. So this table for nomenclature is very important for you to understand. I like this diagram very much. Again, if you look at this diagram and you compare it to the schematic that we just discussed, is very much representative here as well. So if I take this bit, so for example, I take only this bit and then I try to enlarge it here. So what are we looking at? So we have endothelial cells. So these are the endothelial cells. So only this bit focus, okay? So we have two endothelial cells. Now there are two endothelial cells, right? And then we have this green basement membrane. So there is a basement membrane, and then after the basement membrane there are two porocytes. So let's draw two porocytes. So see, this is exactly the same illustration that we discussed here, remember. But say for example, if I don't take this bit and now I take let's just for an example this bit, so my understanding will still be the same. So we have endothelial 1 and 1.5. So one endothelial cell and then a basement membrane and then porocyte, you see. So the orientation, or now if I take this bit for example, let me take the topmost part. So if I take this bit now what is the orientation? We have the endothelial cell. On the top of it is the basement membrane. On the top of it are the porocytes. So this is a true orientation. Endothelial cells and then basement membrane and porocyte. This is a true also orientation. No problem with that as well. Or we have endothelial cell and a basement membrane and porocyte. This is also a true orientation. The point is that you should really understand what is the structure, not the direction, and do not ratify without understanding. Understanding is a must, okay? Now this diagram I like. Let's go through this diagram because it is showing a glomerular globe very nicely, and actually not the complete globe but a glomerular capillary surrounded by podocytes, okay? So what do we have? We have blood inside. Obviously the blood vessel will contain blood. It will also contain protein. So there are protein molecules and blood in there, and there is endothelial lining, and these are the fenestrae. Just say you can have filtration. So these are the filtration diaphragms and slits that we talked about, and the size for this is around 100 nanometers. Things can pass through this, and these endothelial cells are sitting on a basement membrane, and over the top of the basement membrane we have epithelial cells, okay? And the epithelial cells are also having filtration slits, right? So you know where is the glomerular capillary? This round thing is the glomerular capillary. You know what is the endothelial cell? This is the endothelial cell. The basement membrane, this lining outside, or let me say the lining between the epithelial cell and the endothelial cell is the basement membrane. Then we have the epithelial cell, i.e. porocyte, and then outside this will obviously be the Bowman space or the urinary space. So this is all urine, okay? So this is all concealed compartment, and whatever gets out, this is all urine, right? And now when we talk about kidney pathology, so let us divide the pathology into two broad domains, the Nephrotic Syndrome and the Nephritic Syndrome. And obviously there is a mix of diseases, because in reality, in real world, diseases do not follow patterns that we study in books, unfortunately. So there is a mix of overlap of diseases. So we don't see patients who only, for example, have nephrotic syndrome. We may see them, but sometimes we don't. We may also not be seeing patients only having nephritic. And it's not a rule of thumb that if you see a patient with nephritic syndrome, this same patient will not at the same time have nephrotic syndrome. It's possible that patients present to you with a combination disorder, which is nephritic nephrotic. So, but there are hallmarks. In examination, they try to give you a bookish thing most of the times, but they sometimes test you for difficult concepts as well. So for example, we need to understand what is the hallmark of nephrotic syndrome. So nephrotic syndrome is more protein lost, okay, less blood loss. So you see these more protein globes there. So you're losing more and more protein. It's usually more than 3.5 grams per day. So and when we talk about nephritic syndrome, it's more blood coming out and less protein. And if you have mix of both blood and protein, this is what we call nephritic nephrotic, okay? So if we say nephritic syndrome is basically because of damage to the glomerular structure. So there is glomerular inflammation basically. And the cause for this is in the Bowman capsule, what happens, there is a glomerula, you are aware of this. So for any reason, if there is immune complex deposition here, the immune complex deposition will release a lot of obviously inflammatory mediators, and it can also release chemotactic factors and more neutrophils and inflammatory cells will come in here, and they then cause the hypercellularity and the inflammation. So there is glomerular basement membrane damage and loss of RBCs into the urine. So that is the hallmark of nephritic syndrome. Red blood cells leak, and I told you, if red blood cells leak here, they will accumulate here in the tubule and they will be lost in the urine as red blood cell cast. So you will see red blood cell cast in the urine. You will see hematuria, obviously, because blood is lost, okay? And hematuria and red blood cells will be getting out in the urine. Now, obviously there is damage of the glomeruli, so there will be GFR reduction, will lead to oliguria and azotemia. So you will release less urine, and there will be accumulation of stuff in your blood. So nitrogenous waste product will not be excreted. So azotemia, right? There will be more renin release because kidney glomeruli are damaged, so kidney sense it, and renin can activate the renin-angiotensin-aldosterone system, leading to hypertension. Okay, so each and every word written here should be clear to you that what is the cause of any of the presentation. Okay, proteinuria is usually in the subnephrotic range, which is less than 3.5 grams per day. So this is not huge protein, but more blood, and you can see this in the diagram here: less protein, more blood excreted. And however, if it's not a sharp distinction. I told you that patients with nephritic syndrome can start losing more protein, and that's where they enter into the nephritic nephrotic range. And there are many examples. We will discuss in detail what are the different causes of nephritic syndrome in a minute. But just to list them here, if you want, they are post-streptococcal glomerulonephritis, good pasture, IgA, Alport, and Membranoproliferative. But wait for a minute, and the next table will be detailing all of them. Then the other major classification is the nephrotic syndrome, where there is proteinuria, and that's the hallmark, and you lose a lot of protein. It's because you have damage to the podocytes. So if the podocytes are damaged, you start losing a lot of, so there is no filtration barrier, and you start losing a lot of protein. So damage to the podocyte is the hallmark for nephrotic syndrome. So massive proteinuria. You start losing more than 3.5 grams per day of urine, and obviously when you lose urine, you get edema, your albumin levels go down because you are losing albumin, and now because all these things are going out, lipid is increased in its synthesis in the liver, particularly to make up for the lost protein, and you have now more lipogenesis, so hyperlipidemia and hypercholesterolemia. Also, you not only lose albumin in your urine, but you also start losing some of the anti-clotting factors, such as you start losing antithrombin 3, and once this is lost, you become hypercoagulable. So these patients are prone to get more coagulation. And you also sometimes can lose IgGs in the urine, and all these should make sense to you. If you don't understand them, watch the video again. Now, nephrotic syndrome can be primary, in which the podocytes are directly damaged, or it can be secondary to some other disease. We'll talk about all of them. So there are either primary causes or there are systemic causes, such as amyloidosis, diabetes, or even lupus. But the primary pathology is not damage to the glomerular basement membrane, is basically podocytes and the epithelial cells which are damaged. Okay, and whenever there is a mix of these two morphologies, then we call it nephritic nephrotic syndrome. So there is glomerular basement membrane damage as well as loss of red blood cells into the urine. So obviously the patient will have hematuria because of nephritic problem, and the patient will have proteinuria more than 3.5 grams per day, which is the nephrotic range. Okay, so they will be concomitant, and it can occur in any form of the nephritic syndrome, but the two more common ones are the diffuse proliferative and membranoproliferative. They have the tendency to get a dual picture, right? So once we have done this, it is now time to start talking about individual causes of nephritic and nephrotic syndromes. So the prototype disorder that we have to study first is the infection-related glomerulonephritis, also called the post-streptococcal glomerulonephritis, because this is usually seen in children who are 2 to 4. Children of any age group, basically children, but seen after 2 to 4 weeks of group A beta hemolytic streptococcal infection. Can be pharyngitis or skin problem. So if they explain to you, a patient, particularly a young patient or children who had pharyngitis, for example, a couple of weeks ago, and now the patient presents with bloody urine, so hematuria, and they give you then signs and symptoms of the renal disorder. Then you have to pick this one. This is infectious associated glomerulonephritis. Basically, due to the infection, the immune complex are deposited in the glomerular filtration structure, and then because of that immune complex deposition, you start getting immune cells in there. So that's basically a type 3 hypersensitivity reaction, and I just told you how does that happen. And children, most common cause is usually strep, but in adults it can also be caused by staph infection. So that you should also understand it's not always streptococcal. Therefore, they actually changed the word from post-streptococcal to infection related. Okay. Now, what you see under light microscopy is obviously because there is inflammation going on, there is enlargement of the glomerular globe, and there is hypercellularity. Why hypercellularity? Because more and more immune cells are coming in. Now, you should also understand that whenever there is immune complex deposition, you always expect immunofluorescence changes, and the way to understand this would be always understand the basic structure. So if we have the endothelial cell lining, and then we have the basement membrane on which the endothelial cells are sitting, and then we have the porocyte. So if you remember this structure, you should be able to appreciate that the immune complexes are deposited like this. So they are deposited in a granular pattern in or near the basement membrane. So that is what we call the granular or lumpy bumpy appearance of immune complexes. Okay, so this is basically a complex which contains IgG, IgM, there is C3 deposition, and this all happens alongside the glomerular basement membrane. So you actually see that on electron microscopy as well, and also more clear so on immunofluorescence. Okay, so obviously you have to then appreciate that if anything of gross nature is being deposited, you will see big humps on electron microscopy. Okay, so the key take-home message here would be a post-infection type 3 hypersensitivity reaction, hypercellularity of the mesangial area, and granular immunofluorescence deposition. Okay, then this disease, post-streptococcal, sometimes can also be, or because of some other disease. The next bit is progressive glomerulonephritis. Now, this is something dangerous because if the patient start experiencing rapidly progressive glomerulonephritis, that basically means that the kidney may move forward towards renal failure. So that's a bad sign, and therefore these patients have to be taken very, very seriously. Now, the word crescentic basically means that because of inflammation, what happens that in the glomerular globe, when we are looking at DHNE, you see such a big crescent, and this crescent is basically composed of immune infiltrates such as macrophages and fibrin, and that's actually very high yield for you to understand that in examinations they sometimes test you on this, that what are the crescents made up of. These are not made up of bomb and capsule, bomb in space, but they are made up of fibrin and some of the proteins and some other proteins such as which are present usually in plasma, but more so during inflammation, such as C3b, and there are immune cells, monocytes, and macrophages. So that's what is the composition of the crescent. Okay. And whenever you suspect in a patient progressive glomerulonephritis, because you'll do the labs, you'll see azotemia, you will see increased creatinine burn levels, and there may be oliguria. So you suspect the person, and then you start doing further investigations, such as you do biopsy. And after biopsy, you obviously in the biopsy you see the crescents, and if crescents are there, then now you have to determine the cause. And in order to determine the cause, what helps you is immunofluorescence. So it basically goes like this. So person comes to you with complaints of renal issues. So for example, the person says, I have been noticing blood in my urine since X number of days, and I have this problem and that problem and this and that and this and that. And now you start investigating the urine DR and the basic investigations you do, and you suspect glomerulonephritis. So, and you are suspecting that it may be rapidly progressive glomerulonephritis, and then you do the next step you do is the biopsy, and if you see crescents on the biopsy, that's a red flag. Now you have to do, if there are crescents present, you have to do immunofluorescence, which can be by and large, either they will be granular deposits of immune complexes or antibodies, or it can be linear deposit, or there will be a negative finding. There will be nothing seen on the immunofluorescence, and this is what we call the posse-immune type of case of glomerulonephritis. And there, if there is no indication on immunofluorescence, I mean, life becomes easy if it's granular, because you know some very important causes of granular glomerulonephritis. So if it's granular, you would think about, okay, it can be post-streptococcal, it can be this and that. And similarly, if there is linear deposits, you can think about Goodpasture syndrome, for example. But what if there is no immunofluorescent finding? It's negative posse-immune. Now you do the ANCA testing. So it is anti-neutrophil cytoplasmic antibody. So basically the way to do this is that you take the neutrophils on slide, and then you install the serum. So there are antibodies in there, and obviously there will be a nucleus in the neutrophil. If these antibodies are binding just around the nucleus, and this is what we call perinuclear, so p-ANCAs, okay, p-ANCAs. So either it will be p-ANCA, or if the antibodies are binding in the cytoplasm, this is what you call c-ANCA positive. So if it's c-ANCA positive, you identify the pathology. If it's p-ANCA positive, you identify a different set of pathology. We'll talk about them in a minute. But I'm trying to make you understand the algorithm of how you approach the patient with rapidly proliferative glomerulonephritis. The patient comes in with a complaint, you suspect rapidly proliferative glomerulonephritis, you do the biopsy. On the biopsy, you see the crescents. After crescents, you do the immunofluorescence. Now check if it's linear. So what basically linear means, that if these are the endothelial cells, if these are my endothelial cells, and this is basement membrane, and these are the podocytes right there. Actually, podocytes are not like this, I told you. Podocytes are like this, like this. They have spaces in between. So if the antibodies, let me draw antibodies with green color. So if the antibodies are being deposited like this on the glomerular basement membrane, so they are called to be attached in a linear pattern, because they then on immunofluorescence make a linear sharp line. But if they are not attached in a linear fashion, rather they are attached in a granular pattern, such as immunocomplex deposition, this is what we call granular. So you should be able to appreciate what is linear, what is granular, and what is negative. And there are different approaches for each one of them to link them with each and every single disorder. So for example, if you see linear immunofluorescence, it can be because of Goodpasture syndrome, right? And if it is granular, I just told you it could be either post-streptococcal, so granular deposits can be post-streptococcal glomerulonephritis, or diffuse proliferative glomerulonephritis. But if it is posse-immune, if there are no immunofluorescent deposits but the crescent was still there, so you have to worry about the crescent. Now what you do is you do the ANCA testing. And ANCA testing then identifies if it's p-ANCA positive or c-ANCA positive. So if you're seeing p-ANCA, that is usually the microscopic polyangiitis. So that's the way to basically dissect out your patient if you suspect rapidly progressive glomerulonephritis, okay? All right. Then Goodpasture syndrome, you also see breaks in the glomerular basement membrane because there is defects in the collagen, and there will be crescent formation, obviously, right? And in posse-immune, you don't see any deposits. So basically, if you understand what's happening in terms of the pathogenesis, you will be able to make out what's happening at the level of the immunofluorescence and electron microscopy. Okay, so we talked about post-streptococcal, we talked about rapidly progressive, then a few others. There is another disease. Let's talk about IgA nephropathy, which is actually the most common glomerular disorder if you take worldwide statistics in count, also known as Berger disease. It occurs concurrently with respiratory or GI tract infection. So mucosal infections basically, because this is where IgA is secreted. So what happens is that patient acquires a mucosal infection, and because of that mucosal infection, the patient starts secreting a lot of IgA, and that IgA that can be deposited in kidneys. So that's what it happens, okay? So there is IgA deposition, and there is nothing else that we have discussed in the whole renal module where we talk about IgA deposition. It's always IgG and all other antibodies, but IgA deposition classically means it is Berger disease, okay? Because this is again inflammatory issue, there will be mesangial cellular proliferation. It's IgA deposit on fluorescence, and there will be mesangial immune complex deposition. So this all should make very much sense to you. The key point here would be for examination to remember is a mucosal infection followed by glomerulonephritis. Okay. Then let's talk about what is diffuse. Diffuse, I told you, if more than 50% of the glomeruli are involved. Okay, it's often due to lupus, very important and very high yield. So in lupus, these patients typically get diffuse proliferative glomerulonephritis. Very, very important. Okay, you just cannot miss this point. Lupus association with diffuse proliferative is a very high yield stuff to remember. Right now, this patient may also present with a combination of nephritic and nephrotic syndrome. This we also discussed earlier on, that primarily it causes nephritic syndrome, but the patient may start losing a lot of proteins. Okay, you start seeing wire looping of capillaries, and there are granular deposits because immune complexes are deposited. This is a systemic inflammatory disorder, so immune complexes are deposited within the glomeruli, and the way they tend to deposit is usually subendothelial, and sometimes they can also go subepithelial or even intramembranous. So any of the pattern can be seen, but my point here is that you should and you must understand what do we mean by each one of these words. So let us again draw the diagram. These are the endothelial cells, and this is the basement membrane, and here are the podocytes. So if any immune complex is deposited beneath the endothelial cell, so just below the endothelial cell, this is what we call subendothelial deposit. If they are deposited below the epithelial lining, this is where we call them subepithelial, and if they are deposited within the basement membrane, and they can also lead to the split of basement membrane, then they are known as intramembranous. So you should understand all these three terminologies: subendothelial, subepithelial, and intramembranous. And for diffuse proliferative, it can do anything. The way I remember this is that diffuse proliferative is very flexible type of disorder, because it can have nephritic and nephrotic both together. It can have this and can have this and can have this. Pretty flexible behavior, isn't it? Then Alport syndrome in examination is very, very important, because Alport syndrome has, it involves other organs as well. It's basically a type 4 collagen mutation, and type 4 collagen, wherever it is now present, there will be a problem. So glomerular basement membrane, for example, also present in eye. So the patient may have, eye ocular issues. The patient can also have hearing problems. So because all of these areas contain type 4 collagen, so the patient can't see because of ocular problem, can't pee because of kidney glomerulonephritis, and can't hear because of air involvement. So whenever such a patient is presented to you in examination, always think about Alport syndrome. Okay, there is irregular thinning and thickening and splitting of the glomerular basement membrane because collagen is affected. So this particular area of basement membrane is thin, split, damaged. Okay, immunofluorescence initially is negative, and non-specific staining may happen. So because there are no immune complex deposition, at least at the initial stages, you don't see it's kind of a negative immunofluorescence. Okay. On electron microscopy, it's a basket weave appearance due to irregular thickening and longitudinal splitting of GBM. So basically you see irregular glomerular basement membrane, and you always think about problems in the basement membrane can be because of damage to collagen. Then the last one that we have to discuss in the glomerulonephritis list is the membranoproliferative. Type 1 may be secondary to hepatitis B virus infection or hepatitis C virus infection. So basically there are two types of membranoproliferative, and these types are categorized based on where the immune complex are deposited. So let me again draw the diagram for you. These are the endothelial cells, and then we have the basement membrane, and then we have the podocytes here. So if the immune complex deposition is subendothelial, and this is very high yield for your examination purposes, subendothelial. So if it is subendothelial, it is known as type 1 membranoproliferative, and this has high association with hepatitis B or hepatitis C virus infection. And the type 2 membranoproliferative glomerulonephritis is also very important because it has a different location. So in examination, they test you on this. So they basically have intramembranous type of immune complex deposition, something like this. So they are either intramembranous or sometimes subepithelial, but not subendothelial. So intramembranous. So if it is intramembranous deposit, it is membranoproliferative type 2, and it is associated with C3 nephritic factor, which is an autoantibody which stabilizes C3 convertase. So stabilization of C3 convertase means that you have all the time breaking off complement factor 3 into its components, because the enzyme working here is actually stabilized by an antibody. So this antibody is basically called the C3 nephritic factor. So the way it works is that you start generating this antibody, which is known as C3 nephritic factor. Now this antibody goes and find C3 convertase. So this C3 convertase is the enzyme in the body which converts C3 into C3A and B, for example. So once this is overactivated, superactivated because of autoantibody, which is what we call C3 nephritic factor, obviously this reaction moves on all the time in the forward direction, leading to low complement levels, but then also leading to the products which are chemotactic. So there obviously will be a lot of immune complex generation, a lot of inflammatory stuff in the kidneys. Okay, so remember, type 1 and type 2 have two different etiologies, and they have two different locations for deposition of immune infiltrates or the complexes. Okay, and what you also see particularly in type 2 is, here is an interesting concept. So if the immune complexes are being deposited like this in the intramembranous location, what they usually do is they split the basement membrane, and you may see something like this. So in this area you may see a double glomerular basement membrane area, so that is doubling or splitting. So do you not think it looks like rail track appearance, a tram track appearance? So that is why this is very, very important in high yield for examination. If they talk about tram track appearance, always think about membranoproliferative, and it is more so associated with type 2, because type 2 is then deposited within the membrane, has more chances to split the membrane. Okay, all very high yield. Let me draw 5 stars here. So that's the way you study first aid, guys, because if you don't understand what you are studying in first aid, you are screwed basically, right? Now that's also a very important diagram, again showing you a small block from the glomerular globe, and what you see here is now you should be very well aware of this. So these are the for example endothelial cells, and then the basement membrane, and this is the epithelium. So if anything is deposited under the endothelium, this is subendothelial deposit, and if you see something within the membrane, this is intramembranous deposit, and if you see something below the epithelial cells, this is called subepithelial deposit. Very, very high yield for examination purposes, and you see I've been drawing this diagram again and again. All right, let's now talk about pathologies associated with nephrotic syndrome. So recall that nephrotic syndrome is the pathology where podocytes are primarily affected, and there is the hallmark of the disease is heavy proteinuria, which is usually more than 3.5 grams per day. Okay, now there are different diseases which are associated with nephrotic syndrome. The first one of them, let's talk about this, is the minimal change disease. In the minimal change disease, as the name indicate, number one thing, it is self-limiting usually. That's the good news. Sometimes you have to give steroids, but most of the time it limits itself. But what basically happens is because of high cytokines, because of inflammation, what happens is that there is effacement of the podocyte foot processes. So let us illustrate this to make this more understandable. So if this is your endothelial lining and this is the basement membrane, and now this is your podocyte with the foot processes, and then you have a podocyte like this, so there are no foot processes. This is what we call effacement of podocytes, and because of this there is more protein lost into the urine. And why this happens is mainly because of heavy cytokine levels, okay, which can happen in immune scenarios, recent infections, idiopathic. Now idiopathic is interesting because in most of the nephrotic disorders they are idiopathic. We don't know the cause, right? But one important association here is its association with lymphoma, because in lymphoma you have Reed-Sternberg cell, and this is the cause of heavy inflammation and cytokine release in lymphoma. So in lymphoma you also see minimal change disease, the podocytes are damaged. On light microscopy, you see everything normal because you don't see these podocytes on light microscopy. For that, you have to do electron microscopy, and there is no immunofluorescence positivity. It's negative, right? Then let us talk about the other disorder, which is basically the focal segmental glomerulosclerosis. Now, the word focal basically means that less than 50% of the glomeruli are affected, and segmental, of the glomeruli which are affected, only part of it is affected. So if it is the glomeruli globe, only maybe one lobule or maybe two lobules are affected. Okay, it can be a primary disorder, idiopathic, again idiopathic, or secondary. You see this in HIV, sickle cell disease, and some other congenital malformations. But HIV association and sickle cell association is super high yield, and this is one which has a potential to go to chronic kidney disease. It's not like minimal change disease, but it can progress to chronic kidney disease and perhaps failure. Right, so there is segmental sclerosis and hyalinosis, as you see in light microscopy, and in immunofluorescence usually it is negative but may be positive for non-specific deposits, but primarily we define that as posi-immune. And what you see on electron microscopy is the same thing, effacement of the food processes. Right, then the other one is known as membranous nephropathy, and as the name indicates, there has to be involvement of membrane in there. It's also called membranous glomerulonephritis. So we are still discussing this in nephrotic syndrome, although there is a nephritic component as well. Okay, it can be primary disorder because of antibodies to some of the receptors, or secondary due to some drugs, and this is very important. Its association with NSAIDs and penicillamine, very, very important. Also some infections, HBV and HCV. Lupus, I told you in one of the nephritic disorders as well. Lupus is, guys, a very important for diffuse proliferative glomerulonephritis, and lupus is super damn important also for membranous nephropathy. So lupus association with the nephritic syndrome is very heavily tested in examination. Okay, now what you see in electron microscopy is diffuse capillary and GBM thickening, because and it's easy to remember. So its membranous disorder involves membrane, okay, thickening, and there are immune complex deposition, granular depositions, and they start making a spike and dome appearance. And this spike and dome appearance is an interesting concept, and if you want the details on this, you can listen to the next minute, otherwise you can simply remember and skip this. So what basically happens that there are subepithelial deposits. Now this is the endothelial lining, and then we have the basement membrane, and then there are these epithelial cell, endothelium, basement, and epithelial. So what happens that there are subepithelial deposits, meaning that deposits are present in this area. So the immune complex deposits which are then in this area, what they do is they create an artificial distance between the podocytes, the epithelial cells, and the basement membrane. So basically the podocytes think that they are being taken away from the basement membrane, and they start making more basement membrane. And once the more basement membrane is made, so it is made in a way that it starts accumulating over the immune complexes like this. So let me change the color, and so that's the way it starts accumulating here. So there is an additional basement membrane, right? More and more basement membrane. So there is more and more basement membrane here, and then the this pattern continues, and the overall shape comes like this. So there is a dome, that's the dome, and then there is a spike. So there is a dome over the immune complex, and then there is a spike in between the immune complex, and therefore we call this on electron microscopy spike and dome appearance, which is very common in membranous nephropathy. All super high yield for examination purposes. Okay, now there are two diseases which are actually systemic problems, but they affect kidney, and they can cause nephrotic syndrome. They are amyloidosis and diabetes. So in amyloidosis, kidney is the most commonly involved organ, and this is associated with chronic condition that predispose to amyloid deposition, such as amyloid disorders. Okay, AL amyloid, A amyloid. So any thing associated with amyloidosis has chances that this amyloid will also be deposited in kidney. All right. The rest is very easy to understand. There is Congo red stain, which shows apple green by refrigerants. So this is typical of identifying amyloid crystals. And on immunofluorescence, you may see positive kappa and lambda light chains for AL amyloidosis or AA protein for AA amyloidosis. Obviously, they will give you hints in the examination to pick them up, right? And then there is diabetes. So the most common cause of end-stage renal disease in the United States is actually diabetes. Hyperglycemia causes non-enzymatic glycation of tissue proteins, and therefore there is mesangial expansion, glomerular basement membrane thickening, and increased permeability, which is equal to leakiness. And once there is hyperfiltration because of leakiness, there is glomerular hypertrophy and glomerular scarring, which is the bad thing. Right, so these are the events that you must understand in order to understand the pathology of diabetes associated glomerulonephritis. Now, obviously there will be albuminuria, so look for albumin in the urine, and we also check for ratios, albumin to creatinine ratios. And ACE inhibitors and ARBs are renoprotective. ACE inhibitors in many certain scenarios are renoprotective. So you must understand that why is this happening, because angiotensin 2 is basically constricting the efferent arteriole. So if efferent arteriole is constricted, now let me illustrate this much more clearly. I'm assuming that you have been watching my video through the very beginning, so you understand my concepts here. So if you have, this is the Bowman capsule, and then there is the afferent arteriole, and then glomerulus, and then efferent arteriole. So in the scenario where kidney is damaged, obviously the renin-angiotensin system will be activated, because kidney feels like that if there is less blood or less volume in the body, so in order to give a physiological feedback type of thing, a compensatory mechanism, renin-angiotensin system will be activated, and then angiotensin 2 will be preferentially constricting the efferent arteriole. And once the efferent arteriole is constricted, that will further contribute to the damage, and ACE inhibitors will stop this. So ACE inhibitors are kind of renoprotective. You must understand how does it protect kidneys, particularly in the scenario of diabetic nephropathy, right? On light microscopy, you see mesangial expansion because of the mechanism just explained. There is glomerular basement membrane thickening. All this is leading to sclerosis, and these sclerotic nodules are known as Kimmelsten-Wilson lesions. These are pathognomic for diabetes nephropathy. Okay. Right, I think they are shown here. So you see the fibrotic tissue, the sclerotic tissue. They are diagnostic actually for diabetic nephropathy. Immune fluorescence negative, and on electron microscopy you see thickening of the basement membrane because of non-enzymatic glycation as just discussed, and there is proliferation of mesangium and effacement also of podocyte, because that's a general feature for all the nephrotic syndrome diseases. So it's not difficult, guys. It looks difficult, nephritic, nephrotic, but each and everything makes sense. Okay, so let's now start talking about the next stuff, which is kidney stones. So kidney stones are formed when there is excess secretion or excess accumulation of some of the solutes within the urine, so that they precipitate and they form the stones. And there are certain solutes which can form the stones commonly than the other. So for example, calcium stones are very, very common, but we'll talk about different types of stones in a minute. So these stones themselves are very important because they are associated with a lot of different clinical scenarios. So for example, they can lead to obstruction, they can lead to many complications including hydronephrosis. So imagine there is a kidney here and you have got a stone which blocks the urinary outflow in the ureter. So there will be backlogging pressure and hydronephrosis. Kidney will be filled of urine. So this is one of the complications of stones, by the way. It can lead to infections, but whenever there is an obstructive pathology, always think about a stasis of something, and in this case there is a stasis of urine. And if by any chance there was any organism up there, so it's stuck there because this is obstructive, and it can lead to pyelonephritis. And it can also, if the obstruction is severe, it can also lead to acute kidney injury. So all these are the complications associated with kidney stones, and therefore kidney stones become very, very important clinically. Obstructed stones present with unilateral flank tenderness, colicky pain radiating to the groin, and hematuria. So hematuria because they are irritating the epithelium and therefore there can be bleeding. in the urine. So hematuria can be one of the presenting complaint, and if they block the urinary outflow, the ureteric muscle, they are kind of irritated and the colicky movement starts, and that is the reason for the severe pain associated with obstructed kidney stones. Treat and prevent by encouraging fluid intake, so that's the mainstay stuff. Drink as much water as you can. And radiolucent stones, we will discuss about them in a minute. The line written here is just to represent a mnemonic that I can't see because they are radiolucent. You can't see them on X-ray, so I can't see you, and from I can't see you, C is for cysteine and U is for uric acid. So that's a nice line if you want to remember which stones are actually not visible on X-ray. So that's cysteine and uric acid stones. Okay, first aid gives you a lot of mnemonics, right? So let's start doing different types of stones. So calcium stones are the most common type of stones, and they precipitates calcium usually precipitates either with oxalate, for example, or with phosphate, right? And there are some predisposing factors. So for example, calcium oxalate stones are associated with low citrate levels, hypocitraturia, and calcium phosphate stones are associated with alkaline environment, increased pH. Now, both of these stones, the calcium stones in general, are radio opaque, which means you can actually see them on the radiograph, and on CT scan you see them as a hyperdense area because that's calcium here. Okay, and shape wise, if you talk about the urine crystals, they are envelope shaped, the calcium stones, and wedge shaped or prism shaped, but this is very difficult to identify that what exactly is the shape for each type of stone unless you focus on these diagrams, because just by seeing they are envelope shaped becomes difficult. So let's focus on the diagram and see where are the envelopes. Now you can appreciate a close envelope here. So that's the envelope shaped calcium stone. Okay, figure A. All right, now some important notes. Calcium stones are most common stones of the whenever we talk about nephrolithiasis, stones in the kidney, the most common category is the calcium stone. Okay, now calcium oxalate stones are more common than calcium phosphate stones, so oxalate wins the race. They are the most common type of kidney stones. They can result from ethylene glycol, which is an anti-freeze agent, vitamin C overusage, hypocitraturia, this is more associated with calcium oxalate stone, and malabsorption, because when there is malabsorption not always means that there is reduced absorption of something. So for example, in Crohn's disease, we actually reabsorb oxalate more than normal. So when we have a lot of oxalate, calcium oxalate stones are precipitated, and they are treated usually with calcium sparing diuretics such as thiazides. You give citrate because hypocitraturia was one of the cause, and you try to give low sodium diet. So calcium stones, please remember each and every detail that we have just discussed. How do they look like? They are radio opaque. What are the different types of calcium stones, and what are the important notes associated with them? What are the important causative factors? Okay, then there is a category which is called ammonium magnesium phosphate stone, also known as true white stone. They are big stones. So if you look at the diagram here, you see that big staghorn calculus. This is the big ammonium magnesium phosphate stone, which is associated with alkalinization of the urine. So in an alkaline environment, they are hyperdense on CT scan and radio opaque on X-ray, and they appear literally like this, so they kind of cover the whole pelvis region and the calyces, so it actually blocks them. It's a big stone. It accounts for about 15% of the stones, so probably next to the calcium stones, caused by infection. That's an important point. There is an important infectious etiology associated with this. Okay, the bugs which are urease positive, for example, Protease species and Staphylococcus saprophyticus, also Klebsiella. So these organisms, if in the exam they are pointing anything towards the infection of these organisms, think about these stones if this is under discussion. Okay, so urine alkalinization, increased pH, and alkalinization associated with formation of these stones. They are also called staghorn calculus because they have like horn-like appearance, which blocks the renal calyces and pelvis. So that's such a big stone. How do you treat them? So eradication of the underlying infection. So I told you this is because of the infection routinely, and if you treat the infections, and sometimes obviously it's a big one, so you have to do surgery. So you have to do surgical removal of the stone. Without this, only treating the infection will not cure the stone which is already formed. Then uric acid stone, you know what do we mean by U? I can't see you. So C and U, they are both radiolucent. You really cannot see them on the X-ray. And on CT scan, however, they are visible and slightly radiodense on CT scan about the cystine stones. Okay, so uric acid stones are associated with low pH, so acidic environment. So here actually in the treatment you will do the alkalinization of urine, because if you alkalinize the urine, this acidic environment is gone, and then you are not giving the environment to precipitate uric acid stones. Okay, and they have typical appearance when their crystals are talked about, rhomboid shaped crystals, and about 5% of all the stones. So the most common are the calcium, then the next common are the ammonium, magnesium, phosphate, and then the third common category is the uric acid, 5% of all the stones. Okay, so arid climate, acidic pH. So acidic pH is a risk factor. Also has a strong association with hyperuricemia. Now hyperuricemia condition can be in different scenarios. So for example, if somebody is already having gout, or if somebody has any malignancy such as leukemia, so whenever there is increased cell turnover, so because of the increased cell turnover, there may be hyperuricemic condition which can lead to uric acid. Obviously hyperuricemia, uric acid stone, easy to understand, right? Then cystine stones. Now that they are the rarest of all the stones that we see in kidneys, and they are associated with the congenital anomalies. So autosomal recessive condition where you are not handling cystine appropriately. So there increased level of cystine available in the urine, leading to precipitation and formation of cystine stones. Okay, so there can be transporter defects, which also leads to poor absorption of ornithine, lysine, and arginine. Cystine is poorly soluble, thus the stone forms in the urine. So whenever there are high levels because of malabsorption and poor handling of cystine because of autosomal recessive conditions, then there are problems. Also other things are also affected, but cystine is prone to make stones. It can also form Staghorn calculi. So very important point to note here is that these stones can also form Staghorn calculi. So it's not only the feature of istrovite stones, can also be seen, those big stones can also be seen in cystine stone pathology. Okay, right. 16 stones have 6 sides, like a benzene ring, if you remember. You remember the benzene rings that we used to draw in our high school chemistry? 6 side, hexagonal. So they have hexagonal cast appearance. So their urinary crystals are hexagonal in shape. How you treat them is basically you use chelating agent to reduce the levels of cystine. Alkalinization of the urine also helps, and basically it's a metabolic disorder, which is an error of metabolism because of hereditary issue. So it's very difficult to treat them basically. So you kind of more focus on the conservative management. Okay, so after the kidney stones, let's quickly talk about what is hydronephrosis. It's the dilatation of renal pelvis or renal chelicus, and usually it is because of urinary tract obstruction. So like I told you before, if this is the urinary system, ureter, and there is a blockage because of urinary stone, this system will be dilated, and this is what we call hydronephrosis. So it can be because of a stone, it can be because of a neighboring tumor which is blocking the ureter, it can be because of prostate blocking things downstream. Because if you understand the anatomy, the basic concept is that we have the bladder here, there is a urethra, we have ureters coming into the bladder, and then up here we have kidneys, right? So obstruction can be here because of benign prostatic hyperplasia. So BPH can cause obstruction here. There can be obstruction at the level of ureter because of a stone, or compression from the surroundings, such as in different tumors. So any obstruction can lead to hydronephrosis. Okay. So advanced cervical cancer, for example, and retroperitoneal fibrosis. Fibrosis can also obstruct the ureters. So any such thing which is potentially obstructing the outflow of urine can cause hydronephrosis. And if there is hydronecrosis, obviously, then the kidney functions will be affected. There will be serum creatinine, which becomes elevated, which is an indicator of poor kidney functioning. So serum creatinine, you know, is taken as a measure of the GFR in real life. So if it is going up, GFR is being disturbed. Okay. Now it leads to compression and possible atrophy of cortex and medulla, obviously, because there is fluid-filled tissue. So what happens that it compresses the living cells, and those cells can start dying, leading to atrophy of cortical tissues as well as medullary tissue. So you should be, and this is very simple to understand, by the way, there was no difficult concept in here. right? Then we have an important topic, which is urinary incontinence, which means the patient is unable to hold the urine as a normal person would do. So mixed incontinence has features of both stress and urgency. Now we need to understand what is stress incontinence, what is urgency incontinence. Actually, there are three different categories of incontinence, starting from stress incontinence to urgency incontinence to overflow incontinence. That's the easiest one to understand, perhaps. Overflow incontinence means simply, as the name indicates, there is overflow, there is overfilling of the bladder, and because of the overflowing, the urine dribbles down. So it's just like you have a glass of water, you fill it right to the top, and if you get more water in, it will dribble off. Similarly, this bladder is already full. If you pour more urine in, it will dribble off. Okay, so what is the mechanism for this category of incontinence? Incomplete emptying. So the detrusor muscle surrounding the bladder are perhaps weak, or there is any problem in the outflow. So because of the obstruction, there is overfilling. Leak with overflowing, increased post-void residual volume. So because it's all filled with urine all the time, so post-void volume is increased. There's a leak when more urine comes in. Or whenever you are catheterizing the patient or doing the ultrasound, this is always overfilled. Okay, common associations include diabetes, because you get polyuria and diabetes anyways. Bladder outlet obstruction, because if this is obstructed, the outlet is obstructed, you have problem getting urine out, and this is full all the time. Or there can be spinal cord injury. So because of the spinal cord injury, the muscle supply to the nerve supply to the muscles surrounding the bladder may be not appropriate, and therefore the bladder is not functioning properly. So these are all common associations with overflow incontinence. And then how do you treat? Usually catheterize, or you try to relieve the obstruction if it was there because of BPH or any other issue. Alpha blockers work. So just put in a catheter in. So put the catheter in, all the urine should get out in the catheter. But then you obviously have to deal with the primary cause, which is actually causing the overflow incontinence. Then there is urgency incontinence. There the detrusor muscles are actually overactive. I just told you that overflow incontinence, detrusor muscles are not working appropriately. Here they are working more. So there is leak with urge to void immediately. So as soon as the person has urge to void, these muscles are hyperactive and there is leakage, and that cannot be stopped. Usually seen in urinary tract infection, particularly associated with cystitis. And how you treat that is Kegel exercise is one of the exercises where you strengthen your pelvic floor. So just Google this terminology, it will give you the posture which is made during the Kegel exercise. Basically you strengthen your pelvic diaphragm. So that's part of the bladder training. And then antimuscarinics sometimes help. Okay, so because you need to calm down the muscles here, so you need to inhibit the signals there. All right. Then there is another category which is called stress incontinence. So it has something to do with the stress, obviously, and the stress is the mechanical pressure from the abdomen. So outlet incompetence, basically the outlet is not functioning fine. The internal sphincter, external sphincter, the sphincter mechanisms are deficient. There is intrinsic sphincter deficiency, and therefore as soon as there is intra-abdominal increase of pressure, then this pressure will cause leakage of urine. And what are the conditions where you should anticipate increase in the intra-abdominal pressure? Include, for example, pregnancy or anything which causes intra-abdominal pressure to increase, such as obesity. During delivery, you are putting a lot of intra-abdominal pressure in place, right? So all these things are associated with the stress incontinence. So there is some stress which is leading to leakage of urine. Okay, how do you treat this? You try to strengthen the pelvic floor muscles. You try to weight loss if this is because of obesity. Some exercises again to strengthen your pelvic floor. Okay. Right. Positive bladder stress test is directly observed leakage of urethra upon cuffing or Valsalva. So you ask the patient to do Valsalva maneuver or cuff. So because of cuffing or Valsalva maneuver, the pressure on the bladder increases and you physically observe, or the patient physically observes, leakage of urine. So these three type of incontinences, not continences. So urinary incontinences you should be aware of, right? The next discussion that I have to carry here is about urinary tract infections, so UTIs. Now, infectious organisms can affect any part of the urinary system. So starting from the bladder, there is a urethra, this is from where the urine comes out. Then we have ureters, and then after ureters we have kidneys, right? So urinary tract infections are usually generally they are because of ascending infection. So organisms enter from the urethra. Now they can cause inflammation and infection of urethra, causing urethritis. They can ascend here because, and particularly in females, because there is a short urethra in females. So then the organism can settle here and cause infection and inflammation of the urinary bladder, and this is what we call cystitis. And it can further ascend, involve the kidneys, and this is what we call pyelonephritis. So let's talk about acute cystitis first. This is inflammation of urinary bladder, and because of the anatomical knowledge, you should appreciate that if urinary bladder is inflamed, it will cause pain in the suprapubic region. It also is associated with dysuria, pain during urination, and the person has urgency and frequency, wants to urinate more, right? And usually an important distinction from pyelonephritis is that in cystitis, the systemic signs are not present. So fever, chills, these are not present, they're absent. Okay. Being a female is a risk factor for getting cystitis because they have short urethra. Sexual intercourse with unclean people can cause this. Indwelling catheters, because catheter is a foreign body. You try to insert a catheter there, so you are inserting some organisms already inside the urinary system. Diabetes increases to become immunosuppression की वजह से. So this is one of the reasons where the immune system is not working properly. So diabetes can lead to cystitis or any other infection for that matter. Okay, and if there is impaired bladder emptying, so whenever there is obstruction because of any reason, so if there is BPH, for example, so there is obstruction, less urine outflow, urine will be hanging around in the bladder. Obstruction is always associated with increased risk of infection. Okay, what are the common organisms which infect your urinary bladder? E. coli is the most common, and this is also true for kidneys. So number one cause of pyelonephritis is also E. coli. Okay, Staphylococcus saprophyticus and Klebsiella proteus, saprophyticus, particularly in those who are using catheters. Okay, so all these organisms are associated to in order of their priority. So most common one is E. coli, for example, but all of them infect bladder. Now if you do the laboratory test, you obviously see cloudy urine from the physical point of view. So because there is pus in the urine, so it becomes cloudy, right? And you see, because there is pus, you see leukocyte esterase to be positive, nitrites are positive. So this is an indirect indication of bacterial presence, because bacteria can convert nitrate in the urine to nitrite. So if you're seeing positive nitrites, that basically means bacteria are there. And obviously the gold standard way to check if bacteria are there or not will be the culture. So you get more than 100 colony forming units, and if you don't, which means you are talking about sterile pyuria. So if you think that there is no bacteria there, the culture is negative, then always think about Neisseria or chlamydia, because these are notorious for giving you all the classic signs and symptoms, but then all the culture, it becomes negative. So they are negative in culture, sterile, and then think about these two bugs. And you treat them with antibiotics. Most commonly used one are trimethoprim sulfamethoxazole, nitrofurantoin. Easy beasy discussion on acute cystitis. Okay, so I told you that from the bladder, infectious organism can actually go up and infect the bladder, infect the kidneys. So if they infect the kidney tissue, this is what we call pyelonephritis. It can be acute or chronic pyelonephritis. So when we talk about acute pyelonephritis, there is huge heavy infiltration of the renal interstitium with neutrophil, because these are the acute inflammatory cells. Whenever there is an insult, they think this is their duty to go there and try to combat the infection. It usually affects the cortex with relatively sparing of glomerular vessels, present with fever, flank pain. So systemic signs and symptoms are present. Okay, even nausea, vomiting, and chills. They are absent if the patient has cystitis. Important point. Also, the cystitis patient will have pain in the suprapubic region. There will be dysuria, urgency, and frequency. These patients will have pain in the costovertebral angle at the places where you expect the kidney pain to be present anyways. Okay. Common causes include ascending urinary tract infection. E. coli is the most common one. It can also be hematogenous spread. So if you think about kidney, infection can go from the ascending route or through the blood supply. If there is heavy load of bacteria or any other infectious organism in the blood, it can go to the kidney by hematogenous spread via the renal artery. So hematogenous spread can also happen. And it presents with WBCs in the urine because of infection, obviously, and also WBC cast, because if the tubules are studded with WBCs, they form a cast structure, and the cast is released out in the urine. On the CT scan, you should expect striated parenchymal enhancement, which is not something that they test quite a lot at exam, because there are other more important and common things. Risk factors include indwelling urinary catheter. I told you any use of catheter is not free from the risk of getting UTI. Obstruction is usually associated with UTI, and vesicoureteral reflux. This is common because I told you that there is a bladder, and there are ureters which are entering into the bladder at a particular angle. If there is any disturbance in the angle, and the bladder is whenever there is contraction of the bladder, some urines goes up and affect the kidneys. So this is called vesicoureteral reflux. Okay, can happen in diabetes, pregnancy, because progesterone mediated decrease in ureter tone and compression of the gravid uterus. So all these factors contribute to urinary tract infections, particularly acute pyelonephritis. Okay, now acute pyelonephritis, if the cause is not addressed, it can lead to chronic pyelonephritis. So this is one of the complications. Chronic pyelonephritis can also lead to actually necrosis and abscess formation, which can lead to sepsis. So it can be very, very serious if not treated. You have to treat it with antibiotics. And chronic pyelonephritis is obviously recurrence, bouts of or recurrent episodes of acute pyelonephritis. Typically requires predisposition to infection, such as vesicoureteral reflux. So this is something which you, if somebody has it, then there is a persistent risk of all the time. So imagine the bladder here, the ureter here, and the kidney here. So vesicoureteral reflux, every time you try to urinate, some of the urine goes up in there, and this is then leading to persistent insult to the kidney. And because of persistent inflammation, there is scarring and fibrosis, particularly at the upper pole and the lower pole. So if in the examination they give you these upper and lower pole involvement, you have to think about fibrosis, probably because of vesicoureteric reflux. Okay, and the kidney itself, the tissue is damaged, the cells are damaged, and there is protein accumulation in there, so much so that the kidney starts resembling something like a thyroid, having proteinaceous thyroid follicle, and therefore this appearance, you see, these are the protein filled type of materials there, and this scenario is then known as thyroidization of kidney, pathognomic of chronic pyelonephritis. So I've tried to read each and every line, guys, so please pay attention to the video, okay? Every line is important. Let's now talk about what happens when we say there is acute kidney injury. Now let us start cracking the concepts associated with acute renal injury. So basically it is divided into three basic causes: pre-renal, renal, intrinsic renal, or post-renal. And the way to understand this is, now these are your kidneys, and to the kidneys blood is coming via the renal artery, obviously, and then ureters are taking urine out. So if number one, there is blockage or lowering of blood supply to the kidney because of any reason, such as hemorrhage, for example, or for any other reason there is hypovolemia. So if there is reduced blood supply to the kidney, then obviously kidneys will shut down, and this is called pre-renal cause, because problem is happening prior to kidney tissue. So kidney tissue is itself not primarily involved. There is no pathology in the kidney. Kidneys are working fine, but there is no blood supply. So before the kidneys, the blood supply is the problem. So that is called pre-renal azotemia. And number three would be if there is, say for example, obstruction at the level of the ureter or the urethra, or there is something wrong in the bladder. So there is an outflow obstruction of the urine, and because of the obstruction of the outflow, there will be backlog pressure and kidneys will be damaged. So here again, the problem does not primarily lie with the kidney. The problem actually lie outside the kidney after the urine processing has been done. So this is called post-renal problem. So post-renal azotemia. And then comes the intrinsic. So this is something where the renal tubular cells, the nephrons, they have some problem. If the problem lies within the kidney, this is what we call, this is the second cause, this is called the renal or the intrarenal intrinsic renal failure, right? And whenever there is kidney failure, obviously there will be increased nitrogenous waste in your body. Azotemia will be an important finding. So pre-renal, intrinsic renal, and post-renal. All right, let's talk about them one by one. If we dive into pre-renal azotemia, now the point is that this table looks very complicated at the outset, but you have to go through each and every thing written here in order to understand how this makes sense to you. Do not skip anything from first aid, because all of them are important concepts and you may be checked on any of these concepts in your examination. So let's start doing the etiology first. So pre-renal, obviously there is hypovolemia and there is decreased cardiac output, or effective circulating volume is decreased. So because of heart failure, for example, liver failure, anything which is causing reduced supply to the urine is the cause. However, if you look at the pathophysiology, now there will be reduced renal blood flow, because this is the primary cause, and because of the reduction in the blood flow, the GFR will reduce. Obviously there is loss of GFR, not because the nephrons are not working. Remember, this is very important to understand. Nephrons are fine. Nephrons and tubules are working perfectly, and therefore they have perfect concentrating ability, and therefore you see urine osmolarity of more than 500. So whenever we talk about urine osmolarity, basically we are checking if the nephrons are working fine or not. And if the urine is being concentrated enough, which means that solutes are more than 500 milliosmoles per kg, that means nephrons are working absolutely fine. Okay, and also the another parameter by which you check the nephron working is the FeNA, which is the fractional excretion of sodium. You should not be secreting a lot of sodium, so it should be less than 1% in a normal nephron. So that's very, very important for you to understand. Okay, so now you tell me, in pre-renal azotemia, is the problem with the nephron? No, it is not. It is problem with the blood supply. And what will happen to the GFR? It will reduce. What will happen to FeNA? It will be normal. This is normal FeNA, less than 1%. What will be urine osmolarity? It should be normal because nephrons are fine. And what is the urine sodium? It should be less than 20 milliequivalents per liter. So all these are indices that nephron is working fine or not. And these values show that nephron are working fine. And in principle, in pre-renal azotemia, nephron should be working fine. Unless, now listen, there's a twitch, and in examination they sometimes check you with some twists, and the twist could be that if the pre-renal cause sustains for such a long time that now there is acute tubular necrosis and there is tubular damage. Now if there is tubular damage, these indices will change. Nephron will lose its concentrating capacity. Nephron will start losing a lot of sodium, so this FeNA will go more than 2%. This urine sodium will be increased. Osmolarity will be decreased, so there will be changes in the nephron indices. But that only happens in very late, and if there is no treatment at all for pre-renal azotemia. Okay. And this is also important, the BUN creatinine ratio, and you must understand this because otherwise you will not understand this across different diseases. So in reality, what happens that you secrete creatinine into the filtrate and also the blood urea nitrogen. So both of them are secreted. Now creatinine goes out and BUN is reabsorbed into the blood, some of the BUN, and therefore usually normal BUN to creatinine ratio is slightly more than 15 to 20, and that's the normal limit. And this will change in subsequent pathologies. We'll talk about them. Okay, so I hope that this column, everything written here is clear. Why does pre-renal azotemia happens? Because of low blood supply to the kidney. What happens to GFR? It goes down. What happens to nephron function? Nothing. Okay. And what is the blood urea nitrogen creatinine ratio? It's normal. Now let's talk about post-renal. In fact, let's first talk about the renal causes. So intrinsic renal failure. Now when we say intrinsic renal failure, it means that tubules and the nephron, they are damaged. Now they can be damaged because of multiple things. So for example, it can be because of ischemia. So if there is prolonged pre-renal problem, there is prolonged pre-renal ischemia or prolonged heart failure or decreased volume, it will lead to ischemia of the nephron, and now nephron will be damaged, and this is called acute tubular necrosis. It can also be because of some toxins, and there can be so many toxins including drugs and whatnot. Okay, so acute interstitial nephritis can also cause damage to the nephron. So this happens in the interstitium and not in the nephron themselves primarily. So if there is acute glomerulonephritis, that can lead to intrinsic renal failure, like we discussed a lot of, rapidly proliferative glomerulonephritis, that can lead to renal failure. There can be vascular problems such as vasculitis, TTP-HUS syndromes, hypertensive emergencies. So all these are basically have one thing in common. And that one thing in common is that your nephron will be damaged. Okay, and if nephrons are damaged, what will happen? There will be effects in the GFR. It will be reduced. That will be the hallmark. Why? Because you have these nephrons, and then tubes will be damaged, and tubes will be clogging and damaging and obstructing and blocking the luminal flow, because there will be cast formation. And these casts, you remember, I told you these casts will be the casts that we discussed very early on, epithelial casts. So these casts will not have RBC, these casts will not have WBC, but they will be dirty looking brownish epithelial casts, because these are necrosed cells. Okay, so there will be tubular necrosis, and the debris will obstruct the tubule because cast will be formed and GFR will be reduced. And now you tell me, is nephron function normal? No, it's not normal. So what will happen to urine osmolarity? Less than 350. You start secreting a lot of sodium in the urine, and what happens to blood urea? This goes less than 15%. Why? Because now, listen to this very carefully. It's a difficult concept to understand for many students, but very easy if you listen to this. So normally what happens? You release blood urea nitrogen into the filtrate, and then it gets reabsorbed. But now the nephrons are damaged, so reabsorption does not happen. So if reabsorption does not happen, your blood urea nitrogen levels will go down, and when they go down, the ratio will go down. So because you are unable to reabsorb these compounds anymore, because the nephrons are not working, so you are not reabsorbing nitrogenous compounds, so your BUN levels go down, and when they do go down, the ratio goes down. Right? All clear? Now let's talk about the post-renal azotemia. It can be because of anything which obstruct the urinary outflow. So it can be stones here, it can be BPH at the level of the urethra, it can be cancers here obstructing. It can also be radiation therapy, for example, causing sclerosis. So anything which is obstructing the urinary outflow, and this can cause actually post-renal azotemia, because there will be back pressure, and because of back pressure the nephrons will be damaged. Now nephrons do not start getting damaged all of a sudden. So initially, for example, nephron function will be fine. So you may, at the very initial stages of obstruction, you may see this picture, but if there is prolonged obstruction, then now nephron starts getting damaged, and once the kidney function deteriorates, now you may start seeing this picture. So therefore it's written here, it varies, depends upon if it's initial phase of obstruction or the obstruction has been there for a long time. But believe me guys, that's a super important table for you to understand. Okay, now another very important pathology is the acute interstitial nephritis, also known as tubulointerstitial nephritis. There is an interstitial component, the mesangial component, and there is interstitial inflammation. Okay, it is associated with pus formation, pyuria, as well as azotemia, because kidney functions are affected. Can be caused by a range of things, but you must remember certain diuretics, NSAIDs, penicillin derivatives, proton pump inhibitors, rifampin, quinolones. Important list. I would suggest remember this. Okay. It can be also secondary to some systemic infections such as mycoplasma, lupus, sarcoidosis, also Sjogren's syndrome. They are less common, drugs are more common. And one key finding here is eosinophilia. I don't know where they have written here. Should be written somewhere. Let me check. It's associated with fever because it's inflammation, rash and pyuria, costovertebral angle tenderness, again because of inflammation. Remember the cause of inflammation to your drains, diuretics, rifampin, antibiotics. So all these are actually written here. If you can remember this, you don't have to remember the mnemonic. So mnemonics are sometimes very difficult to remember, because for mnemonics you need to remember the list of mnemonics, right? Anyways, so make your understanding clear. If your understanding is good, you'll perform good in the exam. Okay, Now, ATN, acute tubular necrosis, so which basically is the cause for intrinsic renal failure. Good news, it is reversible. It can be reversed if the primary cause is gone. Okay, so most common cause of intrinsic acute kidney injury, tubular necrosis, is spontaneously resolves in many cases. However, it can be fatal. Okay, increased fractional excretion of sodium. Obviously, kidneys are not working fine, so FeNA will be increased, right? Key findings: granular cast. We talked about this so much that epithelial cells will break off and they will make the cast. Okay, 3 stages. There is an inciting event, then there is a maintenance phase, and there is a recovery phase. Pretty simple, understand them, they're easy. So inciting event and then maintenance phase will be oliguric. The patient is not releasing urine, it lasts for a few weeks. There is risk of hyperkalemia because you are not secreting potassium out of your body. Metabolic acidosis because you are also not getting rid of acids out of your body, so that would be an increased anion gap metabolic acidosis. Obviously uremia because you are not secreting urea out of your body. Okay, but then there can be a recovery phase where you start releasing a lot of urine, and then risk of hypokalemia because you secrete a lot of potassium now. So all these phases should make sense. It can be caused by ischemic or nephrotoxic injury, toxicity because of a lot of chemicals, aminoglycosides and uric acid, such as in tumor lysis syndrome. Think about leukemia, cells blast and a lot of uric acid, and then this problem of ATN. Ethylene glycol is very important because many children drink it thinking it's a blueberry juice because it's blue in color and it's very sugary, it's sweet, so this has high potential of accidental intake. Cisplatin, lead, radio contrast dyes. Imagine contrast CTs and you may end up in this problem. So all this very important for examination purposes, easy to understand. Okay, now diffuse cortical necrosis. It's acute generalized cortical infarction of both the kidneys, likely due to combination of vasospasm or disseminated intravascular coagulation. Not very common, but for DIC patients, watch for this. Okay, and this will be a very critical patient. Actually, there will be septic shock and a very bad looking patient in the examination, and cortical hint. Think of these links. Okay, renal papillary necrosis. Papilla are actually very prone to necrosis if there is ischemia. So sloughing of nephrotic renal papilla after necrosis is very common, particularly in cases with if you're taking certain drugs. So for example, NSAIDs, in diabetes, if you have kidney infection, sickle cell disease. So again, a mnemonic here, SAT, PAPA. Anyways, so papillary necrosis. Okay, then consequences of renal failure. What happens if your kidneys are not working fine? Obviously, this should make sense to you. Now, decline in renal function can lead to excess retained nitrogenous waste. Understood? Electrolyte disturbances honge. Understood? Consequences can be metabolic acidosis because you are not secreting acids. Dyslipidemias because particularly you have high triglycerides. Okay, high potassium, you are not releasing potassium. Uremia, you are not releasing urea. Sodium water retention because you are not handling them properly. Growth retardation and developmental delays. Erythropoietin deficiency, it comes from kidney. Renal osteodystrophies, we'll discuss about this in a minute. Okay, 2 forms of renal failure can be acute renal failure or chronic renal failure, which is more common in hypertension, diabetes. Things happen with time. Acute is like you take some wrong thing, some drug, and it goes off, like pops off immediately. Incremental reduction in GFR define stages of the chronic disease. So normal phosphate levels are maintained during early stages of chronic kidney disease due to increased level of fibroblast growth factor 23, which promote renal excretion of phosphate. So in initial stages, phosphate levels are important, they are maintained. Uremia is a syndrome resulting from high serum urea. It can present with pericarditis, encephalopathy, anorexia, nausea. Some patients just do not realize they have uremia and their kidney functions are declining. They may present with these problems, and then it turns out that that was the initial problem. Now, what is renal osteodystrophy? Hypocalcemia, hyperphosphatemia, and failure of vitamin D dehydroxylation, because kidneys are not working, right? So kidney are required for 1 hydroxylation of vitamin D. Kidney are very important for calcium phosphate metabolism. You know this. So if all this is screwed up, then there are problems with your tissue deposits of calcium, and then your bones can go screwed, subperiosteal thinning of bones, and that's primarily because of the kidney problem. Okay, so they are associated with chronic kidney disease. It causes secondary hyperparathyroidism and then tertiary hyperparathyroidism. We'll discuss this more in the endocrine section. Now let's talk about a very important section, which is the renal cystic disorders. So there are certain cystic disorders which you should be aware of. So for example, the autosomal dominant polycystic kidney disease, that's an inherited version, and then there is an autosomal recessive. Now numerous cysts in cortex and medulla, and you can see in the image here, causing bilateral enlarged kidneys, ultimately destroy the kidney parenchyma, presents with combination of flank pain, hematuria, hypertension, kidneys are not working, urinary infection because of obstruction perhaps, progressive renal failure in more than 50% of individuals. So if you have this, kidney failure is almost certain. Mutations in the gene encoding polycystin protein PKD1 in most of the cases located on chromosome 16, and in some cases PKD2 on chromosome 4 is affected. Important for examination. Complications include chronic kidney disease, obviously hypertension, just told you about this, and treatment if hypertension or proteinuria develops, treat with ACE inhibitors. Obviously genetic disorder, what else you can do. There is autosomal recessive polykidney disease, and these patients present earlier because there is a recessive problem, so the disease will manifest itself very early. And there is PKHD1 encoding fibrocystin gene mutation. Cystic dilation of the collecting ducts, often present in infancy because it's a recessive problem. Anything which is autosomal recessive presents early in life. Okay, concerns beyond neonatal period include systemic hypertension, progressive renal insufficiency, and also congenital hepatic fibrosis. These are important associations to remember. Then there is autosomal dominant tubulointerstitial disease. This is not tubulointerstitial, as the name indicates. There will be a component of interstitial involvement, also called the medullary cystic kidney disease. So this is also a cystic kidney disease, but this is not inherited. This is it is inherited, but in an autosomal dominant fashion, not recessive. It causes tubulointerstitial fibrosis and progressive renal insufficiency with inability to concentrate the urine. Medullary cysts are not visualized, smaller cysts, usually not commonly tested in examination. Now, simple versus complex renal cysts. Simple cysts are filled with ultrafiltrate, which you see on ultrasound, very common and account for majority of all renal masses, found incidentally and typically asymptomatic. However, if there is a complex cyst, it includes those that are septated, enhanced, they have solid components, so that is something which may lead to cancer formation as well. So you always have to pay attention to complex cysts if you see them in examination, right? Now, renovascular disease. Okay, so you know that kidney is a primary organ controlling the blood pressure, and you are very well aware of that whenever there is ischemia sensed by the kidney, there is renin release, and then renin causes all the sequence of events, angiotensin to angiotensin 1 to 2, and then it performs its function, try to bring back sodium and water to the body so that blood pressure is actually maintained. So the renovascular disease can be unilateral or bilateral renal artery stenosis. So whenever there is renal artery stenosis, means low blood going to the kidney, there will be low renal perfusion. So kidney will sense there is low blood pressure or low volume. More renin will be secreted, more angiotensin, and hypertension will pursue. Okay, that's very, very important sequence of events. Now, main causes of renal artery stenosis can be atherosclerosis, can block the renal artery, and fibromuscular dysplasias. Remember this, okay? So they are very, very common. And for unilateral renal artery stenosis, affected kidneys can atrophy, it can be asymmetric on size on one side, on the other side there will be a change in the size. For bilateral renal artery stenosis, patients can have a sudden rise in creatinine after starting ACE inhibitor, ARBs, or renin inhibitor due to their interference on RAS-mediated renal perfusion. So we'll talk about them in pharma section. Patient with renal artery stenosis may have stenosis in other large vessels as well, and that makes sense because if you think that atheromatous plaques are being deposited here, they may be deposited somewhere else. So think about always other problems, right? Okay, with this, let us start talking about renal malignancies. So the first renal malignancy that we have to talk about is the renal cell carcinoma. It's actually pretty common renal malignancy, and obviously, consider it that kidney, like other organs, is made up of some units, and those units are known as nephron. And you know that nephrons are lined with epithelial cells. So because there are epithelial cells present, they are prone to develop to cancers. So basically the renal cell carcinoma originates from the cells of epithelial lining of proximal convoluted tubule. So this is where usually it arises from, okay? And because these are cancers and there is a nearby vessel available, which is the renal vein, so renal cell carcinomas, they tend to invade in the very initial phases, they invade to the renal vein. So that's not uncommon for renal cell cancers to invade the renal vein, and this happens more so on the left side, because if you know the structure on the left side, if this is the left side, if the person is standing in a way that the back is towards you, this becomes the left side. So the spermatic vein is basically draining in here into the renal vein, while on the right side that the spermatic vein directly drains into the bigger vessel. So on the right side, even if there is a cancer, there are less chances of spermatic vein being involved, and on the left side particularly there is development of varicocele. Okay, so the involvement of renal vein is a routine phenomena. It's a very, very characteristic feature of renal cell carcinoma. While it affects renal veins on both the sides, left becomes very important because of its connection with the varicocele on the left side in males. So that's an important clinical connection that you must remember. Okay, so it originates from the proximal convoluted tubule, invades the renal vein, and it leads to development of varicocele on the left side. And obviously from the renal vein it can invade into the inferior vena cava, and hematogenously it spreads to the body, particularly to the lungs, bone and liver. So that's the metastasis of renal cell cancers. Histologically, if you talk about these cancers, they are polygonal cells which are largely clear and filled and accumulated with lipid and carbohydrate. Because of the presence of these lipid droplets, these tumors morphologically appear golden yellow. Okay, so because there is increased lipid content. So if you look at the diagram here, so you cut open the tumor and you see all this yellowish area. This is all because of lipid heavy architecture. And if you look at the histology here, you see all these clear cells. You see the cells are clear again because of the high lipid content. So what happens when you are preparing the slides and you treat the tissue with alcohol of different grades during histopathology, the fat is dissolved and what you get is a clear empty cell. So that's pathognomic of a lot of different things, one of them being renal cell carcinoma. Now these patients present to the clinic usually because they have a mass in the flank region, the kidney area. So they manifest in the clinics with flank pain, sometimes palpable mass, and hematuria. So that's a classical triad: a patient coming to you with flank pain, palpable mass in the kidney area, and hematuria. Usually this is painless hematuria. And then there will be associated signs and symptoms, such as because of hematuria the person may have got anemia or even secondary polycythemia. Now, wow, you must be thinking, why there is secondary polycythemia? The reason for this is that kidney tumors are notorious for secreting a lot of other things, and therefore the paraneoplastic syndromes are very, very common. So for example, kidney tumor can release erythropoietin, and if there is more erythropoietin, now you can link this erythropoietin release with polycythemia, because this will lead to increased hematopoiesis, and because of increased erythropoiesis, there will be more RBC. So kidney tumors, remember, are notorious for secreting a lot of different functionally active chemicals, including erythropoietin, leading to polycythemia. These tumors may also release ACTH, for example. So the patient in your exam may appear as a patient of Cushing syndrome, and at the end of the day you may diagnose this as renal cell carcinoma. These patients from their renal cancers can also release renin, and because of the renin, the whole renin-angiotensin-aldosterone system is activated, more sodium and water retention, increase in the blood pressure. So these patients can present to the clinic in multiple ways. So you have to remember all the paraneoplastic syndromes associated, parathyroid related proteins, so hypercalcemia. So the patient in the exam can be a patient presenting with hypercalcemia, hypertension, increased red cell mass, any of these things. Okay, and they may be trying to check your capability of linking all the story to renal cell cancers, right? And like other cancers, these patients may have cachexia, which is weight loss, and fever. Okay. How you treat the patient is usually by surgery of the localized disease. There are some immunotherapeutic drugs available, such as ipilimumab, MAB, and this is a monoclonal antibody. Anything MAB is a monoclonal antibody. That's an immunotherapy, or targeted therapy for metastatic disease. So if it is already metastasis, there are less chances to cure the disease. Okay, the patients may develop resistance not only to radiotherapy but also to chemotherapy. So clear cells, most common subtype, like I just told you, they are clear. They are associated with, this is an important discussion coming up. There is a tumor suppressor gene which is known as VHL, and this VHL is mutated. It has a loss of function associated with the pathogenesis of renal cell carcinoma. Okay, so remember the name of this gene. Now these tumors can be sporadic or they can be inherited. So sporadic renal cell carcinoma means that there is no family history, there is no inheritance, and the person develops the tumor on his or her own. And the biggest risk factor for this is smoking. All right, and the cases which are inherited, they have inherited gene defect in VHL gene, and they usually represent as part of a bigger problem, which is the von Hippel-Lindau syndrome. Okay, and that's a good mnemonic. I like this. This gene is present on chromosome number 3. There are 3 letters in VHL, there are 3 letters in renal cell carcinoma, and there is chromosome number 3. Some of the mnemonics in first aid are really good. Okay. All right. Having said this, one thing, I'm trying that I don't leave any line, any word from first aid untouched. So most common renal malignancy, primary renal malignancy, renal cell carcinoma is the most common one. It's the most common in this age group, 50 to 70. Age groups in examination vignettes are very important, because if they're talking about a pediatric age group and a flank pain or mass, then we are talking about perhaps Wilms tumor, not about renal cell carcinoma, because this is common in this age bracket, 50 to 70 years. Okay, so I think I've covered everything you need to know for renal cell carcinoma mentioned in first aid. And other tumor type is known as renal oncocytoma. That's a benign epithelial cell tumor originating from the collecting duct. So it's not from the PCT, it's from the collecting duct. Okay, because they are benign, they are well circumcised. You can see almost kind of a tumor capsule there. Large eosinophilic cells with abundant mitochondria are characteristic on histopathology. Okay, this can easily be distinguished from renal cell carcinoma because you don't see clear cells quite much here, right? Also presents with painless hematuria, flank pain, and abdominal mass. So the triad may mimic renal cell carcinoma, but then you may be able to identify this on the basis of either the gross morphology, which is well circumcised, as opposed to, you know, this yellow golden appearing lipid laden renal cell carcinoma. And also on the histology, you may be able to clearly differentiate this from this diagram. Okay, so often resected to exclude the malignancy. So even if you find this, even incidentally, or if you do surgery, you remove it, always send it for biopsy, because there are chances that the renal oncocytoma have foci of renal cell carcinoma developing. So you always need to rule out the malignancy, and this is we do for any surgical procedure. Even if I'm removing appendix, it is routinely sent for histopathology to rule out any malignancy. Okay, the other renal tumor that we have to talk about is nephroblastoma, which is also known as Wilms tumor, and it is the most common renal malignancy of early childhood. So this age bracket, age 2 to 4 years, always think about nephroblastoma. Now, Wilms tumor contains structures which were present in the embryonic time period. So it contains embryonic glomerular structures, premature structures, which are also called blastema. So blastema associated tissues are found in Wilms tumor. It most often present with large palpable unilateral flank mass and or hematuria and possible hypertension. So again, all kidney tumors you see are representing to the clinic with abdominal mass and painless hematuria, blood in the urine. Now this tumor is known to be associated with functional mutation, loss of function mutations in a couple of tumor suppressor genes. So WT1 and WT2, for example. Okay, Wilms tumor, Wilms looks like 11, I and L, and this is on chromosome number 11. So this is actually good to remember. These are good mnemonics. VHL was on chromosome number 3, and for Wilms tumor it is on chromosome number 11. Now Wilms tumor also at many times this is usual part and parcel of some other syndrome. So for example, there is a Vagar syndrome. In Vagar, W is for Wilms tumor, so A is for aniridia, loss or absence of iris in the eye. G is for genitourinary malformation, and R is the range of developmental delay. So they are all associated with WT1 deletion, complete deletion, and here the Wilms tumor is part of a bigger problem, which is the Vagar syndrome. Then there is another syndrome known as Dennis-Drash syndrome. This also incorporates Wilms tumor along with diffuse mesangial sclerosis and dysgenesis of gonad. You see, and this is also associated with WT1 mutation. Then there is Beckwith-Wiedemann syndrome. Will syndrome is one of the presentation. There is also macroglossia or gomegany, and this is more associated with WT2 mutation. So there are some disease complexes that you have to remember with Wilms tumor. So these babies who come to you with the Wilms tumor problem may also have other things if they have Vagar complex or Dennis-Drash syndrome or Beckwith-Wiedemann syndrome. So always consider evaluating the baby in with the context that they may have also other problems. Okay. Then kidney is one big organ in the excretory system, and therefore the tumors arising from kidney are the renal cell carcinoma and oncocytoma and nephroblastoma. And now we talk about something originating from the urinary bladder. So urinary bladder has the transitional epithelium, and therefore it is also called transitional cell carcinoma. So cancer can develop in urinary bladder. Most common tumor of the urinary tract system can occur in renal calyces, pelvis, ureters, as well as bladder, although it is routinely found in bladder but can be present in these places. Okay. And again, painless hematuria is one of the clinical finding that is very common in urothelial cancers as well. So either you call it urothelial cancer or transitional cell carcinoma, it's the same thing. Okay. Now it is associated with smoking. Tobacco smoking is one of the key factor, and there are some other compounds which are found, for example, in painting dyes, aromatic amines, as well as cyclophosphamide. So these are very important risk factors which can persistent exposure to these can lead to urothelial cancer. So be aware of this. Okay. And lastly, squamous cell carcinoma of the bladder. This carcinoma of the bladder is not a squamous cell carcinoma. This is transitional cell carcinoma. Okay. Now, sometimes there is a chronic irritation of the urinary bladder that can be because of so many things. So, for example, there is a parasitic infection, schistosoma hematobium, which is very common in Middle East, by the way. If there is chronic cystitis because of any inflammatory cause, smoking, nephrolithiasis, so stones are irritating here. So all these persistent irritation, what they do is they transform the transitional epithelium to squamous epithelium, and this is what we call metaplasia, conversion of one epithelial type to another epithelial type. And once this happens, now we have a squamous epithelium, and persistent irritation can lead to dysplasia and then squamous cell carcinoma. So this is a very common sequence in a lot of places in the body. So a normal epithelium, if persistently irritated, can undergo metaplastic changes, then dysplastic changes, and then they can undergo carcinoma changes. Okay, so normal to metaplasia to dysplasia to carcinoma, all because of persistent irritation, like in this case. Okay, so that concludes our discussion on the pathology associated with renal module. Now we will talk about the pharmacology of renal system. The drugs that are primarily important for your board purposes, which work on the renal system, are the diuretics. And this initial nice diagram in the first aid is a very nice diagram to actually tell you what are the sites of action for different diuretics. So if you look at the structure of the nephron here, we have the Bowman capsule, in which is the glomerulus. Here is the afferent arteriole, here is the efferent arteriole, and the Bowman space leads to the proximal convoluted tubule, and the proximal convoluted tubule then leads to the descending limb of loop of Henle, and then the ascending limb of loop of Henle to the distal convoluted tubule to the collecting duct. So you are already aware of this representation of a nephron structure. And now this diagram simultaneously also tells you what are the areas of the nephron which are involved in secretion and absorption of different types of ions. So for example, proximal convoluted tubule is the point where you are absorbing almost all of the sugar, amino acids, and most of the sodium as well. This segment also absorbs bicarbonate in the body. So from the urine, all these metabolites are reabsorbed back into the blood. Similarly, if we talk about the descending limb of loop of Henle, this is the area from which huge amounts of water are absorbed into the interstitium. So this area is therefore also called the concentrating segment for the urine. And then the ascending loop of Henle is known for absorption of sodium potassium 2-chloride via the special channel called the sodium potassium 2-chloride channel. And then up in the ascending loop and then the distal convoluted tubule, we start reabsorbing calcium along with sodium chloride and magnesium, and collecting duct is the area where we secrete potassium and hydrogen, largely in replacement with the sodium which enters into the body. So what I'm trying to tell you that in order to understand the pharmacology of renal system, you must understand the normal physiology. Therefore, if you refer back to the earlier segments of my video where we have in detail talked about nephron transport physiology, you must first master that all those concepts, because if you do not understand that where are we absorbing bicarbonate, you will not understand where are carbonic anhydrase inhibitors working. So acetazolamide, for example, is a carbonic anhydrase inhibitor, and it works in this area, proximal convoluted tubule, because this is the area where carbonic anhydrase basically works and bicarbonate is reabsorbed. So if you know that this area is the area where carbonic anhydrase work, so you would also know that this is the area where a carbonic anhydrase inhibitor will work. Okay, so understanding the physiology is a must to understand pharmacology for any system, and renal system is the same. So first of all, this diagram, master the nephron transport physiology, and then we will pick up one by one all these 5 classes of diuretics. Diuretics basically are the drugs which increase the urine output. So they usually do it by increasing the secretion of sodium, and along with sodium, water also comes in. So this is the way of diuresis which is performed by most of these diuretics. We'll talk about them in a minute one by one. But this diagram, actually I'll come back to this diagram one more time in the end so that you know clearly that what does this color coding means. So for example, acetazolamide, pink color, works in the PCT. If you talk about mannitol works in all that area where you osmotically drive water. So for example, this is the area where water comes out because of osmotic changes, and in the medulla, this is the medulla where the loop of Henle is present. In the medulla there is very high concentration because of urea, because of sodium, because of other solutes. So this is a very hyperosmolar area, and because of this high osmolarity, water comes out of the nephron. But if you increase the osmolarity within the tubule, within the nephron, and this you can do by administering mannitol, for example. So mannitol stays in here, increases the osmolarity. Now the water does not come out, and if water does not come out, it goes out in the urine, hence diuresis. So mannitol works in this area where water reabsorption is happening because of osmolar effects. Then we have loop diuretics working in that particular area, then thiazide diuretics, and so we'll talk about all of them. But this is a very nice diagram telling you what's happening in each and every segment of the nephron and what are the areas where each drug work. All understanding is basically linked to your understanding of the nephron transport physiology. Okay, this table you can only comprehend once you have understood all the diuretics. So let us start diuretic discussion first. So mannitol, for example. Now mannitol causes so this is something which if injected into the body, it stays into the vascular system and increases the osmolarity of the vascular system. So it basically turns the vascular compartment into a high osmolarity compartment. And once the vascular compartment, the blood vessels become a high osmolarity compartment, what happens that from the tissues, water is drawn into the circulation. So basically this is the use of mannitol. It is used in all those conditions where you want to draw water
out of the tissues. So for example, if somebody has pulmonary edema, so for example, if somebody is dehydrated, so you give mannitol and the water comes from the interstitial spaces, from the cells into the circulation. It is I don't think it is routinely used as a diuretic because there are stronger diuretics available. But anyways, what would be the diuretic effect of mannitol? The diuretic effect I just explained here. Because mannitol stays in the, because it is filtered here and then it stays in the nephron. So once it's stayed here, the nephron becomes hyperosmotic loop. And when it becomes a hyperosmotic tube, what happens that water does not come out. And if it does not come out into the interstitium, it goes out in the urine. So that's the diuretic effect. So it causes osmotic diuresis. It increases also serum osmolarity, which shift fluid from the interstitium to the intravascular space. And therefore, it helps in any condition where you would like to get water out of the cells, such as pulmonary edema, such as high intraocular pressure, such as high intracranial pressure. You would like to decrease those pressures by using mannitol, and that is the osmotic shift of water. Okay. Now clinically, I told you it is used in pulmonary edema, high intraocular pressure and high intracranial pressure. And for this reason, you should also appreciate that you cannot use mannitol in conditions like heart failure. And imagine why, because in heart failure, your heart is failing. And by putting mannitol in the body, what you are doing is drawing extra amount of liquid into the vascular system. So you cannot increase the preload of the heart and expect the heart to be working fine, particularly if it is a heart failure condition. So heart needs to be relaxed. And if you use mannitol, you increase the blood volume. And once the volume is increased, the preload of the heart increases. So it is contraindicated in heart failure. Similarly, it is also contraindicated in kidney failure. So you don't use it in anuria. You don't want your kidneys to be damaged further by using this osmotically active particle. So that's about mannitol. Okay, and mannitol obviously can work only in that area where water is used to be reabsorbed, and particularly this segment, because this is the segment where water drives its movement only purely because of the concentration gradient across the medulla. This segment, water is being absorbed along with sodium, so that's a different story. But this segment is impermeable to iron, so the water is dragging out only because of the high osmolarity in the medulla. And now because of the mannitol, you also create high osmolarity in the loop of Henle, the descending limb, and there is no water movement out of the nephron, and it's secreted more in the urine. So that's about mannitol. The next diuretic, which also is a weak diuretic, and it is not primarily used as a diuretic because we have stronger diuretics available, is known as carbonic anhydrase inhibitor. That is a typical example for this is acetazolamide. What it does, it inhibits carbonic anhydrase. That's an enzyme which is required in the proximal convoluted tubular cell so that you can reabsorb bicarbonate. So if you inhibit this enzyme, you cannot reabsorb bicarbonate. So if you cannot reabsorb bicarbonate, you will lose bicarbonate out in the urine along with sodium and water, basically, because bicarbonate entry is very much dependent on the sodium shifts. Please refer back to my nephron transport physiology bit earlier in this video. So we inhibit carbonic anhydrase, and it causes self-limited sodium bicarb diuresis. Sodium and bicarbonate gets out in the urine, and therefore, because we are losing bicarbonate, the body bicarbonate stores go down, and therefore the urine becomes alkalinized because that's an alkali. Bicarb is an alkali. So if you are losing bicarbonate in the urine, your urine is alkalinizing. Okay, when do we use it? We try to use this when we need to settle intraocular pressures, when there is metabolic alkalosis, because in metabolic alkalosis you want to get rid of alkali, and that's a perfect example. Altitude sickness, and this is something very interesting because when you go high up in altitude, there are reduced partial pressures of oxygen and the persons hyperventilate. So when the persons hyperventilate, they release excessive amount of carbon dioxide, and when they release excess amount of carbon dioxide, they get more alkali in the blood. Now you want to get alkali out of the body, and you can do it by using acetazolamide. Okay, and this accumulated alkali is basically responsible for the symptoms associated with high altitude. So altitude sickness has a link. You should actually understand how the drugs are working, because if you do not understand the basic concepts, then just remembering and ratifying it will not help.
Okay, it is also used in reducing the intracranial pressure. So anything where you can get rid of more and more water out will help in raised intracranial pressure. What could be the side effects? So basically the side effects, it's a sulfur based compound, so sulfur allergy, those persons who are allergic already known are prone to get this. Hypokalemia, because by virtue of losing a lot of sodium, you are actually not reabsorbing potassium. Again, refer back to my transport physiology lecture. So persons develop hypokalemia. Also, these drugs are associated with increased risk of formation of calcium phosphate stones. Now that's a very important point, because what happens is that use of these drugs basically decreases the citrate excretion. Now citrate basically reduces stone formation, so if citrate excretion itself is decreased, there are more chances of getting calcium phosphate stones. Okay, it's also an important cause of type 2 RTA, because if you refer back to my video lecture earlier, this video actually, in where I have in detail described the pathogenesis of type 2 renal tubular acidosis, it's all associated with bicarbonate in the proximal convoluted tubule. Alright, so that's all about the carbonic anhydrase inhibitor. You should know where does it work, what are the different metabolic consequences of using acetazolamide. Let us now extend our discussion to another group of diuretics, the loop diuretics. Now remember, for board purposes, that loop diuretics are one of the strongest diuretics that we have. In fact, across all the 5 diuretic classes that we are discussing now, they are considered as the most potent one, and therefore they are used in critical situations like when you have to decrease the circulatory volume, heart failure and stuff like this. Okay, so examples include furosemide, bumetanide and torsemide. Lasix is the one which we routinely use in the clinics, and you must be aware of this. Okay, how does it basically work is that there in the in this segment of your nephron, you have a very important pump in the ascending limb of loop of Henle, and this is called the sodium potassium 2-chloride pump. So what this pump does is it reabsorbs all these things. So simple to understand, if you inhibit this pump, what will happen, that you are basically reducing the reabsorption of these ions. So it's effectively very easy to understand that if you block the reabsorption of these ions, then these ions are not reabsorbed into the body. So where are they going? They are getting out in the urine. And you know, this is the mechanism for diuresis, that you start losing a lot of sodium, and along with sodium, water gets out of the body as well. But you are also losing chloride and potassium here, and therefore the side effects you can imagine would be low potassium levels and low chloride levels in the body. But also important here to recall from the physiology bit of this video that this particular channel is not only doing this job of reabsorbing sodium, potassium and chloride, but it is also helping in calcium absorption. Because if you remember the cell that we discussed in this region, there was a pump, sodium potassium 2-chloride. So because this pump was reabsorbing a lot of potassium, the potassium coming out was actually creating a positive charge effect here at the membrane, and then it was kicking off calcium to go through the paracellular routes. So that was one thing that we discussed in detail. Okay, so effectively what you have to remember, that calcium reabsorption will also be disturbed, right? So that is the effect. What pump is being affected is the important thing to remember. Then another important point about this pump is, by reabsorbing sodium, potassium and chloride, it was actually contributing to the tonicity of the medulla. So effectively what will happen, that the tonicity of the medulla will also be lost. And if the tonicity of the medulla is lost, what will happen, that in this segment you will not be able to reabsorb water. So this concentrating segment of the nephron gets water out into the interstitium only because of the high tonicity here. So if this tonicity is lost, you do not get water out into the medullary interstitium, and this water is also excreted, hence another diuretic effect. So basically this loop diuretics, they are very strong because they are deploying diuresis by 2 main mechanisms. The first mechanism is that they are releasing these ions into the urine, and because of the sodium excretion, water is getting out from the nephron as well. So that's one mechanism. The other one is, because this pump is blocked, there is no tonicity in the medulla, and the water is not getting out of the nephron in the descending limb of loop of Henle. Hence you lose more water and the urine is not concentrated, and because you are losing more water, this is another diuretic effect. Okay, so it abolish hypertonicity in the medulla, and therefore concentration of urine in this segment is prevented. You should understand what is written here, right? Now, increased calcium excretion, you should understand this point, because we talked about the positive potential and kicking off calcium by the paracellular route. So once the pump is blocked, there is no potential generation and there is no calcium reabsorption. So please refer to my Nephron transport physiology section for in detail understanding of how this is working. Okay, clinically it is used in any condition where you want to get rid of volume, so administrative states such as heart failure, cirrhosis, nephrotic syndromes, pulmonary edema, hypertension, and sometimes also in hypercalcemia, because this leads to loss of calcium in the urine. The adverse effects are easily understandable. They are sulfonamide containing drugs, so sulfa allergies are possible. It can also lead to hypomagnesemia and hypocalcemia, hypokalemia. This should be understandable very easily. Dehydration, because you get rid of a lot of water content, can also damage your hearing capacity. So ototoxicity, although rare, but this is reported. Okay, now gout, because both loop diuretics as well as thiazide diuretics, they kind of increase the uric acid absorption. So once that absorption is increased, you will get increased uric acid levels that can lead to gout. Okay, it can also cause nephritis, particularly interstitial nephritis in the kidney, and it can also be an important cause of metabolic alkalosis. Now this is an important point, because you must understand the concept of metabolic alkalosis, otherwise you will be in trouble, because loop diuretics can cause metabolic alkalosis. Also, thiazide diuretics can do this, and the way to understand this would be that because you are losing a lot of urine, because you are using diuretics, your kidney will be hypovolemic. So they think that they have reduced volume, which is true, because you are losing a lot of volume in the urine. And as a result of this, what happens that your Renin-angiotensin-aldosterone system is activated. So kidneys start releasing renin, and then the system is activated. And you know that because of activation of this system, you kind of try to reabsorb sodium and water, and you try to lose potassium and hydrogen. So once you lose hydrogen, you basically are getting into alkalosis. So I told you each and every word written here is super important and you should pay attention to. So if first aid is mentioning metabolic acidosis as a side effect of loop diuretic, do not move to the next word unless you first address this. It's very, very important. Okay, right. Now, this drug, ethacranic acid, is important because particularly in those patients who are known for sulfa allergies, this drug also blocks the same channel, but it does not contain sulfonamide. So there are no sulfa allergy issues, okay? And they are also affected, they also affect the hearing, in fact, more than what is done by the loop diuretics. So that's a side effect thing that you have to remember. They are also ototoxic more in comparison to the routine loop diuretics. Okay, so in order for you to remember, loop earrings hurt your ear as well. It's a very difficult way to remember this. I would just recommend remember that they are ototoxic. Right, let's now start discussion about the thiazide diuretics. So thiazide diuretics basically work by blocking sodium and chloride absorption in the distal convoluted tubule. So if you recall the cell from the distal convoluted tubule, on the urine side there was a transporter which co-transported sodium and chloride. So you are basically blocking this channel, and once this channel is blocked, sodium gets out in the urine, and along with sodium more and more water gets out as well. And recall that in this cell there was always on the basolateral side sodium potassium ADPase, and there was also another antiporter which used to get sodium in and calcium out. So now see the consequences. If you block this sodium chloride channel, sodium is obviously getting out in the urine, hence diuresis. But what will also happen, that sodium entry into the cell is now not working, but this pump is working, and this pump is pushing sodium out continuously. This will lead to very reduced concentration of sodium within the cell. So sodium gets into the cell from the blood and calcium gets into the blood. My point is that with thiazide diuretics, you increase calcium reabsorption. or the other way to say this would be you decrease calcium excretion. This is in contrast to loop diuretics, and this is an important point for your exams, that if you use thiazide diuretics, you absorb more calcium in the blood, and therefore its clinical uses, you see, now this should make sense. If you have osteoporosis, so you use thiazide diuretics because it increases the concentration of calcium in the blood. If you have hypercalciuria, so you have more calcium in the urine, you would like that calcium to be reabsorbed, and hence you use thiazide diuretics. So these things should make sense to you. Okay, right. So we talked about thiazide diuretics. How do they work? They causes decreased calcium excretion but more calcium reabsorption, and their clinical uses include hypertension, heart failure, hypercalciuria, we talked about it, diabetes insipidus. Because now one more important thing, while the sodium entry into the distal convoluted cells is disturbed, by no way the tonicity of the medulla is disturbed. Now this is again in contrast to the loop diuretics. If you recall my discussion from loop diuretic, the tonicity was disturbed because you were blocking a very important channel which contributed to the tonicity of the medulla. Now tonicity is important because if you disturb the tonicity, water movement out of the nephron will be disturbed. Now here tonicity is not disturbed, so water keeps on being reabsorbed at a normal pace. That's an important point to be understood with thiazide diuretics. Okay, so water keeps on being reabsorbed here, and also water keeps on being reabsorbed in this part of the nephron. Now this brings me to the next very important point, because in these patients the tonicity of the medulla is not disturbed and the water reabsorbing capacity is not disturbed. So if such patients who are using thiazide diuretics, they keep on drinking huge amounts of water, so that water is going to be reabsorbed, and you have blocked sodium reabsorption. So if you increase water reabsorption into the body, what will happen to the tonicity? You know, you will lead the patient to develop hyponatremia because you are absorbing more water but no sodium or less sodium. So that's why these patients, one of the side effect is hyponatremia. You see, each and every word should make sense to you, and therefore it is also used in patients with nephrogenic diabetes insipidus, because if you recall the pathogenesis of nephrogenic diabetes insipidus, then you will make sense and appreciate that why thiazide diuretics are used, because they keep on getting the water reabsorbed from the nephron. So hyponatremia should make sense to you. We discussed earlier that loop diuretics as well as thiazide diuretics, both of them cause hypokalemia, as well as because I told you the renin-angiotensin-aldosterone system is activated. Okay, and they also cause metabolic alkalosis because you start excreting hydrogen, right? Now these drugs are also known to increase blood glucose levels and blood lipid levels, also uric acid levels. Therefore they can also cause gout, just like loop diuretics. They can cause hypercalcemia because using these type of diuretics we are absorbing more calcium, and because they contain sulfonamide group, they can also cause sulfa allergy. So do not leave any word ununderstood. You have to understand each and every word written here, otherwise it will not make sense to you. You cannot memorize first aid, you can only read it by understanding. Okay, and then the typical drugs that you should remember for thiazide diuretics are hydrochlorothiazide, chlorothalidone, metolazone. Right, let us now start discussing the next group, which is actually the last group of diuretics. It's the potassium sparing diuretic. Now the reason they are called potassium sparing diuretics, because they if you remember, I told you in loop diuretics as well in thiazide diuretics, they reduce the potassium concentration in the blood, so they were hypokalemic in their effects. Now this particular diuretic group is actually reducing the excretion of potassium from the nephron. So if you consider this into consideration, then you will understand that it is not affecting potassium levels, rather it is actually blocking potassium excretion. So one of the side effect actually is hyperkalemia. So because it is sparing potassium excretion, it is called potassium sparing diuretic. So it's still a diuretic because it is blocking sodium entry into the cells in the collecting duct, and the way they do it is by inhibiting the aldosterone effects. So the group contains a lot of different compounds as an example, spironolactone, eplerenone, they are competitive aldosterone receptor antagonists. So go back to my physiology bit and you will understand that in the collecting duct we have principal cells and intercalated cells, and then aldosterone is important here. So aldosterone, for example, enhances sodium entry into the body by various mechanisms that we have already discussed. But in principle, you should understand that these type of diuretics are actually blocking the effects of aldosterone. So what essentially will happen, that the sodium entry will be disturbed and potassium excretion will be disturbed. So we are blocking potassium excretion at the same time when we are also blocking sodium reabsorption. So sodium gets out in the urine, hence diuresis, but potassium is retained in the body, hence hyperkalemia. Okay, so that's a simple thing to understand, and clinically we can use this like we use other diuretics in heart failure, in nephrogenic diabetes insipidus, and also if you want to insert anti-androgen effects. In fact, the anti-androgen effect is very important to remember also with reference to the side effect that is caused by these diuretics, because spironolactone particularly blocks the testosterone effects and hence leading to gynecomastia and anti-androgenic effects in males. So the take-home message for this type of diuretic is that it spares potassium. So if the patient is prone to develop hypokalemia, think of using this class of diuretic, and in fact it is used with other diuretics to so that the potassium levels are not very much disturbed, right? So that concludes our discussion on diuretics, and the last page on renal module, it has been a very long video, but the last page is basically about angiotensin converting enzyme inhibitors and ARBs, and so we'll discuss these perhaps with the cardiac module because they're more kind of associated with blood pressure regulation and hypertension treatment. So stay tuned for this particular bit. We'll get back to this, and that is all about the renal module. It's been more than 5 hours of a video that I've made for you, and I hope you like the video. And similarly, imagine I'm going to read the first aid for you for all the modules. So we have just begun with the renal module. We will next start another module, a very long video covering all aspects of one particular module. So I started this initiative because I truly believe that first aid reading is sometimes problematic for students, particularly because they cannot memorize each and every fact written in there. It's a fantastic resource for USMLE STEP1. In fact, it is one of the only highly recommended resource for USMLE Step 1, and if you don't understand this, you will be in big trouble. So this is my effort to make you understand first aid. I hope you enjoyed the video. If you did, only one favor that I ask my students to do is subscribe the channel, share the video so that many students are benefited. I want as many students possible to go through these videos so that their life and journey for USMLE different steps is made very easy. So all the very best, guys, and keep sending me your love, wishes and appreciation, and I love you all. So I'll see you very soon in another video. Take care of yourself.